Alexa, Alexa, Alexa,
So, good morning and a warm welcome to
Alexa,
all the dignitaries present here.
Alexa, the world.
Okay, so good morning and a warm welcome to all the dignitaries present here. Please kindly stay in mute, everyone. So, good morning and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by Indian Association of Reproductive and Child Health of India. And the topic of today's session is Gurukul classes day 3. So now I would like to inaugurate this session with Ganesh Vandana.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
So thank you so much for your patience listening. So let's begin today's session, for which I would like to hand over the session to Dr. Mala Srivastava, ma'am. Over to you, ma'am. Please proceed with your talk.
Please show the CV text, Ruksha.
Sure, ma'am. Just allow me a moment.
Good morning, everyone. It's my pleasure and privilege to initiate the third day of Gurukul classes. I'm sure our postgraduate students who have been attending the Gurukul classes since Friday, they must have highly benefited from the topics that have been chosen for the Gurukul classes, and they must have learned a lot from the teachers all over India who have logged in, and they have given such important guidance and inputs to our postgraduate students. To initiate the third day, it's my pleasure to invite the chief guest of today, none other than Dr. Alka Kriplani, madam. Madam is a teacher of teachers. She is the director and head Department of Gynaecology, Obstetrics and ART, Paras Hospitals, Gurugram. Ex-professor and head Department of OB-GYN, All India Institute of Medical Sciences. Madam had been president of FOXI, president of JESSI, president of GS, president of AOGD. Madam is on the editorial board of so many journals, and Madam is the editor of Asian Journal of Obstetrics and Gynecology Practice. She's co-chair FIGO Menstrual Disorder Committee. She has total got 47 awards. She has given so many orations, and we have learned all our endoscopy from Madam way back in 1999, when she used to conduct so many workshops, Madam. Our basics of endoscopy had been cleared by none other than you, Madam. Over to you, Madam, for your pearls of wisdom.
Thank you so much, Mala. It is a mutual admiration committee. First of all, I must congratulate you, because very few people are so interested as you have been doing in basic teaching. I think it is very important, these basic teachings, our DNBs, our PGs, they are their building blocks. So rather than conducting hi-fi webinars or showcasing one's own, highly specialized field work, I think I compliment and congratulate you for, I have seen your program of these 3 days, wonderful, all basics. And I think more and more youngsters need to clarify their basics rather than doing hi-fi. So, and what to say of Mala Srivastava, the very successful AOGD president and who had done such a great work. She is a quiet worker, but she really keeps working. And in Ganga, it's a legacy that their teaching is very good. Their DNB program is one of the best. And Mala is holding the flag, rather taking it very, very high. I saw these HSG and these basic things, and I really feel that this is the need of the day. In all conferences, we oldies keep on discussing and attending. These youngsters need to be taught basics. And Mala, I heard there are 80 students, so it's a big number. And I wish more and more DNB students get enrolled and learn in these classes. They are very, very important to clarify their concepts. And I could see the name of Chanda Mansugani. So your team is very good, Mala. You are a good team builder. That's very important, I think, for successful running programs and teaching programs. A team is very, very important. And I give you all the credit for leading and having a successful team, and wish you all the best. Happy learning candidates for the day. And just sit through, because if you read in the books 10, 20 hours, you may not imbibe so much of knowledge as you will imbibe in half an hour or 1 hour lecture. So happy learning, happy Sunday. Thank you for the invitation.
Thanks, madam, for all your blessings and good wishes, madam. And it's always a pleasure to see you and hear from you and learn from you, madam. And it's my pleasure again to invite our guest of honor, none other than Dr. Komal Chavan. Dr. Komal is the medical director, Chavan Maternity and Nursing Home. She's a senior consultant, DNB teacher and unit chief, B.N. Desai Hospital, Mumbai. Ex-honorary professor, Dr. R.N. Cooper Hospital and HBT Medical College, Vice President-elect FOXI 2025, Governing Council member, Core Committee membership, Cell FOXI, Chairperson FOXI Medical Disorder Committee, Chairperson AMOX Family Welfare and MTP Committee, Member Managing Committee of MOG, Joint Secretary ISUPA Mumbai Chapter, Treasurer Mumbai Menopause Society, National Expert for FOXI Project, UNICEF, Lakshya, Dhira and RAC, and Convener for FOXI Guinness World Record, Break Free from Anemia. Over to you, Dr. Komal, for your words of wisdom for our PG students.
Thank you so much. And it is indeed a great Sunday morning, and it is a learning experience. The 3 days spread this Gurukul program, which is a comprehensive teaching for medical students, is definitely going to benefit so many PGs. And does training like this, focused on exams, are really, really going to be the need of the hour. Everywhere, all over India, the students benefit. And I totally agree with Dr. Alka Kriplani, madam, deepest regards to her, that teaching is very important. And once who takes up the job of teaching and spreading knowledge is the best thing, that what we can do in webinars, because that is the need of the hour, rather than, upgrading our skills and spreading knowledge is very, very important. Our PGs are the future of our generation, and we look upon them. They should be upgraded with the recent advances, the topics which are in practical base. Like I can see in the program that you have table, HSG, Viva, everything. So this is actually going to give them like a mock exam kind of an experience. So very nice. And I can see Dr. Shobha Gudi also joined. So hi, Dr. Shobha. And many more faculties will be joining throughout the day. So I wish Mala.
Hello, Komal. Hello. Wonderful to see you.
Thank you. And I wish Mala a great success and in all her future endeavors, and best wishes for this program. Thank you for inviting me.
Thanks, Dr. Komal, for your nice words. And we were moved immediately to the scientific program. And it's my pleasure to introduce our first teacher of the day, Dr. Shobha Gudi, madam. Dr. Shobha Gudi, we all know, is an excellent teacher, and she keeps on teaching about the contraception throughout India. Dr. Shobha is a professor, HOD, St. Philomena Hospital, Bangalore, postgraduate teacher as well as examiner. She had been chairperson of Family Welfare Committee of OSCE, President Bangalore Society of OB-GYN, assessor GOI, Project Lakshya, board member FPAI, peer reviewer Jogi, GCM, ICOG, President BMS, Chairperson Contraception and Reproductive Health, ISOPAM, EC member Kasuga, editor Obstetric Hemorrhage, author Foxy Focus, AUB, GCPR, SRH, ALARC, and many publications in national and international journals. Over to you, Dr. Shobha, for your
Thank you.
most
Thank you.
awaited
Yeah.
lecture on contraception.
Okay, okay. I hope that enough number of students have joined and more are going to join because I can see some 34, 35 people here. Some of them are us. So are they going to join, Mala, or we should wait?
Yes,
what
they
we
will
should-
join, and this is faculty link, and there's another delegate
Oh,
link
then
also.
it is okay. Okay, I'm
Because
so
this
sorry.
is
I
all
didn't
faculty
realize
link
that.
who have joined without this thing. These
Okay,
are two
Mala.
separate links.
Okay. Okay, so this is a tremendous day for me when my dear friend Mala calls me to speak on a subject which is close to my soul, I must say, not just my heart, because I think that kind of commitment and involvement is required by practitioners today and practitioners of the future, the healthcare providers of the future, all of you. All right. So it is an amazing thing that I am able to connect to so many young minds in the field. And as you go forward in your career, exploring the possibilities of excelling in a certain field, etc., I'm sure you will find ways and means to excel in the field of endoscopic surgery or vaginal surgery or urogynecology or infertility ART or high risk obstetrics, fetal medicine, obstetric maternal and fetal medicine. There's so many branches today, even gynae oncology, which at some point of time I was extremely attracted to. I would have become an gynecologist, but for my love for obstetrics. So therefore, you will find your ways to reach into some specialized field. I have no doubt. But please remember that once you don this mantle of being an Indian obstetrician, serving this large community, this huge, huge population of India, first and foremost, you must understand the reproductive rights of women, and you must be able to implement planned pregnancy amongst the women who come forward to seek your help. Planning pregnancy with good preconceptional care and good postnatal follow-up is one of the most important prerequisite of having a good outcome in terms
Hello.
of maternal
Ma'am,
and
your
fetal
slide
health.
not visible.
I have not yet shared.
Okay.
I will share now. I have not yet shared. I am just giving a pep talk to the PGs waiting for at least the number of 40 to reach. or as Mala said, they are in the other. So I will start sharing my screen. I just wanted to convey that whichever super specialization you take, or even if you want to do a general OB-GYN, it will be important to implement, or it will be important to have this part of service in your clinic. To make this part of service, provision of contraception, family planning, and a parallel service of safe abortion and concurrent contraception as one of the key areas where you have to integrate your practice into this, because it's important that this is part of your conversation with the patient. So I thought of doing several things, but then I felt that this PPT flow will suffice best for your curriculum and for the way that you should prepare for this subject, because I feel at least 10% or 15% of your entire questionnaire and exam, also including the practical, you will be queried, or you'll be asked about family planning and contraception. You'll be asked about the government programs which are currently in operation in the country, the public sector health programs. You must be knowing the indemnity, the incentives which have been put in place by the government of India. You must remember that the family planning program of the Indian government is the oldest in the entire world, and it was started first, though it may not have succeeded in the ways that we wanted it to. But yes, we do have a very robust program in the public health sector. All right, so let us understand that the world is becoming a smaller place to live because the population is growing. And if all of you are aware that India now stands at 144 crores of people, and we have surpassed China, which is still around, hovering around 140 crores or 139 crores. And you are aware that China is a much, much bigger country. Can you see? China is a much, much, much bigger country than us, okay? So we don't have that much of place, 8 billion plus on the world. It will become 12 billion. Hello? Is my slide seen? Any problem? Any problem?
No, ma'am, your slide is seen.
I heard somebody. Kindly zoom. Okay.
The other participants, please mute yourselves.
Okay. All right. So this is going to become like this, the world in the next coming years. If we are not careful about our own country, we need to protect ourselves from calamities. We cannot take it anymore. Right? We cannot take it anymore. You can see that we cannot take it anymore. All right. So what do we know? 9 billion world population 2050. We account 17% of world population. We have 21% of pregnancies resulting live births are all unplanned, maybe more, maybe more. 2/5 of all pregnancies unintended actually. But if we do meet the unmet need for contraception, which is there in our daily practice, we meet the unmet need, then it is sure that we can avert 55 million unwanted pregnancies per year, 22 million fewer abortions per year, and there will be 90,000 fewer maternal deaths. So that is something to reckon with. So this is what we know so far. We don't know that, every practitioner doesn't know this part of the picture, that we can do a lot of good by preventing unwanted pregnancies. Well, when will India become the most populous country? This is last year's slide. So we know that it has already become. As you can see, we have surpassed China. Now we have become 1.44. So the next time I present, I must update this slide. Okay. So you all know this. This was predicted in 2022, but it became so in 2021. So it was a little early. Let us come to the hard core of the matter as to how we can make a difference going forward, because this many people will all have reproductive intent, and all of them will be ready to reproduce as they become adults. So there are, out of these 144, at least 30% are youth with full potential for reproduction. So we must know that. Well, so far it is female sterilization which looks like it is leading as a method of choice, and that is a little redundant one, because this happens after a requisite number of children. But what we are interested for achieving population stabilization is to put a distance or a gap between two pregnancies, and that will be achieved by all these spacing methods. The pills, the condoms, you can see the list here, the IUDs, the pills, the LAM, injectable condoms. So this pie chart has been put for a specific purpose. When will we start moving towards population stabilization is when all these other colors replace this color, and this becomes a very dignified quadrant like this, and the remaining become, because when these colors move like this, that will be the time when we know that there is a balance in use of different methods of contraceptives, and also this is translating into spacing, less number of births at any given point of time, and hence some small steps towards population stabilization. In India, the challenge is like this. There are several traditional methods which do not go away, and the age, education, the surviving son or the need for a son, religion, social group, household size, the region, and the economic condition of the women are significant determinants of contraceptive use. And that is where practitioners have to do a little bit of, a skilled counseling so that you overcome all these socio-economic, geographical barriers, and you see to it that the woman is able to have planned pregnancies of limited number. So therefore comes the question, is there a medical need of contraception in India? Very much so, very much so. And then we must understand that half of the pregnancies are unintended, and we must make it converted into intended pregnancy. And because this is the 48 million unintended pregnancies, 48 million pregnancies which happen, intended plus unintended in the country total, out of which about 26 million deliveries will happen, which are planned births, so 43%. Then there are some unintended births. Then this is a large segment is induced abortion, and then this is miscarriage happening from the birth, spontaneous miscarriage. This is intended miscarriage or MTP, and this is from unintended miscarriage from intended. So spontaneous miscarriage. Can you see the amount of reproductive wastage which is happening? And can you see the burden of unintended birth? So there is indeed a medical need for contraception. We should all become very adept at prescribing contraception. Please remember that. All right. Okay. Okay. I'll just go for this because I think we have already dealt. Only thing is that the unmet need remains around, say, 9 to 10% in the latest NFHS. This is 15-16. We have now 19-20. We have now 19-20. That is NFHS 5. This was NFHS 4. So the NFHS 5 is not listed here, but NFHS 5 says that unmet need is around 10% to 11% combined. And for spacing methods, it's around 8 to 9%. So remember that. Remember that. This part of the slide is important. Says that there's a large amount of heterogeneity in India, with a difference of up to 55% in modern contraceptive use, and this can improve whenever the modern contraceptive use. Whenever in point of time it will reach 70%, I think we will be beginning to reach towards our goal. When you get oriented to what methods are there is some common terminology used, like what is your method mix? That means what methods do you offer to the woman? And this will depend on the history of that service provider and of that facility. What are the common methods accepted by the women of those geographical areas? For example, pills are very prevalent in higher socioeconomic status. Lower socioeconomic status, the intrauterine devices and the injectables are prevalent. But then, while offering, you have to give them a basket of choice. You have to give them a basket of choice. So these are some of the methods which are there. And a method mix in India, the government basket right now looks like that. LAM is propagated, the sterilizations are propagated, barriers, the pills, injections, and the devices. And a lot is still missing from this list, that is non-hormonal, which is Centproman, which is now Chaya in the government sector. We have contraceptive implants, which will interest you a lot as modern day gynecologists. I'll tell you about it. Then there are female condoms also available today. And this gives a lot of reproductive freedom to the woman because she doesn't have to depend on the man to use a barrier. And then there are other natural methods. You should also be aware about natural methods of contraception, though their failure rate would be low because some of the couples which consult you may agree only for natural methods of contraception. So remember that. Remember that. But then also remember that whenever you offer the basket of choice, you also have to judge whether this couple requires a dual method of contraception. That is the belt and suspender approach. And that means that they may require a very strong method to prevent infection and a very strong method to prevent pregnancy. And this is what we offer to those couples who are not in a socially stable relationship, who are still in the unmarried, zone, and they may have a transient intimacy and then move on to other partners. Such couples, it is imperative that we protect the woman who comes to us for healthcare from both pregnancy as well as infection. One word on condom before we move on. It is only the latex male condom and not any of the fancy stuff available across the counter. It is only the latex male condom which has been, declared as very, very, very foolproof to transmission of the HIV virus. No other substance, no other material, and female condom will not be able to prevent transmission of HIV. The effectiveness chart. This is an effectiveness chart endorsed by many authorities, including the WHO. Even GOI uses this chart. In fact, this is a variant of the Government of India, and this shows this arrow, which shows increasing effectiveness. It shows the LARC methods at the top along with the sterilizations. You can see the LARC methods here. The long-acting reversible contraceptives are the LARC, the intrauterine device and the implant. Injectable and the progesterone IUD is also included in this list, and the sterilizations. So today, the focus needs to be on long-acting reversible contraceptives. You can see they are very highly efficacious. And the top list is for those methods. The Pearl index is less than 1 pregnancy per 100 women in 1 year. In terms of percentage, it will be around 0.5%. The implant is even less, 0.05%. The failure rate. And the less effective as you go down. So this is the other hormonal contraceptive, and then the barriers, and so on and so forth. So choice should be individualized. And this is the MEC criteria. It is often asked of you in exam. You all are very, very, tech savvy. You know that this is a WHO medical eligibility criteria. You know that there is an app which can be downloaded onto your mobile screen, and it can be utilized to provide women with the safest, contraceptive which is applicable for them. So a condition for which there is no restriction of use, a condition where advantages are outweighing the risk, a condition where risk is outweighing the advantage. So better to look for alternative, and a condition in which it should never be used because of unacceptable health risk. And this is the kind of disc which is available. We call it the contraception wheel. You can see the numbers identified on the base of the disc, which are the 1, 2, 3, 4 MEC criteria, the life situations, and the inner circle, which tells the patient particulars like the phase of life, the age, etc. And the outer one adds the extra nuancing or the extra clinical situation or the medical problem or any other peculiarity which is there. So over this is the disc which shows us the method. So today we have a green wheel instead of the blue, and in the green wheel in Government of India, these are how many methods are here? 6. 6 kinds of methods. So the 7th method is the centroman, and that has been included in the green wheel. You can see that these are the methods and these are the criteria here, which there is a slit in here and which will show up the criteria. So for example, what is it showing here? Postpartum and breastfeeding within 48 hours and 48 hours to less than 4 weeks. So the hormones are contraindicated here. The POPs are 2, the injectables are 3. So this and this should not be prescribed very early postpartum. And others like the implant IUD and all are fine. But what is the king is the copper IUD. That means it's excellent for within 48 hours for postpartum IUCD. You can, when the woman delivers with a good technique, with some training, you can place the copper IUCD for her and send her home with a contraception already existing in the uterus, because she might ovulate after a month or so, and she may even enter into her marital life, and she's protected from pregnancy. By now, all postgraduates must have seen women coming back with a pregnancy within 6 months of their birth. And this is how you can protect them, by giving them postpartum contraception. On the back of the wheel, there are, further nuancing for prescription of the contraception. For example, somewhere if you see an asterisk of 1C, HIV/AIDS, okay, then you must go and see what C means here. If past pelvic inflammatory disease, all methods are fun, including the IUDs, right? So that means, um, if there is an asterisk of C, then you have to see that you follow the superscript which is written here. For example, the asterisk of D, right? The asterisk of D. So that means that if within 3 weeks, not breastfeeding and no other BT risk factor, the category assigned is 3 for that particular situation. So this may apply to a postpartum woman who is not breastfeeding and is within 3 weeks. And which method is free for her is the COC, right? So that is how further nuancing is done. This is a ready-reckoner chart, the same MEC criteria converted into a ready-reckoner. The the conditions are listed here, and the sub-conditions are listed here, and the criteria are listed. The methods are here, and the criteria are here. So if you look at green, say post-abortion, immediate post-abortion, post-septic, if it is there, then the hormonal contraceptions are all green, whereas the copper IUCD is in red. So that this is a ready reckoner chart, and you need to just understand it, and it will help you to give safe contraception. Just before I move on, it gives you a basket to offer also. All the wheel as well as this chart, it gives you a basket to offer. Uterine distortion due to fibroids or anatomical abnormalities. Do not think that women with fibroids like this cannot become pregnant. You would have seen more pregnancy with fibroids than in infertile women. So in them, see, the hormonal contraceptions are green, and the copper IUCD and the LNG IUS cannot be given because it's distorting the cavity. So when you offer choice, you have to tell them about different hormonal contraceptive methods. So that is how it goes. And always give a basket of choice. So once we have introduced the subject, let us go very, very quickly to each of the methods, right? And then we can kind of have a conclusion. So you need to understand about contraception as reversible and as non-reversible or limiting, which is the sterilization. And our focus today is on the reversible method, because that is what will take you forward and build up your clientele for contraception and the practice of contraception, and that is what will give women very good health, reproductive health. So reversible short acting, reversible long acting, and the barrier method. That is the general classification. This is the short acting reversible as the oral contraceptive, the combined pill, the progesterone only, and then the emergency contraception pill, the 3 types, and then the oral pill is the non-hormonal pill, which is the centrochromane or the ormiloxicin. The oral was first introduced as early as 1960. It's widely prevalent in the world. 25% of women aged 15 to 44 are using. Most commonly prescribed is the one with estrogen and progesterone. The effectiveness is very high. The combined pill you can see with perfect use, as I have already told, these are highly efficacious. If it's perfect use, it is less than 1 per 100 women. With typical use, however, the failure rate will climb a little, missed pills, etc. And the POP, the progesterone only pill, is more versatile than the combined pill because it can be given in breastfeeding women within 6 months, and it has got similar failure rate. Ormiloxicin has slightly higher failure rate, but it's acceptable to many because it is non-hormonal. The only problem is it is studied less. There are less studies available on centromer. The EC pill, you need to know about emergency contraception because you'll be asked questions of this. ECPs are not continuous forms of birth control. They're related to the episode of unprotected sexual intercourse. It is called UPSI. And if 100 women use ECPs, if they use only progestin, one patient may become pregnant if it is used in the correct way. If they are using the OC pill, the combined pill, then the failure rate goes up. But this should be used within few hours, maybe 48 to 72 hours of sexual intercourse. But it can be taken up to 5 days of the UPSI if we use the ulipristal acetate method, 30 milligrams. Okay, but in general, the earlier it is taken, the more effective emergency contraception pill will be. Women who opt for emergency contraception should be quickly counseled and started on a regular contraception method. How do the OCs act? You're all very good in endocrinology, I'm very sure, because a gynecologist has to be a very good female endocrinologist, right? So you know that this OCP will inhibit follicular development. Actually, how does it do that? It does that through its central action of negative feedback, inhibition of ovulation and the corpus luteum formation. It also acts with the cervical plug and makes it very, very strong, very thick. And that is what decreases the incidence of pelvic inflammatory disease in such cases because it also has a protective effect. Now, this contains estrogen, this contains progesterone, right? Earlier, it used to be very kind of unfriendly type of estrogen, progesterone. Very crude formulations were available. Mestranol, norethynodrel was the first one. But over the years, the technology for pill has refined so much. And today, when we say low dose COC, what does it mean? Low dose COC means essentially that a very low dose of estrogen is being used, and that is less than 35 micrograms. So different COCs just get oriented to how it can be prescribed. The combined oral pill, the traditional regimes are 21/7, 21 active tablets, wait for withdrawal and then restart the pill. 24/4 is a 28-day regime with less than 7 hormone-free days. That means 4 days of hormone-free days, and then the woman has a period and can start again. So this is an even lower estrogen than the 21 days. Extended regimes are more than 28 days. We do use it in conditions for not just for contraception, but also for relief of gynecological conditions like endometriosis and abnormal uterine bleeding, etc. And then there is a continuous regime which also can be offered to women who are severely anemic to prevent them from having periods so that you can build up anemia, and those who have continuous pain related to menstruation like chronic endometriosis also can be offered continuous regime, and up to 1 year continuous can be taken without any adverse effects in well-selected patients. The evolution of oral contraceptive. Now, this is a very, very heavy slide, will not be worth going through each, but you should know about biphasic and triphasic pill, and now there is quadriphasic pill. The latest one is the quadriphasic pill, which is not listed here. It's called the Clara. It is QLAIRA. Please remember, read up because it is a very novel technology where different estrogen preparations, different estrogen dosages have been kind of designed, and it's a very, very attractive option for women. So Clara is the latest, which is quadriphasic, but in general you should know what is biphasic and triphasic. The commonly used pill today which we prescribe are the biphasic pills, the commonly used one. Okay, so then okay. The commonly used pill today is actually the monophasic because we are using the same dosage of estrogen progesterone in the entire pill. Biphasic was introduced with the wish to, split estrogen and progesterone and give it at this different time. And triphasic was introduced to mimic the natural cycle. But all of them were found to be more expensive and less beneficial than the traditional monophasic pill, right? Okay, so this is how it goes. The generation depends essentially on the progesterone, which has been changed, and not on the estrogen. The estrogen is the same, ethinyl estradiol, just the dosages changes, depending on whether it is low dose or not. So when we say first generation, it was norethistron, progesterone. Second generation, levonorgestrel and norgestrel. Third is desogestrel, gestodine, norgestimate. The desogestrel containing pill which is available in India. The fourth generation is when the spironolactone antagonist came into play, and that is the drospirenone and nomigestrol and dinegest. So in India, we have drospirenone and dinegest containing medications, and then there is the low dose COCs, which is a nomenclature depicting that it's less than 35 microgram ethinyl estradiol. It could be 30, it could be 20, sometimes even 50. The estrogen containing is a high dose is no longer used. The moderate dose is sometimes used in the treatment of hirsutism along with cyproterone acetate, but that does not classify as COC. The low dose is 15 to 20, and even 30 also is known as low dose in our lingo, though some industries they prefer to use 30 days as moderate dose. Okay. Why choose low dose estrogen? Because high dose estrogen has got some kind of side effects. Discontinuing or switching to less effective methods will become important. Unintended pregnancy can happen. That is the reason low dose COCs are better. So, okay, in perimenopausal women also, it is valuable to give low dose because the requirement also comes down. Okay. Okay. So, available combination of estrogen progesterone is there in this list. We shall go ahead. Benefits and side effects. Primary benefit is preventing the unwanted pregnancy, but the benefit is it improves cycle control. It gives a feeling of well-being to the woman, prevents cancers, ovarian, endometrial, and colorectal. That's very important. And overall reduction in maternal mortality is seen because unintended pregnancies, unsafe abortion, ectopic pregnancies will come down. The minor adverse effects are kind of time sensitive. After a few cycles of use, they just go away. Sometimes breakthrough bleeding or some pain or breast tenderness. Decreased libido may be there, which also can be overcome functionally. Weight gain is a myth. Weight gain does not happen with the modern pills. What's new in contraception? I have already spoken that some of the progesterones which are used today, the dinegest, etc., make it new. Okay, and classification structure wise. So we shall go ahead. Too much of we need to get oriented to more and more methods. So we shall go ahead. Remember that dinegest gives a low androgenic activity and does not have androgen-related side effects. So dinegest containing pills have very good effect on endometriosis. Because it's a hybrid progestogen, it has got pronounced effect and does not have affinity for other receptors like estrogen, very little affinity, steroid and mineralocorticoid. And the anti-androgenic activity is also there, though it is less than cyproterone. We have levonorgestrel also, which is the older one along with ethinyl estradiol. The effect of POCs on bone mineral density is very encouraging. It does not fall as it does with the medroxyprogesterone acetate injections. There is a reversible fall of bone mineral density. In fact, they show better bone mineral density when they are on CO. So I think we must go on to the progesterone only pill. Progesterone only pill is very useful. 0.75 milligram of levonorgestrel can be used as an emergency contraception. But the mini pill which is used like desogestrel, continuous desogestrel, POP's mini pill, can you see 0.075 milligram as Zerogen or Cerazette. We also have drospirenone 4 milligram. progesterone only pill earlier, the 0.075 milligram was available
Pelvis, it
in
is just for a basic knowledge. Probably it will ask you, oh, yes, if you are not able to see the diameter properly or the points on the inlet properly, then you may be asking what are these mean. So you should know your basic anatomy.
फोर्टीज
But
पैनल
otherwise,
सुनने से
pelvis and
तो
false
माइनस कर
pelvis.
दो
What
तो
we
इतने
are
स्टूडेंट
talking about today is about the
अटेंडेंस
pelvis.
भी 27
What divides the pelvis
ये
into
अटेंडेंस
true and false pelvis
what is happening?
is the
Sorry.
pelvic brim. Okay.
25-30
brim
लोगों को
What is happening? Hello?
I think
Hello?
there is can the backend team, Vinod, can you look and into the matter? There are some other recording playing, and please mute everyone. Ma'am, you can, Dr. Shobha, you can continue. Yeah, probably some, back.
But students are listening, right? People are
Yes,
listening,
yes,
right?
yes,
Because I
yes,
can't
yes.
make out anything here.
Yes,
There's
yes,
absolutely nothing in the chat box. They can post some questions, so I'll know that they are listening.
Yeah,
Okay, so
please
these
post
are
your questions. Yeah.
yeah.
They
Just get
said that somebody
connected.
wrote the voice is too low. You can just raise your volume, Dr. Shobha.
Okay. I have
Otherwise,
raised
yeah,
actually.
you
This
can-
is maximum now. Yeah.
Yeah, okay.
Okay, now I hope it is better now. Yeah.
Yeah.
Okay, so so this is how some of the MEC charts will look when you open it on the internet. You know, on the wheel it will look a little different, but when you open up on the internet or you go into the into respective sites and you look up, then you'll see, for example, if you see the progesterone only pill in the postpartum, you want, if the woman is sitting in front of you, you can open this page. You'll see that, you know, if the woman is more than 6 weeks or less than 6 months, that is when she is likely to come to you for contraception. Then you can see that you can use progesterone only pills for them, injections. You can provide them the LNG IUS. You can even give them the etonorgestrel implants. They are all MEC category 1. So it goes on to say that progesterone only contraceptive is very versatile. After 6 months, she becomes eligible for the combined oral contraceptive also, where estrogen can be added. POP has got tremendous benefit. It can be used in breastfeeding women with no fear of altering the breast milk. And there are several non-contraceptive health benefits like improvement of dysmenorrhea. She will have less premenstrual syndrome. She will not become anemic. So there are several advantages in the postpartum period. And today there is a lot of emphasis about recovery after delivery, how good she becomes, how fit she becomes after delivery. So contraceptives like this will help her to come back to her previous health because she's protected and she has better menstrual health, is protected from pregnancy, etc. The minor adverse effects of menstrual irregularity can be overcome by good counseling and some small medications. All right, so this is further evidence in support of progesterone only pill. The progesterone only pill is contraindicated in breast cancer, liver problems, current deep vein thrombosis and embolism, etc. So in this, the category 4 may be similar to the combined oral contraceptive pill. I have been speaking to you about long-acting reversible contraceptives. It looks like copper IUD. There are several questions which are asked of you on that. There is injection and there is the progesterone-bearing intrauterine device. I'm sure all of you must have inserted the Mirena, and then there is the implant. So just get oriented to SARC versus LARC. So the SARC is pill, patches, ring, user-dependent, the short-acting reversible contraceptive. There's some fear in the minds of the client that it might cause negative health effect, and there is a lot of more training or nuanced information needed for prescription of this, because you have to follow the MEC criteria very closely when you prescribe COC. Whereas LARC methods is like fit it and forget it. So it highest protection against the pregnancies, more effective, more continuation rate, low failure rate, and they're estrogen free. So there is a lot of drive towards LARC method. You can also see that the failure rate, can you see the failure rate of this with typical use is so low. With this I have told you already. So guideline recommendations are also there from NICE, from ACOG, even from FOXY. So let us just see the injectable contraceptives. This is added to the basket of choice under the national program, and some of these omissions are, I think, by some other error. Now this contains 150 milligram, the intramuscular DMPA. It acts on the endometrium, on the cervix, and also acts inhibition of ovulation. You all know that. Just a moment. Yeah. So that is the mechanism of action. It also inhibits the ovulation to some extent. And then you will be asked about non-contraceptive benefits. So when it comes to injection, you can say that it is very user-friendly, it is convenient, it is confidential, it is reversible, and it highly effective, and does not interfere with her marital life. Exam is not needed, pelvic exam, suitable for women who are not eligible to use estrogen, that for immediate lactating mothers, and may be used at any age and any parity. There are some non-contraceptive benefits also for DMPA. Protects against PID and menstrual cramping and ectopic pregnancy, decreases benign breast disease, improves anemia, reduces the symptoms of endometriosis, PID, and protects against endometrial cancer and possibly ovarian cancer, reduces sickle cell crisis in women with sickle cell anemia. So this is the information that you must carry with yourself. Just know that today there is a subcutaneous version, and with some training, the woman can inject it herself, just beneath the skin, subcutaneous version of DMPA, which is 104 milligram with equal efficacy. Okay, so acceptability is very high, it's very eco-friendly. Okay, so then we come to intrauterine devices. So long-acting IUDs is safe, effective, should be advocated for those who require long-term use. And all these myths, you should be able to, misconceptions, you should be able to dispel. That the insertion is difficult, it is painful, removal is difficult, expulsion, you have to get tested before you get an IUD, and that the partner will feel the IUD, all these are myths. And then you can see that, the different type of inserters. So you will be required to know the method of insertion of every intrauterine device. So if copper IUCD is there, if this kind of LNG IUS is there, you must be familiar with the basic technique, the aseptic technique, the no-touch technique, and then there is the postpartum IUCD. You must know the method of insertion. All right, and this shows the hormone. I'm sure all of you must be aware that LNG IUS, it releases 20 microgram per day, highly effective contraceptive. Okay, and there are some contraindications to intrauterine device, and pregnancy should be ruled out, undiagnosed vaginal bleeding, any possible malignancy, a distorted uterine cavity or infection, all that should be ruled out. Relatively, they are not very suitable between 48 hours and 4 weeks. So whenever we teach postpartum IUCD, we say not between 48 hours and 4 weeks, because it's a rapidly involuting uterus, right? Should not do that. Deep vein thrombosis for LNG IUS, not for the copper IUD. The cancers, again for LNG IUS, and in women who are at very, very high risk of STI or currently having STI. Okay, so you can see 30-year-old lawyer, 9 months baby, not comfortable with tablets. You can see 40-year-old, heavy painful period with the anemia, okay, and normal ultrasound. Then somebody who wants is advised sterilization because so many children, does not want surgery. Then you can see that 32 weeks pregnant woman wants to know about her contraception, and then there is this adolescent, unmarried, who is in love and is sexually active. So can we provide LNG to these? Yes. So I just wanted to tell you that there are some contraceptive methods which are very versatile and very useful. Implant and LNG IUS are some of them. So sometimes you'll be asked, is LNG better or the copper IUD is better? Both have their advantages. Copper IUD can cause some heavier bleeding, where this causes very spotting and slight bleeding. LNG IUS effective can be variable. This is available from 3 to 5 to 10 to 11 years. This is 3 to 5 years. But one thing common is both do not protect against STI. And one thing better here, LNG, is it reduces menstrual symptoms. And one thing better in copper IUDs, it can be used as an emergency contraception. LARC after abortion, promote long-acting methods after abortion. The woman will come back less for the repeat abortion request. So she is more protected from the abortion happening again. This is the implant. This is how it is placed on the inside of the arm. It contains etonorgestrel, so it's a progesterone-only implant. Disposable applicator will be there, and it lasts for 3 years. You can see it is just 4 centimeter, 2 millimeter only in diameter, and the preloaded applicator is there, highly effective. Again, it acts centrally as well as locally. A similar contraindications, suspected pregnancy, thromboembolic disorder, malignancies, liver disorder. So it's just like other hormone contraceptives, undiagnosed vaginal bleeding, and if there is hypersensitivity in the past to the same one. Some drug interactions are possible. So which are the methods which have drug interactions? The combined oral contraceptive pill and the etonorgestrel implant. So this is a place where progesterone only pills and the injectable medroxyprogesterone acetate will score a point. They do not have drug interaction. But if women are taking anti-epileptics or on HIV medication or on anti-tubercular drugs, etc., then combined oral pills and the implant efficacy may come down. Okay, so I think I should go towards the conclusion of my talk because I think it is late. How much more time do I have? Can the host tell me?
Ma'am, another 5 minutes.
Thank you so much. So just wanted to show some of the medical conditions like obesity, diabetes, cardiovascular risk factors. Today, women are kind of, having a double trouble. That means they want to get married later and they want to finish career first or earning or want to choose their partner with a lot of care. And so they delay marriage. So childbearing is delayed. So they are older women requiring contraception. There are also women who will be in relationships earlier to marriage for many years. Then the other reason why women are in trouble is because of the higher incidence of non-communicable diseases. And it becomes slightly challenging to offer them contraception for longer periods of time. So we have the obesity on the rise, diabetes on the rise, hypertension on the rise, drug abuse on the rise, tobacco use on the rise. So as practitioners of future in India, you will encounter women with this kind of profile. So you must know what is safe in hypertension. The injectables are good in well-controlled hypertension, but estrogen-containing pills are not safe in hypertension. So you can give the other progesterone and the barrier methods, etc., in well-controlled hypertension. Diabetes mellitus, the well-controlled diabetes, progesterone-only method, and injectable. Okay. And then you have women with other conditions like APLA and SLE, where combined oral contraceptive pills cannot be used. Same for hereditary thrombophilia, same for migraine with Arora. Now, conditions associated with high risk for adverse health events as a result of unintended treatment. All right. And you can see the LARC methods here, which are by and large applicable with some nuancing. You can prescribe to this method because they're very effective and they're reasonably safe. Women with cancer, except for the hormones, the copper IUD can be given. liver problems, heart disease, diabetes with vascular disease, more than 20 years diabetes, endometrial ovarian cancer, early cancer which has been treated, women are waiting, sickle cell disease, epilepsy, asthma, infections which have been treated, hypertension which is controlled, previous history of stroke, SLE, HIV, women living with HIV. There is a whole group of people which are called PLHIV. That means people living with HIV. That is a different cohort of people in our country, because today HIV usually does not kill. It has become like a carrier virus, and people are surviving throughout their reproductive life. So thrombogenic mutations maybe, or malignant gestational trophoblastic disease, all these women, the risk of unintended pregnancy is very high. And in them, the contraception is very important, right? Okay. All right. Sometimes we do get asked about why not the onus of contraception on men rather than on women. So for men, the barrier method and the vasectomy has come in, but other methods, unfortunately, have not found much research, have not found much application, and also it is going to be a long time. We have to advocate what is available for us. All right. I think we come to the end of the talk. In summary, please remember there is a large unmet need. Sterilization should be adopted where adequate, and LARC are good alternatives to sterilization. Modern methods should be included in the contraception mix. Please develop a basket of choice, because women like to choose. Don't give them one method, give them the basket. This is an interesting observation by UN, because it endorsed that, there are 13 life-saving commodities for women. And as far as maternal health is concerned, there are the oxytocics, there is magnesium sulfate, etc. But whereas reproductive health, there is the female condom, there is the emergency contraception, and there is the contraceptive implant. So contraception can be life-saving because it protects the woman from unintended pregnancy and unsafe abortion. All right, so these are targets of family planning in India. I shall not be reading that out. I will end with saying that family planning alone can bring more benefits to more people at less cost than any other single technology now available to the human race. So thank you, dear postgraduates, for listening to me. I'm very proud that I was able to address all of you. It gives me great joy to see that, Mala has been able to
Thank you so
bring
much
all
for
of
such a
you.
wonderful
Thank you very much for the patience.
Can I make a comment here with your permission? Dr. Shobha, hi. Dr. Geeta
Hi.
here.
Hi, Geeta. Good morning.
Good
Any
morning.
residents having any questions? Whoever joined for the first session for the day?
Yeah, Dr. Ashmita, I have one comment and a question, if I may.
Yes, ma'am.
Okay,
Yes,
so
ma'am, please,
Dr.
please.
Shobha, as usual, it is always such a pleasure to hear your very comprehensive lectures, and always a pleasure to gather knowledge from you. One of my queries is, Dr. Shobha, as you mentioned, that love-bitten adolescent, we get a lot of these patients, who are having an active sexual life, they are unmarried, and they're adolescent, and with the modern day scenario, there is a lot of unmet need for contraception amongst these girls. So I think, as the chairman of the FOXY committee on this, what do you think? What is the way forward? How can we address this issue? Because they are so love-bitten, and in the spur of the moment, they are having unprotected sexual activity. What do you think is the way forward in these girls?
I think it's not that they don't get information. I feel that either they read wrong information and get frightened about the method, or they interpret the information which is given wrongly, and simply they do not go to the correct information portals. That is one aspect, because today every youth, every adolescent has a mobile, and they have access to information. So I think we have to sensitize them that there are some principles of safe sex. We have to tell them that with safe sex or sexual freedom, which is now happening in our country, comes a great responsibility. You have to tell them that they have to with that, because nobody is judging them for the choices they make. It may not meet our approval, but we cannot judge them for it. Judging them, being harsh with them, or admonishing them, or wanting to talk to their parents or their elders will only drive them away from our consultation rooms. So what we have to tell them is it is their choice, and they have to exercise one more choice in the same way, and that is choose to use safe sex practices. And that is always the dual method, the belt and suspender approach. They have to use the barrier, and they have to use an extra method. That and that only will protect them from both pregnancy and infection. Having said that, many people will think, oh, that is easier said than done. Then what we can do is to have some entry into the education curriculum. I don't know, calling it a comprehensive education, sexuality education is making it, sound very serious and too difficult to implement and requiring a lot of government policy, etc. So I think as office bearers or as proponents of women's healthcare through organization, can organizational policies happen, and can we talk to the educational institutions heads and make it possible to have some entry into their curriculum in some small way to give them nice structured information about contraception methods? Because today they don't need any knowledge about intercourse. They only need information about safe sex practices. So I think that is what is
Absolutely.
more important.
Yeah, so that's what I wanted to second that, and that is very rightly said, no judgmental attitude, and be, as you rightly said, as a policy maker, maybe in the school curriculum where they read 7th, 8th standard biology and all, I think 11-year-old knows everything these days, just to put in a standard paragraph, maybe at the NCERT level, or, coordinate, you being in the power to do it, just add a paragraph into their biology book. As you rightly said, something substantial has to be done, because that is ruining them. And we have patients who are coming ki haan teenager the, शादी से पहले MTP कराई थी और अब 5 साल हो गए, अब बच्चा ही नहीं हो रहा. All that repercussions of having had an unintended pregnancy, consequently botched up abortion is going to really ruin their sexual and their reproductive life. So just putting a paragraph, you being a proxy bearer, you can, sort of arm twist the people to put in a paragraph about safe sex, and, so just a paragraph about barrier or something, as you said, the Spider-Man, I really love that. I use it so often, with the great responsibility, you have a great freedom, you have a great responsibility. Thank you for that, Dr. Shobha. Always nice to hear.
Thank you very much. Thank you.
I think the residents have no questions. Can we move on to the next session, madam, with your permission?
You can start, Dr. Ashmita, next session.
Hello, am I audible?
Yes.
OSCE. It will be chaired by, it will be moderated by Dr. Geeta Mediratta. Madam is co-chairperson, Institute of Obs and Gynae, Sir Gangaram Hospital, and is also the head of the department. She has a special interest in urogynecology.
She's not co-chairperson, she's chairperson. She's okay.
Chairperson, sorry, ma'am.
Yeah.
On the handout stamp, me has just been printed as it is. I'm so sorry. I just revised my statement. She's the chairperson, Institute of Obs and Gynae, Sir Gangaram Hospital, New Delhi. She has a special interest in urogynecology. and is also the chairperson of the Scientific Committee NARCHI 2024 to 2026. She is chairperson Urogynecology Subcommittee of AOGD 2021 to 23.
I think, Ashmita, we can leave. Let's get down to brass tacks. We have so much material to teach the students. Okay.
And is recipient of in the field of medicine, apart from being the vice president of ISOPUB Delhi. The next moderator for today's session is Professor Dr. Mamta Dagar. She's also the professor in Unit Head, Unit 1, Obs and Gynae, and is an MD, FRCOG, MRCOG, FI.
Yeah, let's go
Excuse
through.
me, Dr. Ashmita, be
Yes.
brief.
Let's move
Yes,
on.
ma'am. The third moderator for today is Dr. Sharmistha Garg, Associate Consultant, Obs and Gynae for Gangaram Hospital. She is the treasurer for the Indian Menopause Society.
So thank
The
you.
session, ma'am. Thank you.
Thank you for a very kind and brief introduction. Thank you so much. And we move on to the next session. Can you see my screen?
Yes, ma'am,
Yes,
we
ma'am.
can see.
You can see your
Okay.
screen.
I hope it is full screen. So no, without wasting further time, now let's move on to the next session, which is OSCE session. And a very good morning to all of you. So basically, we begin with this session, OSCE, which means Objective Structured Clinical Examination, which is in fact a very integral part of your final DNB exit exam. And of course, it's quite scoring if you have answered very precisely and rightly. And this is what we will want to take you through. Me with Dr. Geeta and Dr. Sharmistha will take you through few OSCE cases. This is exactly the same way they are asked in your DNB exam, and your answers have to be in fact precise and right, because there is so much information which is being asked. So if you have read well, you have organized in your mind well, you will be able to answer well. So let's begin with this question. This is the way the question is put to you on your screen in your exit exam. Like this is, just read the scenario very carefully because the time will be like that. You have to read the question as well as the questions which are asked as well as the scenario. So it's a 24-year-old lady which has presented to casualty with anasarca, nausea, vomiting, headache and fever with a blood sugar of 56 grams per deciliter and the liver enzyme SGOT-PT to be 200 and 450, they are raised. So the questions which are basically being asked to you in the exam, there are 6 questions they have asked you in this case. The diagnosis, differential diagnosis, name the criteria for diagnosis, 3 features of the criteria, the risk factors, and the basic management. So I hope you have just read this scenario very well. So it's the gestational age is not mentioned, but the scene is very clear that this is a lady with a raised liver enzymes and a hypoglycemia with the GI symptoms and the CNS symptoms. So the diagnosis, reading the whole picture is what comes to your mind is you have to basically give that. So this picture is most likely very well fitting into the presentation of acute fatty liver of pregnancy, though the gestational age is not mentioned. So you may not be given all the clinching points there. You have to basically give one diagnosis because they have asked one diagnosis. Name the diagnosis. The first part is the acute fatty liver of pregnancy. You may use the abbreviations or you may, if the time permits, you can completely write down acute fatty liver of pregnancy, but provided you use the right standard abbreviations. So the next part which is asked is what is the differential diagnosis? So the differential diagnosis of acute fatty liver of pregnancy is the HELP syndrome, the acute viral hepatitis, preeclampsia, TTP, or there may be in fact intrahepatic cholestasis of pregnancy, which is mentioned as one of the DD of acute fatty liver of pregnancy. So this is what in the differential diagnosis is. Next question which is asked is name the criteria for diagnosis. So basically, and the next 4th is the 3 features of the criteria. So I will combine these 3 and 4 answers in one, though you have to write differently in the exam. So when we write down the criteria for diagnosing acute fatty liver of pregnancy, it is the Swansea criteria which is mentioned as the most standard criteria or the reference criteria for diagnosis of acute fatty liver of the pregnancy. And basically the features of this includes the nausea, vomiting, abdominal pain, polydipsia, polyuria, encephalopathy, a serum bill of more than 0.8, hypoglycemia of less than 72 milligram per deciliter, uric acid of more than 5.7, presence of leukocytosis of more than 11,000, presence of ascites or bright liver on ultrasound, raised SGOT, SGPT of more than 42, raised ammonia of more than 27.5, creat of more than 1.7. I hope you know the known units of these standards. Then the presence of coagulopathy marked by the presence of raised PT and APTT of more than 14 second and 34 second, and the presence of microvascular steatosis or liver biopsy. So the part 3 you may write down as the answer as the Swansea criteria for diagnosis of acute fatty liver. And if there are presence of more than or equal to 6 criteria, then basically you are basically marking it as an acute fatty liver of pregnancy. So more than or equal to 6 criteria are basically given to make a diagnosis of acute fatty liver of pregnancy. Next will be the risk factors. So the 2 risk factors they have asked, though I have mentioned the many risk factors. So if there are 2, they will mark you as, if you have mentioned 2, then you will be given the full mark. So the main deficiencies of this enzyme LCHAD and the other risk factors which go hand in hand are the primigravida, presence of preeclampsia, male fetus, and multiple pregnancies. So if you have marked any 2, probably like deficiency of enzyme LCHAD or the primigravida, pre-T or a multiple pregnancy, any 2 you will be given the mark. Next part is the presence, the basic management. The basic management in case of acute fatty liver is it's really a disease which presents in the last trimester of pregnancy mostly and carries a very high mortality if not well diagnosed in time and managed in time. So it is an early diagnosis and the treatment is a supportive treatment. Supportive treatment you give, you basically correct the hypoglycemia, you correct the elevated anemia, you correct the thrombocytopenia and your coagulation derangement and give a supportive treatment, because if not managed in time and if this lady is not delivered in time, the mortality is very high to the tune of more than 30%. So it is an expeditious delivery, which is basically is the treatment after stabilizing the patient, which goes hand in hand, because it's seen that if there is a delay in diagnosis of more than 1 week, which is usually the case in cases of liver disorders in pregnancy, more so in acute fatty liver, that you take a lot of time in differentiating it with AFLP and the viral hepatitis, and then in that window only you may lose the patient, more so if the time they said if it is more than 1 week, the mortality is going to be really very high. So this much information, this brief information, you will only be able to basically pen down if you have read your acute fatty liver of pregnancy or any of the disorder very well. So because the time permitted will not be huge and you have to basically your pen down your words very precisely in your OSCE. And if you have put in your words very precisely, you will score very well. So we move on to the next question, which is you have to identify the specimen, and which I'm sure you are all able to identify the structures which are removed during the type 3 radical hysterectomy, indication of operation of the above procedure, and what is the stage 1B in cancer cervix. So if any of the figure is given to you in the exam, if you have identified that picture very well, almost 75%, I think you will be able to answer that, because it is, you know what it is, what you are talking about, and on which what you have to answer. So the specimen, of course, is very clear to you that it is a specimen of radical hysterectomy in a woman with CA cervix. You can see this is the uterus, this is the parametrium, this is the vaginal cup, and this is the cervix. In fact, it is mentioned also that the lesion size is 4 centimeters. So they have given quite a good clue as to what stage it is. That will be asked in the next part of the question. The other second question is the structures which are removed during the type 3 radical hysterectomy. So we all know that the radical hysterectomy type 1, 2, 3 we know that nowadays we are going about by the Kurlo-Maro classification of CA cervix, where it is classified the type of radical hysterectomies into type A, B, C, 1 and 2, and D. So the type 3, because it is being asked in the question, the structures which are removed in the type 3 radical hysterectomy. So it is synonymous to type C2 radical hysterectomy of this Moro classification, in which the structures or the classical mixed radical hysterectomy, the structures which are removed are just, I will enumerate this, read very carefully. First is you know very well, in case of CA cervix, in all the radical hysterectomy, there is a routine pelvic lymphadenectomy, which is the feature of all the radical hysterectomies. So what other structures? Just memorize that. Coming down from above, from the ureter, it is a complete dissection. Please mute yourself. Dr. Nikhil, could you please mute yourself? I can hear you. So it is a complete dissection of ureter from the pubovesical ligament to entry into the bladder. However, the superior vesical artery is conserved. Second is the uterine vessels. They are divided at the origin from the internal iliac artery. Third is the uterosacral ligaments, which are resected at their sacral attachments. Fourth is the cardinal ligaments, which are resected at the pelvic wall, and upper half of the vagina is removed, besides a routine pelvic lymphadenectomy, which are the structures which are removed in type 3 radical hysterectomy, and which are the structures which are removed here in this specimen as well. So next question was 3, indication of operation for above procedure. So when a CA cervix is operable, it is operable, we know that till stage 2A1, that limit you should know, and 1B1 is the CA cervix which we operate with the radical hysterectomy. So 1B1, 1B2 and 2A1 are the basically indications for operation for this procedure of radical hysterectomy. I will just throw a brief light on this, that why so, because before I move on to the next part of the question, we go by the treatment options of CA cervix. It's better to refer to those NCCN guidelines, which are the most revised guidelines. In case of stage 1B1, type C radical hysterectomy plus pelvic lymphadenectomy is the answer. However, you are considering the EBRT and brachytherapy if the surgery is not possible. While in situation of 1B2 and 2A1, again type C radical hysterectomy and pelvic lymph node is the desired surgery if the patient is operable. However, if the patient is not operable, then a concurrent platinum-based chemoradiotherapy and brachytherapy also can be offered. While if it is 1B3, when that means if the lesion is more than or equal to 4 centimeter in maximum dimension, then or in 2A2, it is better to give a concurrent platinum-based chemoradiotherapy and brachytherapy and not to operate the patient. So with this, I move on to the next part, which is the part 4, which is what that is. The fourth question, what is stage 1B in cancer of the cervix? So as per the latest FIGO classification of CA cervix, which was revised in 2018, the CA cervix, you should all basically be knowing that classification. I will not go into the detail. However, I will tell you that please go through and make the charts of all the FIGO classifications of all the malignancies. In stage 1B, which is the question which is being asked to us, what is stage 1B in cancer of the cervix? In stage 1B, we know that the lesion is confined, the cancer is confined to the cervix. So 1B1 is when the spread is the stromal spread is more than 5 millimeter in depth, but it is limited to the cervix, is 1B1 as per the latest FIGO staging. 1B2 invasive carcinoma is if it is more than 5 millimeter but less than 2 centimeter. Okay. Then 1B3 is when it is like more than or equal to 4 centimeter is 1B3. So 1B is classified as into 1B1, 1B2, 1B3, which they want you to mention, which is this question is asking. So with this, we move further to the next part, which is next question 3. Identify the figure and diagnosis. Just take some time to basically see that what it is, what this figure is showing. Explain the findings of this image. What is the normal range of HbA2? And it's saying, asking you the Menzer index for severity of the condition and describe. So what it is. I hope you have seen this figure very carefully. It is definitely a graph which is written HbF, HbA2 with some peaking of 8.4% and 4.9%. So the figure is, this is a figure of basically this is chromatogram, or what we say as the HPLC technique, basically, which is a test which is being done to diagnose thalassemias. It is not only thalassemia minor, it is this HPLC is used to diagnose thalassemias as well as hemoglobinopathies. And it is a very important test. You have dilemma in your mind that you are dealing with a case of iron deficiency anemia or a HPLC. So basically, this is a chromatogram, as I said, which is showing two peaks of HbF and HbA2. Just a brief word or a few lines about what this chromatogram is. This is a figure of high performance liquid chromatography. While the chromatogram, this is a technique which is used to separate the different constituents of a compound or a mixture using a high pressure to push solvents through the column. And it is most widely used technique to identify, quantify, and separate components of a mixture or a compound. And this is how these different, the different type of thalassemias are diagnosed. So this is one of the techniques to diagnose, to have an accurate diagnosis of hemoglobinopathies and thalassemias. This you must know. So explain the findings of this image. The second question is, you can very well see it is a raised HbF and HbA2. You will only be able to differentiate this when you know the normal values of HbF and HbA2. So basically, the second part is it is showing a raised HbA2 and raised HbF. 4.9% and 8.4%. What was asked is, what is the normal range of HbA2 in question 3? And the answer is the normal range is somewhere between 1.9 to 3.5%. And if the value is more than 3.5%, then it is pathognomonic of HbA2, which is thalassemia minor. Other thing is range of normal HbF also should be known, that if it is more than more than 1.5%, then also it's considered to be elevated. You need to have the differentiating point that how much HbF and HbA2 should be elevated to basically diagnose a thalassemia major, a minor, or other variants of hemoglobinopathies and thalassemias, intermediate and all. However, this is not being asked. This is the added information I am giving you. So next question is, what is asked is, what is Menzer index and index for severity of the condition, and describe the index. So not always that you have the very clear-cut HPLC or the HPLC test in your hand. So, and not everywhere this facility is available. So there is an index which was being devised by Mentzers in 1973. And this is an index basically which differentiates iron deficiency anemia with beta thalassemias. So what this index is talking about, it is calculated as MCV, which is expressed in femtoliters, divided by RBC count, which is expressed in millions per microliter. And it is said if the result is more than 13, then iron deficiency anemia is the probable diagnosis. However, if the result is less than 13, likelihood of beta thalassemia is there. So basically, with this, I think I want to just finish this. Otherwise, you must know just this much basic information, that MCV, the normal range you should know, RBC normal values you should know. What happens in the iron deficiency anemia, that everything is decreased. MCV, MCH, MCHC, RBC's counts are also less. So the Menzer index will be more than 13. However, in case of beta thalassemias, The RBC count, because there is no suppression, RBC's count is not decreased. However, the MCVs, because the red cells are more fragile, the MCV volume is less. So the Menzer index is less than 13, and it is diagnostic of beta thalassemia. Next question is identify this picture. I'm sure you all will be able to identify, those who know the colposcopies, what the blue line indicates, define the transformation zone, how to identify the structure of transformation zone, types of TZ, percentage of acetic acid used in colposcopy, and if biopsy reports the CIN3, then what is the management? So we'll take it one by one. What is blue line? Blue line, you know, this is the blue line. What does it mean? This means a new squamocolumnar junction. So basically, I will just very briefly tell you about this picture. It's the colposcopic image of a cervix in which some acetic acid probably has been applied. And this is the outer limit of the transformation zone, and this is the inner limit where the blue line is of the transformation zone, which is the pneumocolumnar junction. This pinkish more reddish is the columnar epithelium, and this more whitish is the transformation zone. So what happens in the transformation zone is a zone of metaplasia, wherein the original columnar epithelium is replaced by the squamous epithelium. And when it does so, because in the columnar epithelium there are glandular openings and the crypts opening, and there are Nabothian follicles. Those get covered by the squamous epithelium, and all in the metaplasia you can see are the crypts opening. So these crypts openings, the outer limit of these crypts opening define basically the outer boundary of the transformation zone, which answers the next two part of this question. So I will just move down to the answer, that what is transformation zone is the area of the cervix which is covered by the metaplastic epithelium. It is the TZ. The inner or the proximal border of the TZ is the squamocolumnar junction, and the outer boundary of the junction, that is between the original and the metaplastic epithelium, is the outer limit of the transformation zone. So to identify the outer limit of the TZ, which is the part 3, the question which is asked, then you look for the crypts opening or the Nabothian cyst, which is situated farthest away from the squamocolumnar junction, and draw an imaginary line here. Okay. Next is the percentage of acetic acid which is being applied here. It is 3 to 5%. It is a standard. You all must know how to make this 3 to 5% of acetic acid. Next is, if this lesion there is a biopsy which is being taken from this lesion and it reports CIN3, what is the management? So for CIN3, the best management is through the excisional methods, so as to have more success rate, which is more than 90%. If you have done the LEAP or the LEDs, they both are synonymous to each other. LEAP is it's the American term, that is large loop excision of the transformation zone, or LEDs is the British term. Or you can do, if this facility, because they are the heated electrodes which are not available at all the places, heated diathermy, then you can do the conization, you can do the cold knife conization, or whatever. If the facility is more than that, you could do that. So these are the preferred excisional methods for CIN3. However, the WHO says that if you do not have any of these excisional method available to you, do not leave even a CIN3 untreated. Here you are not wrong, though they are less preferred with a less success rate, maybe 70%, 75% if you are doing a cryotherapy or thermoablation in a treatment of CIN3. So next is the last question for me. It is diagnosis. See these images very carefully. More than 75% you know that what you are talking about. This is the baby, this is the uterus, this is the decidua, this is the placenta, and there is a blood collected in this retroplacental area, which is seeping out here in the figure A and in figure 2. The blood is not seeping out, it is getting collected. So the diagnosis of condition A and B, predisposing factors, 2 maternal complications, 4 clinical signs and symptoms have been asked to you in this question. So you all know it is revealed abruption in figure A, concealed abruption in figure B, The two predisposing factors, there are many for abruption, could be smoking, cocaine use during pregnancy, maternal age over 35 years, presence of hypertensive disorders of pregnancy, or history of abruption in a prior pregnancy. So the two dreaded complications, there can be more than two, you can write down. They could be renal failure, DIC, massive PPH, shock. There can be many, multi-organ failure and all. So you have to write down two complications and the 4 clinical signs and symptoms, the common ones being the abdominal pain, vaginal bleeding, the presence of uterine contractions and uterine tenderness. So now with this, I hand over to Dr. Geeta for her next case 6.
Thank you, Dr. Mamta. So without further ado, students, I continue. And as Dr. Mamta has said, you will get very targeted questions. Just next to the question in your flash, you will see 0.5 marks or 1 mark or 3 marks. So this, as Dr. Mamta said, you can really score well. So I have this question. This will be flashed on your screen. You please look at it carefully. Question will be asked that this is a 33-year-old primigravida who's 12 weeks, 2 days gestation. She has come to your antenatal OPD with an early anomaly scan report with NT at 96 centile, and her combined screen was suggestive of a trisomy 21 risk of 1 in 202. Now, you should know in the back of your mind that a girl who's about, 30 years old has a 1 in 1,000 risk of trisomy 21. At 35, it's roughly around 1 in 400. So here she's having a 1 in 202, so that's a high risk. So there are questions there are as name any two. So this will be a 1 mark question, half a mark for each. So very pointed question answers should be done as Mamta has told you. So any 2 fetal medicine foundation criteria for the measure of nuchal thickness. So you should know the fetal, there are about 10 criteria. I'll enumerate most of them, but you have to write only 2. So here in this case, the criteria for measurement are that the fetus should be in a neutral position with the head in the line with the spine. Neck should be in the neutral position, because if it is hyperextended, you can have a high NT. If it is flexed, you can have a low NT. Then second, you must distinguish between the fetal skin and the amnion. You must measure the widest part of the translucency, and you should take it with the caliper which is placed on the line that defines the nuchal translucency thickness. The crossbar of the caliper should be such that it is hardly visible and it should merge with the white line of the border. And during the scan, you should take more than 1 measurement must be taken, and the maximum one that meets all the criteria should be recorded. So you must remember that this should be a mid-sagittal view of the face, as you can see in this. And how do you know this is a mid-sagittal and not a parasag? You should see the tip of the nose, the rectangular shape of the palate anteriorly, as you can see the palate and the tip of the nose in this, and the translucent diencephalon in the center, and the nuchal membrane posteriorly, as is seen in this picture. Then the CRL should be between 45 and 84. Anything below or above, she doesn't qualify for a NT-NP scan. And the gestation is usually between 11 to 13 weeks. And sometimes you might have a cord around the neck in these cases. So in that case, you should know it can produce a falsely increased NT. So in such cases, what you should do is you measure the NT below and above the cord at different levels and calculate the risk. Next slide. So the question they have asked is name any 4 structures visible in the mid-sagittal view of the fetal face during early anomaly scan while measuring the nuchal translucency. So Mamta, can you project that picture of the 4 structures? Yes, just like that. So these are the 4 structures which you are visible, as you can very jolly well see in this case. At the mid-sagittal plane, you can see the nasal bone in front. Mamta, if you have the caliper, you can just show that NB, which is written nasal bone, the front part. Yes. So nasal bone, the nuchal translucency is right at the back, the NT. Then the thalamus, that is seen. The midbrain is seen just below that. And then you have the brainstem, midbrain, brainstem. And then you see the IT, that is the intracranial translucency. This is the area between the brainstem and the cisterna magna. So the answer to this question is that you can see these, any of these four structures you name, and this is what you see in the mid-sagittal plane. Now, the next part of the question said, what are the other anomalous conditions associated with increased nuchal translucency? So, you know, there are so many conditions apart from trisomy 21 and 18. So you can have major cardiac defects, diaphragmatic hernia, exome loss, body stalk anomalies, skeletal defects, genetic syndromes, you know, like congenital adrenal hyperplasia, fetal akinesia, deformation sequence, Noonan, and SLO. So you can answer any because you have been asked other. So they haven't mentioned, usually they mention two other anomalous or three, and accordingly the marks are given. So the next part of the question is, what will you do now? What is the further investigation now? At the 96th centile, if you have, then obviously double marker is a no-go. You have to counsel that between NIPS and an invasive test. So this counseling must be done very carefully by the genetics people or the fetal medicine department. But this is a half a mark question. You can just write NIPS versus invasive testing after counseling. That's all. Next question, Mamta. So this is a lady who's para 3, 50 years female. She has presented to you with frequency and urgency. And you have apparently ruled out a UTI, that is must. You must do that. Then what investigation is done? What do the readings signify? Mention 2 characteristics and write 4 parameters obtained from the graph. And if there are 2 or more lower peaks with prolonged tails, what does it mean? So to answer the first question, this is basically a uroflowmetry. And the reading, the investigation done is the uroflowmetry. The reading signify the 2 characteristics. The x-axis shows you the time, and the y-axis shows you the flow rate in milliliters per second. So you can write that. Then what are the 4 parameters you get from the graph? So if you see that graph, Mamta, can you go back? So the graph will show you the peak flow rate, the mean flow rate, the time taken to void, and the voided volume. These are the 4 parameters you can obtain from this graph. Now they have asked, supposing the woman has a lower peaks with prolonged tails, usually this is a case of bladder outlet obstruction with hesitancy. So if you just write that, you get your 5 marks. Next question. Now they will show you this picture, and a patient is 16-year-old female. She has presented with primary amenorrhea and with good breast development. Now study the karyogram very carefully. As you can see, there is a pair of chromosomes all around, but if you see, there is an XY chromosome. So it's a 46XY, but the patient scenario is of a 16-year-old female who has come with breast developed and a primary amenorrhea. So that should click in your mind, and your diagnosis is now, because this is a genetic male with a phenotypic male, so it's a very obvious case of testicular. So the diagnosis, half a mark. Testicular feminization syndrome, also called complete androgen insensitivity syndrome. The next question they've asked you is give 2 differential diagnoses. So the 2 differential diagnoses, you can have, basically, you can have a tetragametic chimerism, even Klinefelter's or a Turner mosaic, mixed gonadal dyssynergia. These are of the various differential diagnoses. The next question they have asked is, can this woman become virilized? Now, just to give you a background, testicular feminization is when a male, a genetic male, because of the various abnormalities of the X chromosome, is resistant to the actions of the androgen hormone. So if they are resistant to androgenic hormones, obviously the male genitalia and the masculinization features will be absent until by default all fetuses are female. So to answer that question, this woman rarely cannot get virilized, right? Now, the next question is, can this be a threat to her life? Usually, this is not a threat to her life unless they develop a malignancy in the dysgenetic gonad. That is why the answer is no. But you can write in paragraph, in a parenthesis, that if they do not remove the dysgenetic gonads, they can become malignant. Then 2 other investigation to confirm the diagnosis. You can do a pelvic CT to reveal that there is no uterus, ovaries, or there's a hypoplastic vagina. And you can also locate the testes, which can be either in the inguinal ligament or sometimes in the labia or in the intra-abdominal space. Next slide, please. So basically, next, yeah. So basically, as OSCE says that you will have this structured clinical examination. No, so it is almost like a practical exam where they show you things, spots, case scenarios, specimen pictures, and ask you relevant questions. So now this question, there is this tablet will be shown to you, and they will give you a case scenario, a primary gravida, 28 weeks, presented in OPD with a BP of 142/90. She was started on the following drug by the obstetrician. So simple question, identify the drug, just answer labetalol. The next question they can ask anything, but I am just giving you these scenarios. So what is the mechanism of action? So the mechanism of action, you know very well that it is a beta, it acts by blocking the beta adrenergic receptors in the body, basically beta 1 and beta 2 receptors blockage, which is leading to reduced heart rate, decreased force of contraction, dilatation of blood vessels, and thereby lowering the blood pressure. And it also provides a selective alpha 1 receptor blockade. So basically alpha beta receptor, with alpha receptor blockade being selective, beta 1, beta 2 is a non-selective blockade. And second thing to remember about labetalol when you prescribe is that the potency of the beta blocker is 5 to 10-fold greater than the alpha adrenergic blockade. And it also has a partial beta 2 agonist effect, so that promotes vasodilation. So this together leads to a drop in the blood pressure. So next question they asked was, 2 contraindications for this drug would be in bronchial asthma or overt cardiac failure or heart block, cardiogenic shock, bradycardia, and conditions associated with severe and prolonged hypotension, and in patients with a history of hypersensitivity to any of the products. So since they have asked you 2 contraindications, you can write asthma and heart block, or asthma and cardiac failure, because these are the major ones which you don't give. Now coming to the onset of action of this drug. Now if you give an IV, a labetalol, it acts within 5 to 15 minutes and lasts for 4 to 6 hours. Tablet starts working in 2 hours, and usually you give it 8 hourly. And another question, the last question they had asked was, name another alternative drug. You can give hydralazine, which is a direct vasodilator, which is used orally to treat essential hypertension, and also intravenously to rapidly reduce blood pressure in an hypertensive emergency. So as you can see, your questions should be very directed. We have given you full answers, like Dr. Mamta gave you, all the criteria. You were asked 2 criteria. Like I asked Fetal Medicine Foundation 4 criteria, but you write only 2, but we are just telling you can write any of these, right? So next is again a specimen, which we will be flashed on your screen. Just study this specimen. As you can see, this is an opened up uterus, and the right hand is on the top of the fundus, and the left hand is actually peeling the placenta. As you can see, the placenta has this attachments to the uterus. It's almost attached to the uterus. So the question background is, it's a 33-year-old lady. She's a 6th gravida, para 2, abortion 3. At 36 weeks of pregnancy, she has come with history of 2 previous cesarean and history of 3 dilatation and evacuation. That was done, maybe she had an MTP at 8 to 10 weeks. She came to your emergency casualty with a complaint of bleeding PV, APH, and emergency operation was performed. So this is the specimen of that operation. So the question is, it may be half a mark question. What is seen in the picture? So you simply write, this is a specimen of cesarean, post-cesarean hysterectomy showing accreta, increta. You can write both because you don't have a microscope in your eyes. So whether it is accreta, increta, that the pathologist will decide. Then they are asking you, what are the criteria, 3 predisposing conditions for this condition? So you can write previous cesarean, previous DNCs, previous placenta previa, age more than 35, or previous history of synechiolisis. Any of these, they have asked you for 3. So this will be probably 1.5 marks question. Third part is, what is the fear of this condition? The fear of this condition, as we all know, the PGs know very well, it's massive obstetric hemorrhage, shock, sepsis, which in turn can lead to acute kidney injury, maternal mortality, and having a ventilatory support, etc. Right? Then the next question is, what is the standard treatment, which is already been done? You can see very well, cesarean hysterectomy. Just write that and you'll get half a mark. Then the next question they asked is, what complication may occur while performing? Now, previous question was, what is the fear? After doing this operation, what all can happen? But here they have asked, while you are doing this operation, so name, usually they write 2 complications. So you can write massive blood loss, you can write injury to bladder, supposing it is a percreta invading the bladder, there will be injury to the bladder, injury to the bowel can occur, a broad ligament hematoma can occur during, this is all operation, during operation. The patient can go into shock during operation. She needs to be on, NORAD support. You can need to have irreversible shock also, and rarely you can have a ureteric injury also. So if you are asked 2, you write 2. If you write 3, I have enumerated all. Main thing is Dr. Mamta has told you is read the question carefully. Don't answer tangentially, because when we mark your papers, we are looking for these answers. If we find them, you get the mark. If we don't find these answers, you don't get the marks, right? So thank you, Mamta, for flashing my slides. Thank you so much. I hand over to Dr. Sharmistha for her part of the OSCE.
Thank you, Geeta. I'll take it over from here. Now, good morning, dear students. In this question, a picture has been flashed. You need to identify the anomaly in that. If you can see, it's a membrane over there, and a cord is arising from that membrane. The cord is inserted at the membrane. So please identify the anomaly. The second question is, how is the shown condition diagnosed prenatally? How do we diagnose this condition? Somebody has rightly answered, it's a velamentous insertion of cord. So the anomaly is a velamentous insertion of the cord. So 1 mark is given for this. Now the second part is this anomaly, how early we can diagnose it. So the answer is we can diagnose it earliest at the 2nd trimester scan, because the 1st trimester, the placenta is not very clearly seen with the vessels going with the cervix. The 2nd trimester, the fetus is quite low with a lot of liquor amni, so it can be very well diagnosed during the 2nd trimester. Now the third part of the question is, how is the definitive diagnosis made? It's only on the gross examination and when we send the placenta for the histopathology. Can we go back to the previous slide? How is the definitive diagnosis made? So diagnosis is made when we see the placenta on gross examination, as well as when we send the placenta for a histopathological examination. That's how the definitive diagnosis is made. The fourth question here is, list 4 complications associated with this placenta. As we know, when the cord is inserted over the membrane, these membrane can lie over the internal os. It can cross over the cervix. So when there is membrane rupture, what it can cause? It can cause bleeding. So that bleeding usually occurs from the fetal side. That condition is called as vasa previa. And when the vessels, they bleed, it usually leads to fetal anemia. So it endangers the life of the fetus. And what are the other complications that can arise because of these conditions are preterm birth, placental abruption, or a fetal growth retardation. So it's even though rare cause of APH or antepartum hemorrhage that occurs in antenatal period. So the most common are the placenta previa, abruption, and the third commonest cause is a vasa previa arising from a velamentous insertion of the cord. Now coming to the next question. Here a case scenario is given where a 27-year-old lady with a history of normal delivery, which happened 10 months back, she was not using any other contraception methods. She missed her periods and she took a over-the-counter MTP pills, which is very common in our Indian scenario. And she gave a history of 2 months amenorrhea, after which she took an MTP pill. She kept on bleeding for 20 days and then she was admitted to obstetric emergency with, now she's giving a very typical history of fever, 101 degree Fahrenheit for 2 days, with a tachycardia, pulse of 112 per minute, and a low blood pressure of 80 by 50 mm Hg. So what is the diagnosis? It's a very common scenarios we are getting in our casualty. So what is the diagnosis? It's a septic shock, secondary to a septic abortion. So now the second question in this part is, what is the mean arterial pressure? and mention the formula for calculating the mean arterial pressure. So mean arterial pressure is defined as the average arterial pressure throughout the one cardiac cycle that lasts for about 0.8 seconds throughout the cardiac cycle through the systole and the diastole. How do we calculate the mean arterial pressure? It's 1/3 of systolic pressure when it's added to 2/3 of diastolic pressure. That's how we calculate a mean arterial pressure. So at all costs, it should be more than 60 mm of Hg. Now the third part of question is we have been shown two fluids over there. So one is a ringer lactate and another one is a normal saline. We all know fluids are divided into crystalloids or colloids. In the crystalloids, which is very similar to the natural composition of our serum or our body fluid, it has to be a balanced one or a unbalanced one. In most of the scenarios, we are giving normal saline for such situation because it has got 0.9% sodium chloride. But we must know a very serious side effect of this normal saline is hyperchloremia. So ideally, if available for the initial resuscitation period, we should be giving a balanced crystalloid, and it comes in the name of ringer lactate. Patient with sepsis should be induced hypoperfusion or septic shock. It is advised to give at least 30 ml per kg of IV crystalloid in the first 3 hours of resuscitation. And after the resuscitation, the initial resuscitation has been done. When we know the oxygen pressure has risen over 70%, the CVP is somewhere between 8 to 12 mm Hg, and the mean arterial pressure is more than 65. And when the urine output is well maintained to about 30 ml per hour, or roughly it's 0.5 ml per kg per hour, then you know that yes, the initial resuscitation has been done, the patient is stabilized. Then we can go for the volume expanders. So the lesson learned is in the initial 3 hours, the volume expanders are not to be given. You need to give the crystalloids first. And once the mean arterial pressure is very much above the 60 or 65, then we can give the volume expanders or the plasma expanders, which comes in the name of HES or starch or albumin. So these can be given after that. Now the fourth question in this part is name any 2 medications that has to be given when the patient is coming with shock. So one, we are giving the fluid for the resuscitation. Apart from that, the patient might need inotropes, which noradrenaline or dopamine can be given. Apart from that, we need to give some broad spectrum antibiotics for a broad spectrum coverage. And we can also give steroids when the patient is stabilized. So when the question is asked, name any 2 drugs, so it has to be inotropes and broad spectrum antibiotics. Now coming to the fifth part of this question, which asked us, how do we assess the response to initial infusion of IV fluid? So as I told you, after 3 hours after the initial resuscitation, we need to measure the oxygen pressure, which should be more than 70%. The central venous pressure has to be 8 to 12 millimeter of Hg. The mean arterial pressure has to be more than 65 mm Hg, and the urine output has to be maintained at the rate of 0.5 ml per kg per hour. That's how we know that the initial assessment resuscitation has been done, and then we can give expanders and we can keep the patient on maintenance. Next question, please, ma'am. Now, in the next question, an 3D ultrasound photograph has been provided. So we need to identify the pathology and give one differential diagnosis. So what do we see here? So Dr. Preeti is the only one who is answering all the questions. I think the rest of the PGs are not even interested. So Dr. Preeti, if we can see, this is a picture of a bicornuate uterus. Okay. Now, one differential diagnosis. Yes, they have asked for one differential diagnosis. So yes, it can be a separate uterus. And another differential diagnosis really can be an arcuate uterus, but doesn't look like arcuate uterus, or it can be uterus diadelphys. So these are the differential diagnoses. Now, the next question which is asked is, what are the complications? So what are the complications with the bicornuate uterus when the lady gets pregnant? These are the risk of preterm birth, fetal growth restriction, or a retained placenta. How do we diagnose such condition? A good 3D ultrasound can help us diagnose these Mullerian anomalies. A hysterosalpingogram, 55% cases can be diagnosed on hysterosalpingogram, yes. And when we see the MRI, so we need to measure the angle between these two cornules. If the angle is more than 105 degrees, so it has to be a bicornuate uterus. If it is less than that, then yes, it can be a separate uterus, something. And if you ask for the gold standard, then it's laparoscopy plus hysteroscopy. When we see on a laparoscopy supplemented with a hysteroscopy, that gives us a gold standard diagnosis for bicornuate uterus or a separate uterus. The last part of the question is which two organ systems are involved in such condition. So along with Mullerian anomalies, we see urinary system, that's the genitourinary system, and the skeletal systems are most commonly involved in such anomalies. Next question, please, ma'am. Now, again, a picture has been flashed where a 26-year-old sexually active woman, she presents with a recent onset of white, milky, non-viscous, adherent vaginal discharge. So please read carefully. It's a white, milky, non-viscous, adherent vaginal discharge with minimal vulval irritation or pruritus, minimal vulval irritation. So on wet smear and microscopic examination of the secretion, this kind of picture is seen. So what is the diagnosis? So Dr. Nikita Sharma has diagnosed it correctly. This is a picture of bacterial vaginosis. So as we rightly know, the diagnosis of bacterial vaginosis is made most commonly on clinical examination or clinical inspection. And the criteria which we use is Amsel's criteria. In the Amsel's criteria, 4 criteria are given, and out of which 3 should be there to make the diagnosis of bacterial vaginosis. It has to be a homogeneous thin discharge, very clearly mentioned in our question also. It has to be a homogeneous thin discharge. Then there has to be clue cells. What are these clue cells which we are seeing on the picture? These are vaginal epithelial cells. When they are studded with bacteria, they give us this picture of the striated appearance of that cell, and that is very typical of bacterial vaginosis. These are called clue cells, and they are seen on wet mount preparation also on the macroscopic examination. As we know, the normal pH of vaginal fluid is somewhere between 3.8 to 4.5. So we can measure it on a litmus paper. If the pH is more than 4.5, it becomes one of the criteria for diagnosis of BV. And there is fishy odor of vaginal discharge when we add 10% of KOH. So that test is called as Whiff test. So out of the 4, if the 3 criteria are there, we diagnose it as bacterial vaginosis. The second question is, what are the common organisms causing BV? As we know, bacterial vaginosis is mainly an imbalance of the good bacteria and the bad bacteria. So what are the normal bacteria forming the microbiota of the vagina? They are mainly the lactobacillus species. There are more than 20 species of lactobacillus. They are mainly gram-positive rods, also known as the Dodelines bacilli. So they are the normal microbiota of the vagina. But when these anaerobic organisms like Gardnerella vaginalis, Prevotella, Mobilincus, when they are predominating, so that they become bacterial vaginosis. They are the cause of bacterial vaginosis. What are the differential diagnosis of such condition? It's mainly a vaginal candidiasis, trichomoniasis, or an HSV. Sometimes it replicates the findings of bacterial vaginosis. But in candida, we all know that the itching is very prominent. There is curdy discharge. The woman itches herself so much that there are scratch marks or there is bleeding from the vagina. So that's not the case with bacterial vaginosis. Trichomoniasis, a very gray, thin odor is there. And in HSV, you will find lesions also. So that's how you diagnose. These are the 3 conditions. What is a confirmatory diagnostic lab? In the labs, they're using the Nugent scoring for grading all the bacteria, and their score is given for confirmatory diagnosis of this test in the lab. Now the next question. Now, please look at the picture on the left upper part. A 30-year-old woman, she is 4th gravida, P3. She delivered a 4 kg baby, and it was forceps assisted delivery. She went into shock. She went into hemorrhagic shock soon after delivery, and the abdomen was opened in OT for a traumatic PPH. Her uterine artery was lost. There's a very common scenario. The uterine artery is lost in some massive broad ligament hematoma. If you can see, there is a hematoma on the lower part of the uterus. That's a broad ligament hematoma. And we don't know where exactly the uterine artery is. So below shown was the operation performed. So what is the name of the operation shown? So whenever we have a traumatic PPH and we are suspecting a pelvic hematoma or a pelvic hemorrhage, what we do, it's an exploratory laparotomy. There's an exploratory laparotomy. How does the operation help in controlling the bleeding? As we know, the internal iliac artery, that's a major supplier of the blood supply to the pelvis. So we have the anterior division and the posterior division. So what we do, we have to devascularize the uterine circulation. So as we cannot see the uterine artery here, so we have to go till the origin. That's the anterior division of the internal iliac artery. So you must know the branches of the internal iliac artery. It has got an anterior division and it has got a posterior division. The branches of the anterior divisions, we all know it's an umbilical artery, which later on gives the uterine artery and the vaginal artery. Then we have the superior vesical, middle rectal, inferior gluteal, internal pudendal, and the obturator artery. So we need to identify the umbilical artery that is 2 centimeters below the bifurcation of the common iliac vessels at the level of the sacroiliac joint. And then we need to identify that and we need to ligate that. Now, again, there is a shown a photograph of a forceps. What exactly that forceps is? That is called as the mixed right angle forceps. And how do we introduce it? For ligation of the interiliac artery, we need to pass it laterally to medially for the ligation. And the suture material, the third question that asked is a suture material. The material we are using is silk 10, and in many settings we are using Vicryl also, 10 or 1 number. And the last part of this question which is asked is, what are the complications that can happen? As I told you, there's a major supplier of the vessel to the pelvis. What are the complications that can happen if we ligate that artery, or if we mistake the ureter as the interiliac artery? So it can cause ureteric injury. In young girls, yes, it can cause infertility, or if you're ligating the superior vesical artery, it can cause a bladder gangrene. And in some cases, we have seen the gangrene of the gluteal area also, if we have falsely ligated the gluteal artery. So these are the common complication, the vascular complication of interiliac artery ligation. And the last picture, if we see, ma'am, can we go back to the previous slide? Yeah. So if we see, since I don't have the pointer, there's a bifurcation have been shown. The ureter has been dissected, and we have taken the, yes. And then we have taken the interiliac artery at this point. Yes, where this blue thread they have marked, this is how we have taken it. So that completes our question. The name of the operation is exploratory laparotomy with interiliac artery ligation. How does the operation help in control bleeding? By devascularizing the uterine circulation. The suture material used is silk 10. The forceps is mixed right angle forceps, and the complications are infertility, ureteric injury, or a bladder gangrene. Thank you, Mamta ma'am, Geeta ma'am. Any questions from the postgraduates?
So basically, yeah, that finishes our OSCEs well in time. This is what we expect you to be very precise and very concise and to be in time when you are basically answering your OSCE examination. If we are any questions still left with, we are happy to take it. Otherwise, we can move further.
Only Preeti and Nikita have answered, ma'am.
Yes, now if I see the
Thank
chat
you.
box, yeah, they are
Thank you.
many.
Let it be a eye opener for the PGs that this is how you have to answer. Basically, our aim was to tell the PGs the type of questions which are asked, what is expected of them, and how to answer very methodically and to the point, and not go at a tangent. I think we have succeeded. Thank you, Dr. Mamta and Dr. Sharmistha. I think we have succeeded. I hope the PGs, you have understood that what is expected in the OSCE. This is a very scoring 150 marker. So you can practically pass your exam if you answer all of them.
And it is not like that these questions are more or the answers for more. This is exactly the replica of what you are going to be asked. Bilkul true image of what you will be, I mean, the way your OSCE is going to be finally. Thank you.
Right. Thank you. Thank you, organizers. Thank you.
Thanks for the
Thank you
opportunity.
so much, Geeta ma'am, Mamta ma'am, and Sharmistha ma'am for such a wonderful insight into the OSCE structure family. And now I'd like to invite Dr. Arun Arora, sir, for a session on the dummy pelvis. Dr. Arun Arora has been ex-HOD GMC Udhampur, is visiting professor ICOG and member Quality Assurance Committee of the Union Territory of J&K. Sir, please, if you can just start the session.
Am I audible?
Yes, sir. Yes, sir. You're audible. And with a lovely background for this wonderful Sunday.
Okay. Thank you very much for organizers. Hello, good morning, friends. I'm sharing my screen. Is it visible now? Hello.
Yes, sir. Yes,
Yeah,
sir.
we can
Please
see.
go ahead.
Yes, sir, visible.
Thank you so much. Friends, today I'm going to take you through a journey which is one of the most difficult journeys, no? Although it is just a 4 inches or 10 centimeters of journey, but once you have passed through this journey, then you can pass through any journey of your life. So this post-graduation which you are doing is just a very small journey. So you will always pass through this journey once you have passed through this 10 centimeters of journey. So coming on to the part which we are going to discuss. So first is the passenger who wants to go through the journey. And for that matter, the first thing, important thing which has to pass through that journey or the tunnel, what we call as, is a fetal skull. So we should know what are the what is the size of that fetal skull and what are the parameters of that fetal skull, right? So this is a side view of a fetal skull. It is basically divided into two parts. This is the line which divides. So this is the green color is the base, and this blue color is what is called as the vault. So this base is usually rigid and incompressible, whereas this vault is compressible because it has gaps in between, which we call them as sutures, right? One second. Okay, now this part, the root of the neck is called as the glabella. From here up to the anterior fontanelle, this is of anterior fontanelle, and this is a posterior fontanelle. From glabella to the anterior fontanelle is called as sinciput, which you always hear about sinciput and occiput. This is the sinciput part. This whole part is the sinciput, and from posterior fontanelle down below is a occiput, right? So this is occipital bone. This is a coronal suture. We'll come to these sutures again in the next slide. So this, and on this parietal bone, we have this a mark, what we call as a parietal eminence. This is just a slight protuberance on both sides of the parietal bones, right? Now coming on to the sutures, now these are the frontal bones, two frontal bones in blue color. These are the two parietal bones, and this is the occipital bone here. Between the two frontal bones is what we call as a frontal suture or the metopic suture, right? Now this is the anterior fontanelle. This is a diamond-shaped gap, and between the frontal suture and the parietal suture is a coronal suture. This was the coronal suture on the side view, okay? And between the anterior fontanelle and the posterior fontanelle, we have a sagittal suture, which sagittal means which goes, this like this. And between the parietal bone and the occipital bone, we have a lambdoid suture. So we have two lambdoid sutures, two coronal sutures, one sagittal suture, and one frontal suture. Basically, what sutures does is God has given us this privilege that your head has to, or the baby's brain has to grow. So once they fix that, suppose both the bones are, all these bones are fixed together, so you don't have a space for the brain to grow. So they have given a temporary, something like a gap. So later on, after the birth, when your brain grows by say 18 months or so, so then these sutures, they ossify and they join together, right? And how does this help? The sutures helps. One, they permit gliding movement during molding, and secondly, they help us when we do a parvaginum examination during labor. They help us in finding out the engagement of the head or degree of internal rotation depending on the location of the sutures, right? Now coming on to again, we have this is anterior fontanelle. I keep on repeating these things because these landmarks are very important. This is what examiner always is interested in asking you. So he will ask you about the fontanelles, how many fontanelles are there. So we have an anterior fontanelle. This is a sphenoid fontanelle, okay? This is a parietal bone. This is what I told you was a parietal eminence. And this is a lambdoid suture. This is a mastoid fontanelle. This is a squamous suture. This usually we forget these things. This is a squamous suture between a parietal bone and temporal bone. All right. And in front of the temporal bone, we have a sphenoid bone and zygomatic bone. And the suture here is a sphenoid and the fontanelle here is a sphenoid fontanelle. All right. So this is a nasal bone. This is maxilla. Now, this area from glabella to this is a this area which presents in the bro presentation. We'll come to this later on also. And this is the area which comes in face presentation. And this is the vertex. This area is the vertex. When we say vertex presentation, this is the area which is presenting. All right. Now coming on to the diameters of the skull. Again, these diameters are important because these are the diameters which have to pass through that journey through that tunnel of what we call as a pelvis. So the most important we always hear is a suboccipitobregmatic. All right. So this red color is a suboccipitobregmatic because the most common presentation, say if we call as a vertex presentation. So this is the diameter which is the engaging diameter. All right. Then we have other what we call a submentobregmatic diameter. Then we have a occipitofrontal diameter. And this suboccipitobregmatic we have in vertex. Suboccipitofrontal is a, so from here to here is a, this is a suboccipital frontal. All right. So this again we have, when we have an incomplete flexion of the head, this diameter presents, or this is the engaging diameter. All right. Then we have an occipitofrontal. This occipitofrontal is when there is a marked deflection. All right. And then we have a mentovertical. All right. Now this is a mento. From mentum to vertex is a mentovertical. And then we have a submentovertical. From submentum or the from here to is the the vertex is a submentovertical. So you have to remember the dimensions of these diameters because this is what examiner is interested. Suboccipitobregmatic is 9.5 centimeters. Suboccipitofrontal is 10 centimeters. Suboccipitofrontal is 11.5. Mentovertical is 13.5 or some books write 14. So this is the longest diameter which you have to remember. Many times they ask what is the which is the longest diameter. So always have it is a mentovertical. These are AP diameters. I'll come to transverse diameters also. So this is the longest AP diameter is a mentovertical diameter. All right. Then is a submentovertical, which we have in face presentation, and this is also face presentation, and we have a complete face presentation, and they're just slight modifications. No, if we have a submentobregmatic, it's a face presentation, it is 9.5 centimeters. But if the extension is slightly less, then probably the submentovertical diameter comes into picture, and it is 11.5 centimeters. All right. Now, again, reiterating the same story. Once we have a well-flexed head, it's a 9.5 centimeter suboccipitobregmatic diameter, and the presenting denominator is a occiput. In a less flexed head, we have a occipitofrontal diameter, which is 11 to 12 centimeters, and again the denominator is occiput. Whereas in bro presentation, I told you it is a mentovertical, which is 13.5 or 14 centimeters. And the presenting denominator is frontal. All right. And in the face presentation, again, we have a submentobregmatic, which is a small diameter. So many times, babies who are in complete face presentation, they deliver normally, right? But here, this bro presentation, we do not have any diameter in the pelvis, which is 13.5 or 14 centimeters. So for when there is a bro presentation, babies never deliver vaginally. It has to be a cesarean section. All right. Now coming on to where these movements happen. So say this is a head, right? So this is, say, baby's head. Now this is the spine. This is the spine. So somewhere here is your flexion point. This is what I have mentioned here. It is roughly 3 centimeters in front of the posterior fontanelle. So all movements occur, all anterior posterior movements or extension flexion movements occur at this point. So if it is anteriorly moving, it's called as flexion. If it is posteriorly, it is called as extension, right? So these are shown here. And we can have side movements also. One can ask, what are the side movements? Like this head can turn here also, no? On sideways. That is what we call as asyncretism. We'll come to that again in the ensuing discussion. So because when baby is trying to pass through that pelvis, he will go through a diameter which is he finds comfortable for him to pass through. So he can move anteriorly like these movements, or they can move sideways also, right? So these are the movements which have been shown. This is flexion, this is extension, this is a pro presentation, this is a a vertex presentation. Now coming on to the diameters, transverse diameters, we have a biparietal diameter between the two parietal eminences. This is 9.5 centimeters, and bitemporal diameter, which is 8 centimeters. And then we have a 2 between the two mastoid processes, which is 7.5 centimeters, right? And the question comes is, which is a smallest diameter? Smallest diameter is 7.5 centimeters, which is a bimastoid. But many times, if you do not have this option, then bitemporal becomes the smallest diameter. And the AP diameter, which I told you was the longest, was a mentovertical. All right. So this is the longest AP diameter, mentovertical. This is in bro presentation. So vaginal delivery is not possible. Smallest diameter is a bimastoid, which is 7.5 centimeters. Now this is what I was talking of, asyncretism. So normally this is a biparietal diameter, which is the engaging diameter. Suppose you don't find a baby doesn't find a space, he just slightly turns his head towards the side. This diameter, which is 9.5 or even sometimes 8.5 also, depending on the degree of the baby turns to. This is called as a suprasubparietal diameter. All right. Suprasubparietal or suprasubparietal diameter. All right. So this is asyncretism. It can be anteriorly also, it can be posteriorly also, depending on the space which the baby finds in the pelvis. Now, what is molding? Basically, molding is an alteration of the shape of the forthcoming head while passing through the resistant birth passage during labor. So what basically happens is, again, the baby tries, when you find any moldable thing like head is, we have sutures in between, it has a space in between. When it passes through any resistant passage, like say the pelvis, then there is some amount of movement of the bones against each other. So this is what we call as, basically it is a 4 millimeter alteration. And this is the mechanism is there is a compression of engaging diameter with elongation of the diameter at right angles to it, right? I'll show you this picture, right? So see this picture. So the engaging diameter is, so here the engaging diameter is this one, right? And the molding is occurring at this diameter. All right. So this is a perpendicular to the engaging diameter. Now, depending on the resistance, this can be of different grades. All right. Normally, it is a 4 millimeter commonly. But if bones are separated and sutures are felt separately, this is a 0 grading. If it is sutures are opposed, it is 1 plus. If sutures are overlapped, but they are reducible but with your finger, this is 2 plus. And if it is 3, means if it is overlapping, but that is not reducible with your fingers, this is 3 plus molding. Anything more than 3 plus molding, it can be a trouble because it may lead to tears in the dura mater, or there may be some vessel tearing down. Basically, in these molding, usually usually the parietal bones tend to overlap all the other bones. Not that occipital bone will overlap the parietal bone. No, it is usually the parietal bone which is overlapping all other bones. This one slide which I am really interested is, so this is say your biparietal diameter. All right, suppose no, this is not exactly this picture. From here to the other side, if we say this is your biparietal diameter, which is engaging diameter. All right. So what we always tell is, once you find it on PV examination, you find the denominator at 0 station, we always think that engagement has occurred. What does this mean? See, if I can show you this, if you can see this picture. So this is a biparietal diameter. And from biparietal diameter, this one, this distance, from biparietal, a plane passing through the biparietal diameters and to this tip is this distance is 4 centimeters. All right, remember this part. Now, you know that from the pelvic brim up to the ischial spine, we have 5 centimeters. This means if the lowermost part has reached the 0 station, this means the biparietal diameter has passed the pelvic brim. All right, this is the basis of telling that once, knowing that once the lowermost part has reached the 0 station, the biparietal diameter has crossed the pelvic brim. All right. Now, coming on to the passage now, let's understand. In women, the pelvis has special form that okay. In the women, the pelvis has special form that adapts to childbearing. It is composed of 4 bones. 1, the sacrum. 2, innominate bones. This is the sacrum and this is the coccyx. And 2 innominate bones. They are formed by fusion of ilium, ischium and pubis. The sacrum forms the posterior wall of the pelvis and it is curved to accommodate the rotating head. All right. Now, this is again very important. This is a question many times what examiner does is they will hand over the pelvis to you and tell you, put in the normal position. Normal position means the anatomical position. So what you have to do is you have to, so I can show you on 1 second. Let me show you. Now say, so they hand over you this. What you have to do is this anterior superior iliac spine and your pubic symphysis, they have to be in one plane. This is the, so this means, so once you do this, this is your anatomical plane. Once you do this, this inlet plane, which we'll talk again, that comes at a slant, all right, or at an angle. So the first thing they ask you is, they'll give you this thing and tell you, okay, hold it in. So if you hold it like this, normally the tendency is you keep it on your table, the examination table is straight like this. So in this position, this is not, because this is the pelvis, this is the pubic symphysis, which is ahead, and this anterior superior iliac spine is behind, So you have to tilt it like this, so that this and these two things, they come in one plane. All right. So this is the plane which I am showing. So this is the pubic symphysis and the anterior superior iliac spine. They have to come in one plane. All right. Next, what will they tell you is, now we have to divide this pelvis. It has been divided into 2 parts for definition purposes. So this is the pelvic inlet or this plane, the blue one which I'm showing is a pelvic inlet. On transverse section, on the lateral view, we have this is the pelvic inlet. Anything above this is a false pelvis, and they have divided arbitrarily into this is true pelvis because this is usually involved in the process of labor. So the importance of false pelvis is that it just holds the uterus, a gravid uterus. All right. Now, the true pelvis is the portion in the child important in childbearing. It is bounded above by a promontory, right? And the ala of the sacrum. This is a promontory. This is ala of the sacrum. And this is a linea terminalis. This portion is linea terminalis. Then we have the upper margin of the pubic bone, and below by the pelvic outlet. So this is the boundary. All right. So earlier we used to measure, what we were doing was external pelvimetry, right? So where the false pelvic we used to measure, we usually had a big instrument which was used for this. We were measuring intercrystal diameter. I'm just telling you because some examiners the old examiners are really interested in asking these smaller old things also, which probably may not have much significance in the present day obstetrics, but they are interested, so you should know them, right? So it is the intercrystal diameter, interspinous diameter, and the external conjugate. External conjugate is a distance between the apex of the spine, the fifth. So that is measured, from here. So this is externally measured. We have instrument like this, something like this. So it measures from here on this side. From this side, we put another limb of that instrument here. So this is this. Otherwise, you can't measure from here. So this is the measurement which we find. This is the right. This is a external. What we're using this as a external conjugate. So intercrystal diameter is 29 centimeters, interspinous is 26 centimeters, and external conjugate is 20 centimeters, right? Again, some examiners are trying to find out how can you differentiate between a male and a female pelvis. They will hand over the pelvis to you and they'll ask you whether it's a male pelvis or a female pelvis. That is many a times the first question to, sometimes really check you. So you have to find out that, in the male pelvis, this outlet is heart-shaped, whereas in the female pelvis, it is a oval type of outlet, right? And then we have a greater sciatic notch, which is narrow in male pelvis. We have ischial tuberosity, which is a broader. We have a body of the pubis, subpubic angle. Subpubic angle is this is the angle. This is smaller, or 60 to 70 degrees in male pelvis, whereas in female pelvis it is around 90 to 100 degrees. All right. Now, what are the types of pelvis? This is another question examiner is interested. So we have, this is what we call as a Caldwell-Malloy classification. We have around 50%, we have a gynecoid pelvis. All right. And then we have an android pelvis. This is android pelvis. This is around 20-25%. Then we have an anthropoid pelvis, again 20-25%. And we have a platypoid pelvis, which is around 5% of patients we have, right? So this is a gynecoid pelvis, which we have in females. But there can be, one word of caution, there can be a mixture of all these, types of pelvis. It is not that it's a pure gynecoid or it's a pure android or it's a pure anthropoid. There can be some overlap between these types of pelvis. So you may not find all feature in one type of a pelvis. To further define, we have these are the shapes. All right. So now, can somebody recognize this? Please show in the chat box, right? So this is a entrance of Mata Vaishno Devi cave, okay? So if somebody has gone to Mata Vaishno Devi, this is how I always teach that this is if you can understand this cave, you will understand the mechanism of labor, you will understand the passage of the pelvis, right? So once we enter through this, we have two caves. One is at Mata Vaishno Devi Bhavan, another is at Adhkavari, which is halfway through the Mata Vaishno Devi Bhavan, where we have a cave which is called as Garbhajon Gufa. All right. So it is thought that Mata Vaishno Devi stayed in that gufa for 9 months. So 9 months is equal to the period of gestation. So that has been named as Garbhajon Gufa, right? Now this is the inlet. So what are the boundaries of inlet? We have a promontory, or we go from here, so from the anterior side. This is pubic symphysis. Then we have a pubic crest, pubic tubercle. Then we have a pectineal line, iliopubic eminence, iliopectineal line. Then we have a sacroiliac articulation where the sacrum and the innominate bone join together. And then we have an anterior ala of the sacrum. Then we have a sacral promontory, same here. If you go from here, it is promontory, ala of the sacrum, iliopectineal line, iliopubic eminence. Then we have a pectineal line, right? Pubic tubercle and pubic crest, and then the pubic symphysis. Okay. Now, what are the AP diameters of the inlet? This is another, see, you have to remember anything from the sacral, they all start from the sacral, tip of the sacral promontory, right? Mid of the sacral promontory. They come anteriorly. So the topmost diameter is what we call as anatomical conjugate or a true conjugate or a conjugate vera. This is around 11 centimeters. This is from the distance between the midpoint of sacral promontory to the inner margin of the upper border of the symphysis pubis. All right. And the second one is the obstetrical conjugate. It is from, again, the starting point is same, but then it is up to the midpoint of the, it is midpoint of the posterior surface of the pubic symphysis. Now, point is, we cannot measure these two conjugates or two diameters. What we have done is, then we have defined a third diameter, which is from, again, starting from the midpoint of the sacral promontory and going up to the lower border of the pubic symphysis, what we call as a diagonal conjugate. And this is the only thing which we can measure clinically. And from here, we can subtract, say, 1.2 centimeters to find out the anatomical conjugate. All right. Or say, so this is 11, this is 10, this is, say, 12. All right. So if we just subtract 2 centimeters from here, then we will have an obstetrical conjugate. If we subtract 1.5, so we will have a 11 centimeters. Okay. Now this is obstetrical conjugate. This is 10 centimeters. Now coming on to the transverse and oblique diameters of the inlet. Transverse diameter is 13 centimeters. It is a diameter which is the two farthest points on that plane of inlet. This is 30 centimeters. And then we have a oblique diameter which is 12 centimeters. All right. Now this is another one. What is angle of inclination? I told you when I was trying to tell you to hold the pelvis in an anatomical position. Similar here. Once you hold that pelvis in that anatomical position, the pelvis, the inlet, the plane of inlet is at a slant. All right. This is what I told you. Once you hold it in like this, these two should be in one plane. Then this plane is at a slant. And this plane, the angle, once you extend this plane to the surface, a horizontal line, so the angle which it forms with that horizontal line is called as the angle of inclination. What does that mean is that pelvis is inclined at an angle of 55 degrees with the transverse diameter. And this is in a standing position. All right. So this is an angle which so this is a pelvic inlet plane, which is coming here. This is a horizontal line. So this is the 55 degrees, which it forms with a horizontal line. This is in a standing position, in an anatomical position also. Now, many times what happens is the fifth lumbar vertebra joins together with the sacral bone, what we call as a sacralization of the lumbar vertebra. And then we have a high inclination. So once we have that high inclination, what happens is it causes a delay in engagement because the long axis of birth canal or the inlet does not coincide with the long axis of the uterus. So there is a discrepancy in the two axes. So we have a delay in engagement, and this favors usually occipito-posterior position. And there is a difficulty in descent of the head due to long birth canal and flat sacrum interfering with the internal rotation also. Now, coming on to the pelvic cavity. So this I told you is your plane of inlet. Okay. Now there is another plane, what we call is the plane of least pelvic dimension. Okay. The area between the pelvic inlet and the plane of least pelvic dimension is called as the pelvic cavity. It is usually a cylindrical or equal in size. So that is why all the diameters of pelvic cavity are same. That is say 12 centimeter, 12 centimeter, 12 centimeter, maybe oblique, maybe AP, or maybe transverse. Okay. Now coming on to the plane of least pelvic dimension and plane of greatest pelvic dimension. If you want to define what is the pelvis, say mid pelvis or the pelvic cavity, it is bounded above by plane of inlet and below by the plane of least pelvic dimension. Its shape is usually round or cylindrical. All diameters are 12 centimeters. Now coming on to, there is a plane of greatest pelvic dimension in this pelvic cavity only, which starts from the posterior surface of symphysis pubis to the junction of second and third sacral vertebra, right? And this is the widest plane in the pelvis. Now, the axis of this plane is, it is mid-perpendicular line drawn to this plane. I'll come to this axis again in detail in the next few slides. Now, another term which has come is a mid-pelvis. What is a mid-pelvis? Now, it is between the plane of greatest pelvic dimension and the lower plane of least pelvic dimension. This is called as a mid-pelvis. Some people want to, use this term, but usually does not make much of difference, but because this whole is your pelvic, right? This is again the same picture which I was telling you. This is a Garbhajun Gufa. So what a person does once passing, once you straightway go through it, you will never be able to pass through it. But it has projections here and there, mountains, the stones here and there. So you turn here this side, turn your head this side, then you turn your shoulders on one side, then you, and all are able to really pass through. And this is a real, I should say a real similar to what a pelvis in maternal pelvis is. Now we have talked about the pelvic inlet. We have talked about the greatest pelvic plane of greatest pelvic dimension, plane of least pelvic dimension, and now this is a pelvic outlet. Now pelvic outlet is say we name it as two. One is a obstetrical pelvic outlet and another is a anatomical pelvic outlet. So what is the obstetrical pelvic outlet? It is a segment between plane of least pelvic dimension to the anatomical outlet. Okay, so this is a pelvic outlet. I'll come to this axis problem again. So plane of least pelvic dimension, where it is exactly, it extends from the lower border of symphysis pubis to the tip of ischial spines, and posteriorly it joins a tip of the fifth sacral vertebra. Okay, so this is a plane of, this is a plane of least pelvic dimension. It is passing from, not from the coccyx, please mind it. It is from the fifth sacral vertebra goes through the ischial spines. Basically, all these planes are imaginary planes, right? So this is fifth sacral vertebra, ischial spine, and then to the lower surface of the pubic symphysis, right? Now this is obstetrical. The transverse diameter here we always think is a interspinous diameter, which is 10 centimeters. It's the shortest transverse diameter of the pelvis. Now this is a plane. Now what is the importance of this plane of least pelvic dimension? One, the internal rotation of the head occurs at this level. It marks the beginning of forward curve of the pelvic axis. It represents the zero station of the head. External os of cervix is at this level. It marks the origin of levator and eye muscles. It's a landmark for pudendal block. And most cases of deep transverse arrest occur at this level. All right. So this is another question which examiner is interested in asking you. What is the importance of least pelvic dimension? All right. Plane of least pelvic dimension. Now coming on to the anatomical outlet, it is basically a bony outlet. It is bounded in front by lower border of symphysis pubis. All right. Then laterally by ischiopubic rami, ischial tuberosity, and sacrotuberous ligament. This is a ligament here. It's a sacrotuberous ligament. And posteriorly by the tip of the coccyx. The obstetrical outlet was at, or the least pelvic dimension was at tip of the fifth sacral vertebra, whereas this is at the tip of the coccyx. So the AP diameter of this is 13 centimeters. It's basically a diamond shaped area. All right. So these are just to recur this thing. We have a brim or the inlet. We have anterior posterior diameter is 11. This is the conjugate para. This oblique is 12 centimeters. Transverse is 13. In the cavity, we have all 12, 12, 12. And in outlet, we have practically opposite of the first one. It is 13 is the anterior posterior, 12 is oblique, and 11 is the, so the oblique diameter is 12 centimeters at all levels. Whereas in the brim, it is 11, here it is 13, it is 13 here, and it is 11. So you can remember this easily. So what are the other things which are important is many people ask is subpubic angle. What is this subpubic angle? We'll talk about subpubic angle. We'll talk about pubic arch. We'll talk about pelvic curve, and we'll talk about the waist space of Morris. So this is the pubic arch, all right? So if we have, it is like this, right? And it is the angle which is formed here, right? This is a pubic angle. So if what we do many times, if we 2 centimeters below this, say this is 2 centimeters, this area is around 6 centimeters. All right. So this accommodates your 3 fingers. This is somewhere here. It accommodates your 3 fingers, right? If you can see properly, I don't know. All right. So this below 2 centimeters below this lower border of pubic symphysis, it usually accommodates 6 centimeters, accommodates your 3 fingers. All right. Now coming on to the pelvic axis, which I always find very interesting. So this was your plane of inlet. All right. So this is the axis of the inlet or axis of the brim. Anything, the axis is always perpendicular to the plane. So this is the axis of inlet. All right. Then you have a pelvic, you have a, the middle pelvis or the pelvic cavity. The pelvic cavity, the axis is usually vertical. All right. And the pelvis or the axis of outlet is like this, for coming forward. So So if we join all these axes from here, 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 and want to come from here, no, this forms something like this. It forms something like this. And this is called as the curve of Caris. And this is the pathway which a baby follows during labor. All right. So this you have to remember. It is basically a pathway which is joined by, or once we extrapolate the three axes. This is one axis. This was axis of inlet. This was axis of mid pelvis, and this was the axis of outlet, right? So this, at the end of the day, this forms your curve of Caris. Now, what is the waist space of Morris? Waist space of Morris is like this is suppose your head. All right. It never fits into this area. So this area is always, vacant. And this is called as a space of Morris. It is usually less than 1 centimeter. But if it is more than 1 centimeter, this means we are wasting more of space here. So then what happens is the baby's head presses on your posterior structures. Posterior structures means your soft tissues, and there are chances of tears of your soft tissues. All right. Okay, we have learned about the diameters of the baby's head. We have learned about the diameters of the pelvis or the passage. Now, how do we really assess it? It is mainly a clinical. And when should we do it? The examiner will always ask you when you will do pelvic assessment. So it is done anytime beyond 37 weeks in priming gravida. In multi-gravida patient, you can do it during labor also, because you already tested that patient has already delivered a baby. So you can do it in a multiparous women. And what is the best for pelvic assessment? Is a trial of labor. Whatever you... Am I audible? No, is there some problem? Hello? Am I audible, madam?
Yes, sir, you're audible.
Okay, thank you. So how do we find out? So what is a contracted pelvis? Contracted pelvis is when any of the diameters of any is less than, say, 0.5 centimeter less is, we call this as a short or the short diameter. And for inlet, we have obstetrical conjugate. If it is less than 10 centimeters, we call this as a contracted inlet. If it is less than 11.5 centimeters diagonal conjugate, we call this as a contracted inlet again. If interischial diameter, ischial means ischial spine diameter. If it is less than 8 centimeter, we call this as a contracted cavity. And if we have a transverse diameter of outlet, which is less than 8, this is basically a TDO, transverse the tuberosity, intertuberosity diameter. Normally it is say 10 centimeters. If it is less than 8, we again call this as a contracted outlet. But see, it can be a small pelvis also, but the baby will also be small and then baby can deliver. It's not absolute. See, these CPD is never absolute. It all depends on so what is the size of the baby and what is the size of the pelvis, right? So coming on to the grossly abnormal pelvic types, we have a Niggler type. What happens in Niggler type is the sacral ala is absent on one side. Here we have a sacral ala. Here it is absent. All right. So this is called as a Niggler's pelvis. Again, old examiners are interested in finding out this from you. When we have absence of both ala, this is called as a Roberts type of pelvis. Now this is a rachitic. Earlier days we used to have rickets. So this is a rachitic type of pelvis. All right. This is this shape, how it becomes. Then we have kyphotic type of pelvis. The patient has some problem in the spine. Now coming on to the cephalopelvic disproportion. Disparity, it is a disparity in relation between the fetal head and the pelvic size. It can be due to big baby, or it can be because of small pelvis, or it can be because of altered shape of the pelvis, or it can be combination of any of these factors. Now, how we diagnose? If we suspect, first of all, if baby's head is deflexed, and it is usually flexed by term when in primigravida, and or it is a free floating head at term in primigravida, this is, we always think that there may be some problem in inlet, right? Or CPD of at the level of inlet. All right. Now, how do we measure all these things? Earlier, we were using radiopelvimetry, we were doing X-rays, then we were finding out the diameters of the pelvis, then CT pelvimetry came, then MRI pelvimetry came, and then the important, which we all follow and which is time tested almost, is a clinical pelvimetry, which we will be discussing. So what is clinically measuring a diagonal conjugate? What we do is you put your two fingers and try to reach the sacral premonitory, which usually in a normal pelvis you are not able to reach, but the maximum you can put your finger is there, and the distance, and mark a distance on the here on your finger or on your outer edge of the finger. This distance from the middle finger to this is called as diagonal conjugate. Every obstetrician should know, usually should know the distance between his fingers, or if not, you can keep a scale and you can measure this distance. And if you if you measure a diagonal conjugate, then you can subtract to find out the true conjugate. All right. Now, what is the protocol? What we do is we start, put your hands in, two fingers inside, gloved fingers. We look for prominence of the sacral promontory. Usually you are not able to reach and you are not able to really find out that. But if you are able to reach sacral promontory, this tells me that this pelvis is contracted. All right. Then we find out the obstetrical conjugate. This we do by I told you, by measuring the diagonal conjugate. All right. Once you enter your fingers inside, so what you do is you put your fingers, you see for the curve of the pelvis also, and move your fingers like this downwards also and sideways also, whether that pelvis has an adequate curvature, the sacrum has adequate curvature. So this is assessing the curvature of the sacrum. So estimation of the prominence of ischial spine. Now what happens is, in normal gynecoid pelvis, the spines are not that prominent. All right. Or they are not inverted. Once they are inverted or they are prominent, you will be able to palpate them and you will be able to know that they are prominent and they are. So once they are prominent, this gives me a suspicion that my mid pelvic cavity or plane of least pelvic dimension is smaller. All right. And what you do is, secondly, is try to open your fingers, like say these fingers, try to reach both spines. Normally, you will not be able to reach because your two fingers will not be able to diverge to that extent that you are able to reach here. Once you are able to reach both spines, this means your spinous diameter is less. So say your finger, if you open your two fingers, I'll show you. If you open your two fingers, these fingers can never be open up to say 10 centimeters, right? If you are able to reach both spines with your fingers, this means this is something less than 8 centimeters and this is a smaller diameter. Now, how do we measure about the pelvic outlet? Estimate. prominence of the coccyx. Now, coccyx usually is it is slightly because the sacrococcygeal joint is slightly mobile, so you can slightly move your coccyx also. Many times this joint is immovable or fixed. Your coccyx will not be able to give that space to the coming head because it will not move posteriorly. If it is fixed and your coccyx is here, it is prominent, it's not movable, it will give me an idea that it can be a trouble. Then coming on to the subpubic angle, usually a subpubic angle, I told you it is around 90 to 95 degrees in female gynecoid pelvis. Usually it accommodates 2 fingers. So that gives me an idea that this is right this. Or what you can do is, you can, so once you are measuring this, you can put your 2 fingers like on the 2 from here, right? All right. If you are able to do this, you have to, then it is a normal. But if it is smaller, like you are able to do only this much, this is a, between the middle finger and the 3rd finger, this is a smaller, all right? Then we have to, your 2 knuckles, put your knuckles here and find out the intertuberous diameters. Normally it is 10 centimeters, I told you. If it is less than, you are able to, not put your knuckles here, then it is a smaller diameter. So it gives me some idea about the size of the pelvic outlet. Now, how do we do it to find out whether, once you find that pelvis is okay and, you still baby may not be able to deliver because baby size is bigger. So how do we clinically, we have some methods, like we have an abdominal method of diagnosing CPD. What we do is we put your 2 fingers here. The inner side should be parallel to your pubic symphysis and try to catch hold of the head and try to push it down. If it goes down, it is fine, then there's no disproportion. But if it is pushing against your inside of your fingers, this is then there is a mild disproportion. If it is displacing your fingers, then it's a moderate to severe type of a disproportion. All right. Then another method which we always do is it's a by manual method. We put your fingers at the level of ischial spine or 0 station, and then from above you push the head inside the pelvic cavity. If you are able to feel the head at 0 station, there is no disproportion. But if it is not, then there is a disproportion. This method is called as a Muller-Monroe method. Now, what happens once there is a contracted pelvis and CPD in labor? What can happen? There can be malpresentations and malpositions. There can be early rupture of membranes because, so say this is your pelvis, right? So your head is here, cervix is here. It is not fitting into the part, no? So the bag of membranes, it is there. So it tends to rupture. It's not again, the head is not against the bag of membranes. It is hanging, so there are more chances that it will rupture. Then once it ruptures, there's increased risk of cord collapse. The cervical dilatation is again what we call as a Ferguson reflex, right? Once there is a pressure on this, then there is a Ferguson reflex, more of contraction, it dilates properly. But in this condition where we have a CPD, the cervix dilates slowly. Then there can be arrest of labor and prolonged labor. There can be increased operative deliveries. There can be increased maternal injury, or there can be fetal distress and asphyxia because there is a prolonged labor. Thank you so much. If we have any questions from my young brigade, I'll be able to, try my best to answer them.
Anyone have a question, please write in the chat box. I guess there are no questions, sir. Thank you so much, sir, for the wonderful session.
Thank you, ma'am.
Hello, am I audible?
Yes,
Ma'am, am I audible?
Good evening, sir. Good evening, Konar, sir.
Very good morning.
Good
No, it is
morning.
yeah, good afternoon.
Good
After a
afternoon,
long
sir.
time.
Yeah.
I was thinking to talk to you. Yeah.
Thank you so much.
Where we shared our room, sir?
We shared in Gorakhpur. We are coming to Gorakhpur again.
Good days.
Are you coming to Gorakhpur now?
Whenever invited, you know, like you, I am also person.
Right.
Very good afternoon, sir. Dr. Hiralal, sir.
Very good afternoon.
So now moving on to our next session, that is Forceps and Vacuum. We would like to invite Dr. Hiralal, sir. Sir is a professor in Obs and Gynae in RK's Mission Matri Bhavan. Sir is an ex-professor and head in the department of OG. Sir is a vice president of OSCE 2008. Sir is a chairman of ICOG 2013. FOXY representative, sir is a member of Oncology Committee of AOFG.
Madam, और रहने दीजिए.
Okay.
Leave those aside.
Okay, sir. Okay, sir. Thank you, sir.
Thank
Sir,
you.
please start. Oh.
Right. Can I have the full screen? Right, you are. Can I speak now?
Yes, sir. Yes, sir.
Am I audible?
Sir, you're audible, but your slides are not visible, sir.
No, I have not opened the slide.
Okay, okay.
I will make it share screen slide. So, only thing to tell that I'm really thankful to the organizers Gurukul class for the Gurukul classes, especially that of the Institute of Obstetrics and Gynaecology, Sir Gangaram Hospital, Delhi, and the organizers that we know, Professor Mala Srivastava and Professor Chandra. It is my pleasure that I have attended this program number of years, quite few years now, and the organizers are working hard to get this program successful. And I wonder that the teachers are from across the country, north, east, south, west, all are there, and it would be a huge exposure and understanding of the subject, and by all the assessors, most of them are the examiners, so this would be of great value. So with this, only my request is that I would ask the participants to make their questions written, so that at the end of the discussion, we go for the discussion. Basically, this is a complex area of instrumental vaginal delivery. I will be covering that of the voltage and that of the forceps. Many areas, unless you see, unless you handle yourself, don't understand. So that's the reason I have got the instruments with me also. I have taken from the hospital the obstetric forceps, long curves, short curves, the rotating forceps. They are there. If you have got any questions at the end of the session, I am happy to talk, and I will finish up in time so that you get the time for discussion. With this, I will go for screen share. No?
Yes, sir.
How can I? Yeah, I have done the screen sharing. Can I have the slide now?
The slides are not visible. Your screen is shared, but the slides are not visible.
I have done the screen sharing.
Sir,
Yes,
go
sir.
to the slideshow.
Sir, can you click on the enable editing option? This is the white colored small option, enable editing.
It is in the bottom.
No, sir, it is
No,
in
sir.
the
So that yellow in between white enable editing is written. On the top, sir.
On the top.
Enable editing in the white box.
Sir, can you see the option protected view just beside that? Enable editing, sir.
Find home, insert begin transitions. Slideshow.
Yes,
Sir, below that. Below that.
Just below.
That, sir, yellow mark. Can you see the yellow mark, sir? And then a small white option on that yellow mark.
So just below the arrow.
Below the arrow, this one?
No, sir.
Annulate. Stop.
Yes, sir. Enable editing.
Yes, sir, that one.
Mhm. What's wrong?
Yes, sir.
Right. Oh, I am going there. Is it
Go to
okay?
the slideshow.
Yes, sir. Yeah.
Go
Now
to the
visible.
slideshow.
Yes, sir. It is fine, sir. Just make it full screen.
Can it be enlarged now?
Yes, sir.
So just do the slideshow.
Slideshow.
Actually, sir,
Right, you are. Is it okay?
yes, sir.
Yes,
Fine.
sir.
Right, you are.
Fine.
Now let's start that of the operative vaginal delivery. Basically, this concept came earlier with that of the some use of some delivery process when assisted by with the use of some instruments. If you go back to the history, initially these were designed to deliver a dead fetus from the uterus, and that was the destructive operations all over the world. The assisted vaginal delivery safe concept came after the destructive operations, and it differs from that of the obstetrics maneuvers. You know, there are some technical procedures that we do during the course of delivery or pregnancy to help the delivery process. Those are the obstetric maneuvers like assisted vaginal bridge delivery, shoulder dystocia management. These are all the different issues. But operative procedure that we would be discussing here, the concept came from that of the destructive operations, and the procedures that we are using now, that of the for the assisted operative delivery, forceps, ventouse, and that of the Odon assist. This is coming up in the new thing that WHO is looking forward. So mainly we'll be focusing on the forceps and ventouse, and to some extent of the Odon, because in the last conference in Calcutta, we invited Dr. Tim Dreckert, that the mastermind, that he's on this research for over the years. And we had the practice with him, and he was so keen to teach us, especially for me. He spent time to do how the one Odon is and how safe it is. So with this, let's go to the next of the slide. Now, we all know that of the operative vaginal delivery, there are several indications for that. That there is a standard book teaching that maternal factors, maternal regions, fetal regions, maternal regions meaning that maternal pushing effort when mother is exhausted, or the pushing effort is not there, or we don't like to encourage mother to go for the pushing effort because of the some reasons like cardiac disease, severe eclampsia, all these things that we don't like the mother to push. Obviously, the fetal indications that we know, that there are many things in the fetal indications that you will get in the detail in the books. But to talk about the principal areas of the fetal factors, like head must be engaged. There is no doubt that there is any question, head must be engaged. That means clinician, even me, to be a bit careful that when you are assessing the mother, that abdominally 1/5 of the head is only palpable and 4/5 has gone down the brim. And then on the top of it, that of the we must know the presentation, apart from that of the position, rotation, station. These are all important things that before we go for that. And others is that of the, well, there are indications like the, if the second stage is prolonged, probably in an institute delivery, we don't allow that. But in certain cases that when the delivery is prolonged or when the mother is under regional anesthesia, that more than 2 hours or more than 3 hours in case of regional anesthesia, the second stage, or more than 2 hours in case of primary multigravida. So those are the indications for that of the to go for the assisted vaginal bridge delivery. This is from the history we all know that came from that the Chamberlain families, 1600, and more than there are different varieties. I have given you some of the varieties like that of the Simpson forceps, that of the different designs. There's fenestrated blade, solid blade, that of the rotational forceps, that of the Killian forceps that often we don't that much use, but as a part of information, we should know that the Killian forceps is used for the rotation of the head when the rotation is incomplete and we are going for some assisted operative delivery. We should know that the use of rotation forceps. And then comes that of the another variety, that of the short curved obstetric forceps or the Wrigley's forceps. So there are commonly 3 varieties that we are using. One is that of the long curved obstetric forceps, and that of the short curve obstetric forceps, otherwise known as the Wrigley's forceps. Another is the rotation forceps or that of the Killian forceps. And there are other designs I have not seen in India because I move around all the centers. This is the Piper's forceps. Piper's forceps is specially designed with least amount of the pelvic curve, and it has got a long shank and the handle that the baby can rest on it. So this is the design for the delivery of the aftercoming head in case of bridge presentation. Let's move on. So to give you the idea that we are using commonly, the upper one is that of the long curved obstetric forceps. And you see this forceps has got a notch on the blade. This notch is to accommodate or articulate that of the traction, axis traction system. There is the second figure shows the axis traction system. These sort of systems we are not using now because there are different opinions regarding that of the, even that of the forceps delivery. I will make this presentation another in a big seminar. There I will talk detail of it, that this mid forceps delivery is a bit of special situation that commonly we don't encourage that to the beginners. So mid forceps delivery, for the mid forceps delivery, axis traction rod and that of the traction bar all are there. We will come in a way of discussion when we start individually. And this is the third one is that of the C1 is that of the Wrigley's forceps. You see, Wrigley's forceps is a short. It is known as the otherwise known as the short curved obstetric forceps. The blades are there. Shank, the shank part of the forceps is less, and the handle is also short. So this is the short curved obstetric forceps or Wrigley's forceps. And the D1 is that of the rotational forceps or that of the Killian forceps. Killian forceps has got some peculiar shape. Pelvic curve is less, cephalic curve is there, and you can see two buttons over there, knobs are there on the handle. Those are the points to guide the forceps during the course of delivery in case of rotation of the head as well as to direct towards the occiput. When we are applying the blades in case of rotational delivery, Killian forceps, these points should direct towards the occiput, and then it has got a sliding lock. We push one blade over the other so that the asyncletism, mind that asyncletism means the relationship of the sagittal suture of the fetus to that of the transverse diameter of the pelvis. And the deviation from that is the asyncletism. And to correct that asyncletism, we use Killian forceps. Again, then, honestly speaking, these days, these are all been restricted. We are mostly restricted our use of forceps. I will show you, as I said, I will be making more of detail of it in another conference, that of the, we are mostly confined to our instrumental delivery when using the forceps. For you to know detail of that of the Wrigley's forceps or outlet forceps and that of the long curved obstetric forceps for the delivery of this low forceps. So we will move on to the next slide to talk about the different parts of the long curved obstetric forceps. Otherwise, it is, if you see, the same type of design is there. In England, it is called the Nebuliband forceps. When you will be working in England, this forceps the same design and that of Nebuliband forceps. In India, I tell you what, this is our pride that the long curved obstetric forceps, if you ever come, I believe Professor Mala Srivastava worked in Arjigor Medical College at one point of her time. I heard it, but I don't know. So here there is a museum of Das's varieties. Sir Kedarnath Das, this variety of long curved obstetric forceps, it's a bit different from that of the Nebuliband forceps, and it goes by the name of Sir Kedarnath Das, Das's variety. So this is the Das's variety of long curved obstetric forceps. To talk about little bit about the parts of the forceps, here you see, I have got the forceps. At the end of the session that I will show you, I don't know whether you can see this one. It has got the pelvic curve. It has got the pelvic curve means that curvature on the end of the blades. It has got the two blades. Blades are fenestrated, not the solid, to make the instrument lighter. And the edges are on the curvature on the edge called the pelvic curve. Pelvic curve is the entirely that of the forwards and this one also, all called the pelvic curve. And the curvature inside is called the cephalic curve. Here is a curvature inside. So this is known as the cephalic curve. Cephalic curve means it accommodates the fetal head. and it is so designed, the gap between the two, the tip of the forceps or the toe, tip of the forceps are known as the toe, the neck of the fetus is there, and the blades, the cephalic curvature, both the sides, when articulated, this is the articulated forceps. I will tell you how to articulate, and it accommodates the fetal head. As you know, sir has already definitely has told you that biparatal diameter is 9.5 centimeter. This diameter comes 9 centimeters. So the 0.5 centimeter is the compression effect, minimum compression effect, and the neck is protected, and it is works safely. So this is the Das's variety or that of Neveliband forceps, and this is the cephalic curvature that I tell you. This is the pelvic curvature, and this part is the blade. This expanded portion up to this junction is called the blade. Next to this is the shank. Here is the shank. It is around 6 centimeter. The shank junction of the blade to that of the handle. This is known as the shank, around 6 centimeter. And when the blades are articulated, the shank does not oppose, as opposed to that of the handle. You see, the handle is opposed to each other, but the shank remains separated. And advantage of this shank is this: when you will be going for this operative delivery, forceps delivery, the cephalic part, the blade of the forceps goes inside this pelvis or then inside the pelvis, and the shank remains outside. So means this part allows the operator to maneuver and place the fingers. All I will tell you in detail, and the shank rests on this perineum or bit of outside. So this is the shank, and the lower part is known as the handle. Here, the lower part is known as the handle. Handle has got the peculiarity that we hold this. When the blades are articulated, we hold the blades, and the handles are opposed when the blades are articulated. And there is a projection. This is known as the finger rest. Here I am showing you. Here is a projection, the finger rest. So I will show you how to place the fingers and how the fingers are accommodated, and while you are pulling, exerting the tractions over the blades. Now, this is one, and here is a screw. Here is a screw at the end. The screw, once the blades are articulated and opposed, and this screw is made tighten, so that there is no disarticulations of the forceps, so that it does not disarticulate, does not go hayward. So when we apply the blades, and there are several steps like application of the blades, then the locking of the blades, and then screwing, keeping them tight, and then tractions and delivery. So we will go one by one. So this is the Das's variety to talk you about the different parts of the forceps and the blades and the handle. Now finger rests are there. The fingers has to be placed. I will show you when we are going for this delivery. Now, overall, this is the different parts of the blades, and that of the cephalic curve, pelvic curve, shank, lock, and the lock, and that of the screw. Now, to talk about the Killian forces that I have told you, virtually no pelvic curve, cephalic curve is there, the slot is there, it is the sliding lock. I have told you, one blade can be moved over the other so that asynclitism could be corrected. So this is the Killian forces. Killian was popular in India at some centers or some specialized obstetrician. I have seen our teachers, but these days we are not in favor of. My experience of working in England, again, it was at one time popular, but again then declining. So Killian mostly we are virtually not using, because we have got another alternative that I will come to you. So this is the Piper forceps, the bottom one. This is again not that I have not seen in India. Any centers that I have told you, I have moved around all the centers, but I have not seen. And then it has got no pelvic curve, or the reverse pelvic curve. It is sometimes cephalic curve is there, and that of the shank is long, handle is long, so that the baby's body rests on the shank, and that of the handle. So this is the delivery of the aftercoming head of bridge presentation. So this is known as the Piper forceps for that of the aftercoming head. Now, prerequisites for operative vaginal delivery. prerequisite for just going back. Sorry, it has gone. Just a second. I think it has. No, prerequisites for operative vaginal delivery. As I have told you that fetal criteria that of the head must be engaged and the position must be known, station must be known. Maternal criteria that of the cervix must be fully dilated, fully effaced, membrane must be ruptured, pelvis should be deemed adequate. And there are other parameters, there are long list. Other parameters are there that operator. Regarding the operator, one important thing that I should mention that operator must be skilled one. In the skill, development of the skill, that's an important issue these days. So somehow with this video presentation, with that of the with the dummy and model, we have to develop the skill to go for the actual practice. So college recommendation, Royal College, that must develop the skill of going for this operative vaginal delivery before actually doing clinical scenario. So other operator criteria is that of the must be a skilled one and must assess the total criteria for feasibility of the operative vaginal delivery. And he or she has the idea in case of difficulty, what could be the alternative? And more important is this, willingness to abandon the procedure when there is difficulty, when there is obstruction that could not be overcome. There is no such dogma that I must make the delivery successful, whatever goes, not at the cost of the baby. That's the reason operator willingness to abandon the procedure whenever there is any difficulty in terms of applications or the traction. Obviously, presence of neonatologist is important. He should be there or she should be there to help the baby if we need. Now, regarding this all, you know that of the assessment of the pelvis that I was talking to you, head must be engaged, meaning that 1/5 of the head may be palpable, but the rest of the 4/5 has to go down the pelvis. And keeping in mind that the plane of the least pelvic dimension, that is that station 0, and the head must be at station 0 or +1 to go for the criteria fulfillment of forceps delivery. But even then, this is the mid forceps delivery that I am talking of. But mostly we are favoring forceps use for that of the either outlet forceps or that of the low forceps. This is the same station that we know from our knowledge, bispinous diameter, station 0, above minus up to -5 plus, and the down below plus to +5. Choice of forceps operations. This I was talking to you that of outlet forceps. Most of us, we know that the outlet forceps commonly that we recommend to use, and most of the hospitals that we are practicing now, mostly the outlet forceps or that of the low forceps. Outlet forceps criteria, I believe you know from the textbooks, that when the fetal scalp is visible without separating the labia, that means this the head is on the perineal floor, fetal scalp on the perineal floor, sagittal suture in the anteposterior diameter of the pelvis, and the rotation is within 45 degrees. So this is the criteria of the outlet forceps. Outlet forceps is permissible without any difficulty. Coming to that of the low forceps delivery that we are practicing more, low forceps delivery, that the station is +2, and that of the fetal skull is on the pelvic floor, rotation may be 45 degree or more than 45 degree. Mid forceps delivery is very important for the operator to decide whether I am going for the low forceps delivery or the mid forceps delivery. Mid forceps delivery by criteria means the station 0 or +1. This is the mid forceps delivery. So one should be very much careful regarding the assessment of the pelvis and the fetal parts because of the problem of caput formations moldy and high forceps, that for definition that you know that head is not engaged, tripartite diameter above the pelvic rim, we are not at all using that of the high forceps. It is the abundant one. Now, Professor Arora has shown you all this 9 biparietal diameter that we are looking for this criteria of engagement. And when we are assessing the maternal pelvis, apart from that of the dilatation, effacement, that of the station and the rotation in terms of the occiput. Here is, we have shown you the occiput in terms of occiput. Sometimes, that if the caput formation is there, molding is there, molding must be seen. Plus 2 molding probably is not good for the operative vaginal delivery. That the criteria, they are opposed, separable, and they're overlapping and not separable. So those are the criteria that should be fulfilled. Occiput, depending on the degree of flexion, that need to be assessed, whether you are palpating the occiput or the sinciput. So these are the important things either for the forceps delivery or that of the ventouse delivery. We will come later on. So the assessment of the pelvis, apart from that of the dilatation, effacement, the station of the head, rotation of the head, and that of this detail of information, capacity of the pelvis. So these are the important things. Here to show you that you see, well, head is well engaged. Major part of the head has, forceps has gone down. So head is the bipartal diameter below the level of the ischial spine. It is a good thing that all criteria fulfilled. So we can go for this forceps delivery, low forceps delivery. Now here is a situation, you see, just to give you the idea how the caput is there, how the molding is there, and this molding is inseparable mostly. It is so much of overlapping. Probably these are the situations, and that the 2 feet of the head is above the brim, head is not engaged. These situations of clinical scenario for operative vaginal delivery, be it ventouse or that of the forceps, probably these days it is not acceptable. Those situations, unless you are in a very difficult situation, it is always better to go for the cesarean delivery. So this is the area that we like to focus. Selection criteria of instrumental delivery and the operator expertise and the willingness for the delivery, important things. Here is the situation if your bipartal diameter is above the pelvic brim and it is the super molding. And this is the area often you are misled. And once you are misled and you go for this, you are in a disaster. Low forceps operation, just to show you how the low forceps operation to be done. This, I prepare it and we demonstrate even in the odd hours of the evening or the night. I go for, I deliver, I allow them to practice and see. So preliminaries to tell you that we know that assessment of the case is the more important. And then you go for that of the cleaning, saving. I have got the video, I'll show you that how the process is done. Anesthesia, by and large, low forceps or outlet forceps, we don't go for that of the inhalation anesthesia. By and large, we go for the perineal infiltrations or at best the pudendal block. Catheterization and bladder must be emptied and internal examination. Mind that I have put another star by the side of the internal examination, meaning that you fulfill to your satisfaction all the criteria, meaning that of the station, rotation, and the position of the occiput, and that with the pelvis capacity. And then once the efficiency be done, then we will move for the forceps. Steps are there. Steps are important, often asked in the examination, that show me the blade, left blade, right blade, and how you assemble them, and how you go for this insertion of the blades, how protection you are taking. So this is the one. Just we will go for the one to another. And there are the steps is that here it is overlap. One is that of the steps of forceps delivery. One right side you see there are 3 bullets. One is application, second is the locking, and third is the traction. And once the baby head is born, then removal of the blades. So these are the steps of the procedure one to another. Now, identification of the blades. Blades need to be articulated. You see, these are the separated blade. This is the another blade. This is the another blade. Another blade. Now I articulate the blade. You see, this is the left blade comes low, and the right blade comes above the left, and the locks are there. Here is the locks. I show you. I am sliding lock over one to another. Blades are separated. Blades are opposed, and the screwing is done after application of the blade. So this is the application. And once this articulated forceps is placed in front of the mother's pelvis or that of the dummy pelvic maternal pelvis, then the blade that goes to the left side of the mother is known as the left blade. Imagine that mother is lying over there. This is the left side of the mother. So this is the left blade. So take it out. So, and advantage is that don't get confused. Often most of the Indian blades, the left side is the screw is attached. So this is one, and left it remains the lower level compared to the right. So this is I have shown you the parts of the blade. Then how to introduce the blade. So left blade is to be taken first. Articulated, the figure shows the articulated forces and selection of the blade, and then we go for the left blade. Type of application. There are two types of application. What by definition we say that of the cephalic blade application, meaning that I have done the clinical examination. I am sure that occiput is there, the centriput is here, and that of this rotation is complete, and the station of the head. With this information, when I apply the blades, the left blade first is known as the cephalic application. But there may be a situation in case of prolonged labor or difficult situation where sometimes the obstetrician puts the blade inside without knowing the information. This is not the ideal one. This is known as the pelvic application. Irrespective of the knowing the position, position and the rotation of the fetal head, application of the blade is not accepted. So this is known as the pelvic application. Best is that of the cephalic application, meaning that operator knows the rotation, station, everything. So this is the cephalic application that we are going. You see the figure shows 4 fingers of the right hand. 4 fingers of the right hand and the thumb we have introduced inside this maternal left pelvis between the left wall of the vagina and that of the fetal head. So 4 fingers of the right hand is introduced between the head and the lateral pelvic wall, the dorsal fingers to vaginal wall, and the soft palmar surface of the fetal head, and the blade is taken. The left blade is taken in a vertical way, holding using 3 fingers, index, middle, and the thumb at the junction of the shank and the handle. In a vertical way, you see the left blade screw is there. This is the way that you hold the blade, and then thumb, right hand blade is placed towards the palmar surface and towards this introitus, and then thumb is placed at the junction of the shank and the blade, gently guiding the blade inside between the lateral pelvic wall, between the vaginal wall and the fetal head. Slowly and gently. Once you get the blade in and push it gently, the blade goes in and the handle comes down, rotates in the wide arc of a circle, downwards and backwards, and it remains horizontal when the blade has totally gone in. When the blade has totally gone in, so this is the blade is there. And as I have told you, shank lies on the perineum. It adds to the length of the forceps, and the handle is there. So this is the application, cephalic applications of the blade, and the left blade is used first. So this is the dictum. If anything more that you need to know, I will talk at the end of discussion. So this is the cephalic application. Left blade is used first. Once the left blade is high up by the side of the head, just keep it there. There is no need of asking the assistant to hold the blade. Now we go for this application of left blade is over. Now we will go for the application of the right blade. Now you see right blade in the same fashion, junction of the handle and that of the shank and the 2 fingers of the left hand. We don't need, neither the space is there, and we place 2 fingers of the left hand between the vaginal wall and the fetal head. Thumb is at the junction of the shank and the blade, and gradually you see the handle is stopped vertically. The blade appears as the parallel to the opposite left inguinal ligament. Now, if you push the blade gradually under guidance of the 2 fingers, it goes gradually in and in, push it down, and the handle moves an arc of a circle downwards and backwards, and it takes its own position. Once the blades are in, then you try to lock the blade. Then you try to lock the blade. This is the locking one over the another. Here is the lock. I show you. Blades are there, one over the other. You may use the screw also to tighten the blade. So once the blades are in position, in proper position, there is no difficulty in the locking or the application of the blade. So the correct application makes locking easy. I will talk the different difficulties of this using the blades. So there are certain criteria that blades are placed correctly. You know, this is the instrument. Anything goes wrong, that goes wrong, devastation to the mother, to the baby. So that's a devastating. I will show you complications. But once it is appropriately placed, very smooth and easy. Now then, locking of the blades. Before locking of the blades, we must ensure the blades are placed bimalar, biparietal. length, longitudinally, this dimension, the blades are applied, and the posterior fontanelle remains finger breadth. Posterior fontanelle remains finger breadth above the shank of the blade. The posterior fontanelle of the fetus, this is the posterior fontanelle, remains finger breadth above that of the shank of the blade, and margins of the blades are equidistant. The posterior fontanelle bimalar, biparietal, I have told you, and posterior fontanelle remains one finger breadth above that of the shank of the blade. Lambdoid sutures, you see from the figure, equidistant from the upper edge of the blade, equidistant, they are same. This is the proper application of the blade. And sagittal suture remains vertical to that of the blades of the forceps. So sagittal suture remains vertical in the plane. So this is the correct application of the blade, and the blade forceps. The blades are gone in, barely the fenestration could be seen. It has gone totally in, only the shank remains on the perineum. So this is the correct application of the blade. Once the blades are correctly applied, so the no difficulty in the locking and no difficulty would be in the traction pool. I will show you. To sum up, that once the blades are left blade is introduced first and followed by the right blade, and guiding by the fingers and the thumbs, 4 fingers for the left blade, 2 fingers for the right blade, gradually introduced. Once they're in the proper place, that should be biparietal, bimalar, and that of the posterior fontanelle should be finger breadth above that of the shank, and this lambdoid suture should be parallel, equidistant from that of the upper edge of the forceps, and the sagittal suture remains vertical in the plane. So this is the telltale picture of a good application of a forceps. Once the forceps blades are applied, so position of the fingers, here you see, I am showing you again, the middle finger goes between the shank, and the index finger on the shoulder, ring finger on the other shoulder, and the thumb is below. This is the application of the blade. Here it is exactly shown, very easy. So position of the fingers before traction, has to be placed. So to repeat again, middle finger goes in between the shank, the index finger on the one shoulder, and the ring finger on the other shoulder, and then palm over this blade, and then now you are ready for traction. Once it is there, then everything is fine. You are ready for traction. Now question comes, how the traction pool should be. Those days are gone that the mid-forceps delivery is difficult. When I used to practice when I was the registrar at Nilatan Sakara or PGI Chandigarh, but those days are forgotten now. A low forceps and outlet forceps, traction pool, very simple, that I will show you. But when to exert the traction pool, don't forget, when there is uterine contraction, besides uterine contraction, don't go on haphazardly, that will create trouble. So once the contraction is there, maybe that you ask your assistant, fill the uterus, auscultate the fetal heart sound, monitor the fetus, and tell me when the contraction comes. She or he will guide you. Yes, contraction is coming, go ahead. So go for the pulling of the forceps delivery, traction, along with the uterine contraction, along with encourage the mother to push down. That will make your job very easy, satisfactory, both for the mother, baby, and you, the operator. So this is the tricks of forceps delivery, especially the low forceps that I have told you. And then observe that with each pull there should be descent. I have written down the bottom line, descent with each pull. And by and large, low forceps, 3 pulls is enough. By and large, 3 pulls. Maybe that you need more, but by and large, 3 pulls with descent in each pull. So this is the applications of the forceps and the locking of the forceps and the timing of the pull. Now, direction of the pull is very easy. In case of low forceps delivery, you see downwards and backwards, little bit downwards, you see arrow is there, so that the head is come in the perineum, and then straight pull, the crowning, and then upwards and forwards to release the subsequently the vertex, the brow, the face, and down, make it down so that occiput is released, baby is born, head is born. So once the head is born, I think the rest of the once the head is born, the traction pull is there, change the fingers. You see, there is a changing in the position of the fingers, that once the blade comes up, we immediately change because blades are therein, it will not dismantle. So you place the 2 fingers or 3 fingers inside between the shank, thumb behind. So that makes you very beautiful and very safe and easy. So thumb behind, 2 fingers or 3 fingers between the shank, and turn it up towards the mother's abdomen, head is released. So this is the position of the change of the fingers, and forceps delivery, low forceps delivery beautifully could be demonstrated. Provided criteria is fulfilled, operator is a skilled one, no doubt it is a safe procedure. Obviously, talk about this next part. Release forceps, I have got the release forceps for you. You see, blades are there, shank is less in length, and the handle is really short. So this is the release forceps for the outlet forceps. And release forceps for procedure, by and large, the principles of the procedure are the same. Instead of 4 fingers, you place the 2 fingers because head is there in the perineum. So 2 fingers between the left blade of the forceps, the same rule, left blade of the forceps first, 2 fingers, put the blade in. So I saw you put the blade in, holding in a pen holding fashion, and guiding it by the 2 fingers down and down the opposite parallel inguinal ligament, push it down, it goes in slowly, and then the handle comes horizontal plane to this flow. So left blade is in, then another 2 fingers, it goes in, and then again the lock the blades. It will, once good correct application, locking is very easy. So then you don't need to downwards and backwards because head is there in the perineum. Straight pull, upwards and forwards, that release the head and delivery is over. So these are the maneuvers or the different maneuverability of the low forceps or the release outlet forceps delivery. Forceps operations in occipital posterior position, just anybody has got the interest just to complete the list. Occipital posterior, mind, remember that the occiput is in the posterior surface. So the long cut obstetric forceps that we are using. Blades should be equidistant, same rule. Blades should be equidistant from the inciput, and the blade should be side by side parallel, equidistant, inciput and that of the occiput. Traction horizontal, because occiput is behind, root of the nose will come under the symphysis pubis. Then upwards and forwards to release the occiput. Occiput will come out, then downward, release the nose, and then the face is released, delivery is completed. So this is the situation in occipital posterior position that could be done, low forceps delivery. Moving on, now this is the important thing that you are maybe senior, maybe younger, whoever, there could be difficulties in sometimes the forceps delivery. What I am talking of, it needs much of skill, understanding, and judgmental power. Both abdominal and pelvic examination. What could be the difficulties? Application, you cannot apply the force, you cannot introduce the blades. What could be the reason? Reason is simple, cervix is not fully dilated. Cervix is not fully dilated, or even if dilated, then some malrotation is there. Maybe undiagnosed occipital posterior. You are facing struggling. Locking is difficulty. You cannot lock the blades. You have put the blade in, but you cannot, you are struggling that it cannot be locked. What could be the difficulty? Locking of the blades, meaning that, again, that problem is that the undiagnosed, unrotated head or undiagnosed occipital posterior, or the blades are not too far in. You have not pushed the blade in so that it cannot be locked. Or sometimes we need to push the blades down. Once you push the blade down, sometimes it goes in and it easy locking. So these are the difficulties. If there is difficulty in the locking, be careful. These are the difficulties that we need to overcome. And then you face the traction difficulty. Even if you applied the forceps somehow, you don't, you are not comfortable during traction, meaning that you cannot apply traction and there is no reason. Because in that case, you think of, this is a wrong application of the forceps. It may be pelvic applications. Without knowing the rotation, without knowing that of the position, you are applying the forceps. So traction difficulty warns you that it may not be, it may be that blades are not far in, or you have not made the blades down, or unrotated head, occipital posterior, or sometimes rarely mid-pelvic contractions. So those are the things. Once traction difficulty, be very careful. And obviously the fourth one, slipping of the blades, means that wrong application, because maybe the blades have not gone in, or there is some of this unrotated head. So these are the difficulties, or macrosomic baby. So these are the cases that you are facing difficulty. So be careful. In case of difficulty, either you can overcome what I have said. These are the points that we often practice. Or if not, take out the blades, reassess the case, and decide your mode of delivery. There is nothing that dogmatic attitude, I must deliver the baby irrespective of anything. Never, ever these days. Now, there are certain terminology, just to finish it up. These are very catchy questions in the Viva, be it in that of this membership examination or national board. or even that university examinations in India. Prophylactic forceps, it was designed by 1920 by Delhi. What is prophylactic forceps? Prophylactic forceps means that of application of forceps in a way of prophylaxis to cut short the second stage of labor to in anticipation of some complications, either to the mother or to the baby or both. If I anticipate some complications to the mother or the baby or both, and I like to cut short the second stage of labor, it is called the prophylactic forceps. You know that commonly we are using severe eclampsia, or that of this regional anesthesia. Prophylactic forceps is we have to use it. Trial of forceps is a word that is a bit restricted these days. Trial of forceps, meaning that it is the deliberate, it is the tentative attempt of delivery, not. It is the tentative attempt of forceps delivery in a case of suspected mid-pelvic contraction. All criteria fulfilled for application of forceps, and it is a tentative attempt of forceps delivery to deliver the baby in a case of suspected mid-pelvic contraction with preamble declaration. Beforehand, you tell that I may need to go for abandon the procedure and go for cesarean delivery if the moderate amount of pull fails to deliver the obstruction. So this is the trial of forceps. Trial of forceps is done in the operation theater. I have written in capital words that it is done in the operative theater, keeping everything ready for the cesarean section with a preamble declaration that if moderate pull fails to deliver the baby, I will go for the cesarean delivery. Usually in a case of big baby or some of the posterior position, these are the mid-pelvic contractions. So there are certain situations the trial of forceps by an experienced operator could be. And failed forceps is a category. It is the failure of the procedure with deliberate attempt. I have gone through everything, examinations, and I am putting deliberate attempt, but I cannot overcome the resistance. But there is no way to go forward to exert more force, but need to abandon the procedures despite the deliberate attempt of application with moderate force to overcome the resistance. If it fails, it is called as the failed forceps. By and large, failed forceps is due to that of the macrosomic baby, that is obesity, short stature, or mid-pelvic contraction. There are certain reasons that failure of the forceps could be there despite our assessment. In that case, we need to abandon the procedure, reassessment, go for other mode of delivery. Complications of forceps operation, by and large, what I have said, to my experience, if you are very judgmental with your experience and clinical assessment, there is no problem. It is very smooth, especially the low forceps and the outlet forceps, very smooth. It is very enjoyable situations. You success and you get pleasure that I have done this success delivery. And then, but problems may be faulty assessment. I remind you, faulty assessment or faulty criteria, indications of forceps not correct. Big baby, you are going for this, or technically wrong, meaning that you have not pushed the blades in, you have not low down the blades to locking, and the direction of the pull, that may be a wrong thing. So those are the areas their problem. And once problem is there, it might happen to the mother, might to the baby. And once it is there, it is a disaster. I tell you, complications of forceps delivery, I honestly speaking, when it is just smooth, perfectly, it's a very enjoyable procedure, very safe procedure. Everybody enjoys, mother, baby, family members, everything, because we reduce the cesarean section. Maternal soft tissue sulcus tear, if you rotate unknowingly the blades inside the vagina, disaster. Complete perineal tear, obstetric anal sphincter injury is another complication. Nerve injury, femoral, those are the though rare. Hemorrhage, mind that it could be atonic, both traumatic. Your trauma and that atonic combined and make your life very difficult. Others, morbidities, obviously, we know. Neonatal injuries, well, there are intracranial hemorrhage, capal hematoma. But as I say, properly applied, selected case, there is no such problem. These are the different, so often we get confused, what is capal hematoma? It is within the galla aponeurotica, within that of this, and that of this subdural hematoma, epidural hematoma, all the different terminology, and these photographs are there so that we get the correct concept. Now, Hontus delivery to finish up quickly, that of the operative vaginal delivery. Hontus delivery. Now, you see, Hontus delivery is a bit simple compared to forceps, but I tell you, each instrument has got its own merit. So the cuff, there are three parts. One is the cuff, another is that of the tubings, Another is the vacuum machine or the suction. This is the cup. Earlier days, I had my training with that of this. I had my training in operative and delivery with that of the operative, with that of the destructive operations, craniotomy. You know, my experience, I have got lots of publications in Journal of OSCE as well as Indian Journal of JIMA, Journal of Indian Medical Association, regarding the morbidity and mortality of North Bengal Medical College, my experience in the Sub-Himalayan region. So then I moved on to that of the forceps delivery, then move on to the one-twos that came. I had the experience with the metal cup. Now these soft cups are available, silk cup, elastic cups, the plastic cups, bell-shaped cup, that of this QE Omni cup. I will show you QE Omni cup has got certain advantages. In the last workshop, we are using the QE Omni cup. Principles of use. The forceps works by pulling tractions over the fetal head through the neck. But principles of use of vacuum, that creating one-two is creating a vacuum between the fetal scalp and that of the cup, and then tractions over the fetal skull. So this is the principles of use. They are the different. One-two has got certain advantages. Instruments has got the cup. I told you vacuum generator, traction tubings. I will show you all indications of use and criteria as in forceps. Mind that there are notes and books I have seen. Even the 8 centimeter jumping, asking the students to go for the one-twos. Never, ever, never, ever. Criteria: full dilatation, full effacement, membrane must be ruptured, station must be known, presentation must be position. All these things, they are both the same. Never ever 6 centimeter, 8 centimeter, you run for the one-twos. Never ever. I warn you. Now preliminary is the like that of the forceps, cleaning, asepsis, catheterization. Now then cup application. Separating the labia, folded. These cups are folding, soft cups, they could be folded, and I have got the video to show you. Negative pressure generations, and they pump negative pressure generation, and then traction and delivery. How to put the tractions? Here is the earlier the metal cup, vacuum pump. This you have seen, that is the manometer, and here is the flexion point. In examination, must be you would be landed up with this problem unless you know this one. Flexion point on the close to the posterior fontanelle, 3 centimeter in front, 6 centimeter behind the anterior fontanelle, and it is the point where the cup is applied, because to maintain the flexion during the traction of the pulling, so that once the head is flexed, it makes your job easier, easy delivery of the head without any trauma to the mother, neither to the baby. So cup is placed close to the occiput. This vacuum is created. Here you see we are going for the pulling and moderate tractions. Now there are rules that you know, that you see from the textbooks, that you can go by the increasing pressure 0.2 kg per centimeter square per minute. Go by the 0.8 kg per centimeter per minute by 10 minutes time, or 2-3 minutes time, or you can wait. You can go slow creation of pressure, and then spend some time to develop the vacuum, and you go for delivery. Moderate traction, how to pull, how to make the traction. The traction must be at right angle to the cup. Must be at right angle to the cup, never up, never down, never lateral, right, left, nothing, no twisting, no rocking. Cup will be detached. Steady tractions at right angle to the cup. Mind that. Same with that of the forceps, with the uterine contraction, with maternal pushing. And if it is so properly applied, all selection, head, even if that is occipito-posterior or that of the left lateral, then auto-rotation occurs, mild auto-rotation, and by 3 pulls, it delivers. Very easy to learn. And if there is pop-ups more than 2 by the organizer's recommendation, you reassess the patient. Don't go for more than application of 1-2. You may have the other options. Vacuum is released, and once the head is born, vacuum is released, cup is detached, and the rest of the delivery process is completed. And then, as you know, the third stage management. Here is the QE Omni cup. This cup is rigid. Here is the pressure gauge and the manometers are there. So QE Omni cup has got the advantage that detachment is less, and it is rigid cup. If you place over the occiput correctly, then it will help in the auto rotation. This is a flexible one. The stem is flexible one. It will help in the rotation. So purpose of rotational forceps is also start with this. Here once the cup is used, and you allow some time to develop this pressure, negative pressure, and once this negative pressure is there, part of the scalp tissue is included within the cup. This is known as the signon. Nothing to worry about. It usually resolves by 24 hours. Now question is sequential use of ventouse and forceps. Sometimes if you do better, next questions will bombard you that is that possible that I have failed with the ventouse delivery? Should I go for the operative forceps delivery? Should I go for that? That means that is known as the sequential use. Question is, well, this is the soft cup. Question is not to perform as a routinely. If you go make your argument that maybe if it is the head is on the outlet and it is visible, it has come out, maybe we can get the head lift up with using the outlet forceps. But assess the case again. Don't jump for that of the well. We can go for the forceps, or we have failed with the forceps. Should we go for the ventouse? No, not to perform routinely. But again, both the colleges, you see, American College, Royal College says not to perform routinely. But again, then they allow. If you clinical assessment you feel that could be made out easily with the use of forceps, you can go ahead. So postpartum care, you know, the examination of the perineum, any injury, laceration, urinary symptoms like retention, incontinence, use of prophylactic, use of antibiotic is recommended by our Indian practice, our OSCE, as well as the Royal College. Neonatal care, obviously neonatologists. When to abandon the procedure? Once we go for this procedure, when to abandon the ventouse? This is important just to tell you, if each pool there should be a descent. If with 3 pools there is no descent, there is no reason. If you face difficulty in applying the cups and this that means station is up or too much of caput and molding, don't go for that. If there is three pop-ups or the detachment, don't go for that. Or with each pool, there is no descent, don't go for that. You decide your plan and go for the other modes of delivery. So neonatal injury, again, I tell you, for ventouse is safe, no such problem. But again, then, if difficulty, then you may land up with these complications similar to that of forceps, with that even to that of the cellular dystocia. Maternal, obviously, complications I have told you. Urinary incontinence and that of retention of urine, those are less, especially with that the ventouse, usually less. And by rest or pain, once the pain subsides, everything is okay. Fecal incontinence is not a problem. Infections, obviously, we recommend use of antibiotics. Contraindications of ventouse application. There are certain contraindications. We must be knowing that not all cases are good for the forceps. Not all cases are good for ventouse. If the presentation is other than the vertex, brow, face, breast, never ever. Fetus is having some problem, diastasis of bleeding diastasis hemophilia. Preterm fetus, less than 32 weeks. Royal College, American College says less than 34 weeks. Royal College says anyway, whatever you say is accepted. Macrosomic baby more than 4 kg. Don't go for this ventouse. These are often they land up in failure. Choice of forceps ventouse. This is the question, you see. I have written each instrument has got its own superiority over the other. And selection depends upon the individual case. Really, head is visible, perineal outlet. Well, you can go for either with the ventouse or forceps. But if this is mid forceps delivery or that of the low ventouse delivery, depend on the baby size, station, rotation, all these things. But expert is in each because ventouse has got the advantage that it doesn't need a space. It helps also rotation. Learning curve is very easy. So there are certain points in favor of ventouse. Again, then forceps claims that, well, I have never failed. I have got the good success rate compared to the ventouse. So this way, pros and cons are there, textbooks are there, you consult all the points. But as a clinician, it is entirely depends on availability of the instrument. Ventouse is there, forceps is not there, or other way, ventouse is not there. So you have to go for this, either the selection of the, depending on the case, clinical scenario, and that of the availability. Now coming to the last part of my area, Odon assist device, as I told you, international it is going on research. It is in the phase of randomized control trial. It's an inflatable device placement of an air cuff. I have got the photograph. Yes, I will show you. Air cuff circumference. We have got the in our book. We have given this Odon. This time we will be giving in more way because Tim Draycott, he was so interested. We are in the almost WHO stage, the final phase, and it has got many advantages. Even the midwives can use it. So it has got an inflatable device. Placement of the air cuff circumference over the fetal head. That air cuff is there and pressure is raised. So low pressure than that of forceps. And mechanics and principle that of the uterine propulsion force, and the instrument has got the maintaining the flexion and obviously traction force. So this combined together, it is helpful. That is, you see, this is the design. This model is again been revised to some extent, but this is the principal one that over the fetal head, you see, circumferentially over the fetal head, and usually no such injury. And I have given you primary outcomes are very good. Successful assisted vaginal delivery 88.5, similar to that Omni cup that I was talking to you, the rigid cup. No serious outcomes. Median time 8 minutes. Secondary outcomes, maternal outcomes, estimated blood loss, perineal loss, anal sphincter injury, almost the same. Is nothing that more, rather it is safe, more safe. So this is the Odonaxis device, and no serious maternal and neonatal adverse effect. Device is easy to use, short learning curve. This Odon has got the short learning curve compared to that of Forceps and this, this Vontage is good. Randomized control trial, I told you, is awaited to compare the outcomes objectively, the different one. So probably very soon, WHO ready to introduce this modern device, provided this trial is over. Here is the one figure. It is the newer one that we practice over this. This is the same principle of inflatable device over the fetal head and creating that of the pressure. Now I think this is my slide, but I have got a video. How then we can go? Now, can I have news here. Can I go to this video from here? Absolutely. Oh. Absolutely. News share.
So can you tell me that what issue you are exactly facing so that I can help you out?
It is in my desktop to get one video
Okay.
to share and to show you.
Sir, for that you need to stop the screen share and then you want to share that video, right? From your
Share
desktop.
the video. Just have to
Okay,
be
sir.
there.
Sir, then you need to stop this PPT sharing. Just stop the screen share of this PPT.
PPT,
Okay, sir,
yes.
it has stopped. So now you just open the video once
Video.
and then just
So
minimize it, sir.
I should put it down minus.
No, sir. You just go back to your desktop and then open the video and then pause it. And then after pausing that video, come back to the Zoom room.
So I should minimize the screen now.
Yes, sir. You can minimize the Zoom screen.
How can I do that? How can I?
Sir, just open your video from your desktop and
No,
then just
I like to get rid of this screen now to go back. Acha.
have you minimized it?
I have minimized it.
Okay, sir. Now just open the video and then pause it.
Right, I am going there. Oh no, I have got in the. I have got in the. Microsoft Select an app. Is it open now?
Sir, I won't be able to see it from my end because you're not sharing your screen. So you just simply open the video from your desktop and then pause it and then again minimize the video.
Pause it.
Have you opened the video, sir?
Media player.
Yes, sir. Open with any of your media player that you're comfortable
Media
with.
player. I have
Okay,
done
so
it.
now pause the video. I think with the video is playing, right?
Can you see now?
No, sir. No, sir. We will not be able to see it. You just
How?
pause the video, sir. Pause the video once. Have you paused it?
Why to pause it?
So you
It
can
is-
click on the space option in your keyboard. You can click on, you can tap the option space, the space bar
State bar.
in your keyboard, sir.
Now, how to pause it? Or can we
Yeah,
share
yes,
it?
sir. Yes, sir. Just press the option space bar in your keyboard. Just
Skip
press the
back.
space bar.
Space bar.
Yes, sir, in your keyboard. So
Video screen.
the video will be
on
paused, sir.
I have
there are
to-
two labs. Just pause them the
How
two
to
labs.
share it now?
Okay, sir. Now you come back to the Zoom room, sir. Just get back to the Zoom room.
Zoom.
Have you entered in the Zoom room, sir? Okay, so now just repeat the process. Share screen, the green colored option. Just click on the share screen option.
Share screen option is not shown here.
So have you, have you get back to the Zoom room, sir?
Sir, just move your cursor.
I have gone back to the Zoom room.
Okay, sir. In the
Where
Zoom
you will
room,
have a
are you
Zoom
able
room.
to see the option share screen? The green colored option, sir?
No, I can't see that one. Green color I am looking for. Search. No, I can't see that one. Zoom.
Just scroll your mouse.
Yeah.
Sir, your voice is not coming properly. Your voice
No,
is
I can
little
see
too-
that of the green color that share screen.
Yes, sir. Now click on the share screen option.
No, I can't see that one share screen.
So then, sir, can you explain me what exactly you are seeing? What exactly the options that you are able to
On the
see?
screen that the video is open.
Okay.
And then I am looking for the bottom bar panel says nothing that of the share screen.
Sir, mute,
Green.
unmute participants. Are you able to see those options? Mute, unmute, start video, participants.
Is setting Delhi June.
Madam, can you minimize the video first? Sir, minimize the video first.
Minimize the video. Well, I will. I have done this.
Now you will see the Zoom bar.
I am not seeing that your share screen. Share screen. I have opened the video.
I understand, sir.
You
You
need to
have
see
opened the
that
video. You need to minimize the video as well, sir. Have you done it?
I have done the minimize the video.
Okay, sir, now
I am
where,
looking.
sir, now where are you? In the video or in the
I
Zoom
am
room?
back to the screen.
Back to the Zoom room, right?
Not the Zoom room. I am looking for the share screen.
Sir, you need to get back to the Zoom room for that. Otherwise, you cannot find the share screen option.
Launch meeting.
Sir, do not click on the launch meeting. Sir,
Uh.
can you see the ZM option at the
ZM
bottom?
option.
Sir, just place your cursor on that ZM option.
I should click it the Zoom.
Yes, sir, you can click it
Get
on. Can you see the window now? The Zoom window that
No.
you have minimized previously?
No, not yet.
Sir, have you placed your cursor on the ZM option? Okay, so now what you can see, sir, after placing the cursor on that ZM option?
I have there.
Can you see your face, sir, there?
Can you see?
Can you see your face over there, sir?
I can see my, yeah.
Okay, sir, just click on that window, sir. You need to click on your face.
Something is wrong. Anyhow, ZM I am clicking.
Sir, just place your cursor on the ZM option and there you will be able to see your face. So just click on the
I can
window.
see the face.
Okay, so have you clicked on the video? Have you clicked on the window?
I should click on the ZM, na?
It is, sir, you don't need to click on it. You can just place your cursor over there.
Acha, right. I have
Clicking
placed
is not
the
mandatory, sir.
cursor on the ZM, then?
Then can you see your face there?
Yeah, I can see the face.
Okay, sir, now click on the window that's showing your face, sir.
No, nothing is anyhow. media player, all is there. I am clicking on the face and then
Sir, are you now in the Zoom room?
uh,
Can you see the share screen option now?
no, I have done the Zoom JDM and then clicked on the face.
Okay, then.
And then I don't see that of the screen share. That's the important thing. Otherwise,
So
or should
the
I click?
option should be in the bottom, sir, the green colored option.
No. Green color I'm not seeing. Green color option in the bottom bar, no.
Sir, do you have any other person around you who is technically a bit sound, sir?
I think that's the
So
important thing.
sir, is there anyone available with you? So that would be easier for them to help you out through that.
Just a second, I'll
Okay,
see.
okay, sir.
No, nothing that I can do. I think we have to leave it in that case.
Sorry, sir.
JDM, I can click on the face.
Okay, so
That I can't see that of the screen share. That's the important thing.
sir, somehow will you be able to share that video with me
Oh,
anyhow?
well, no, video is heavy. It will not.
I
how
understand,
can I say?
sir.
By mail, it won't.
It will take longer
Yeah.
time, sir.
No, it will not be possible to by mail because it is a heavy file.
Yes, sir.
Anyhow, leave it then. Now it has come to my screen, but you can't see this, no? Can you see this?
No, sir.
You can't see. It is in my screen.
So you're in the Zoom room, right? Can you see the option panelist, attendees?
No, I can see the Microsoft, no. File exposure, chat, no.
So can you see the option video participants, Q&A, chat at the bottom?
I'm looking for, but I don't see all these things. No. Anyhow, in that case, we will see if any question answer, we can cover it up. Is there any question answer for this?
Sir, we have a chat box and also a Q&A box, but we
Any
haven't
moderator
received.
that they can pick up the questions and we can go for discussion? File Explorer. One that of the File Explorer.
Sir, I'm asking you, are you in the Zoom room? I mean that you have been previously, sir? Are you in the same Zoom room? Can you see the option?
ZM there.
Yes, sir.
Then
So ZM is the option of a small tab at the bottom. So after placing your cursor on that small tab, are you able to see your face?
You can see. No. ZM, if I place the cursor ZM, then I could see my face.
Sir, can you see one arrow there?
Arrow off is there.
Yes, sir. Just click on the arrow once. The green colored arrow.
I have clicked it, but it says ZM and
Is the screen full screen now, sir?
no, should I? It shows the up arrow. Zoom not signed in. Zoom, it says Zoom not signed in.
No, sir, no. You are already signed in the Zoom room. So can you tell me one thing? Just are you?
Chole,
Hello,
huh?
hello.
Tell me.
Kindly mute yourself. Okay, so sir, can you tell me that how are you seeing the Zoom room? I mean, in a small box screen or in a bigger
In a
format?
small box screen, in a small
Okay,
box
sir.
screen.
If it is in a small box screen, then just click on the green arrow to exit this minimized format.
Where is the green arrow, madam?
So just place your cursor on that small arrow. I mean, on that Zoom box.
Oh, there is a up arrow,
Yes,
show
sir. Just
hidden
click on that up arrow.
up arrow, but it shows there are few icon. One that of Q, another is ZM, another is pen drive. Should I? It is there in my desktop, so I like to open it up. Share screen. I think the once that of the share screen comes, then it will be resolved.
Yes, so I'm saying that are you able to find that? I mean, green colored one small arrow.
Green color small arrow तो नहीं देखा मैडम. Green color I have not seen. Small arrow. One arrow head is there, down arrow.
Yes, so just click on that once.
Once I click the down arrow,
Yes, what it is showing.
it's showing some icons. Like again, the ZM is there. One pen drive symbol icon, the symbol is there. Security at a glance.
Sir, click on the arrow on the right side, sir. Right side arrow. Is there any arrow on the right side? There will be two arrows, one on the left side and another one on the right side.
One only two arrow. That I don't see. Maybe that I'm not in the correct place. No. Anyhow, leave it, madam. It is not working. But
Okay,
it was a
sir.
good video that I thought I will project it. Anyhow, leave it. Sorry, it would have been good to show you this video.
Or else, sir, is it possible to share with someone else in your in this panelist group? Is it
That's a
possible?
file. That is a
Oh,
heavy.
I understand, sir. Okay.
Otherwise, it would have been easy. That's a heavy file. Anyhow, leave it, madam. Okay, then. I'm closing it.
Thank you, sir. Sorry, sir.
No,
Thank you.
it is coming on my screen. It is coming on in my screen, but where is your share screen icon? Is no, I can't see that one. Share. Can you see now?
No, sir. Can you send me on WhatsApp? I'll be showing for your side. Hello.
Can you see now?
No,
Can you
sir.
see?
No,
Eh?
sir. No, sir. No, sir.
Oh, no.
Sir, are you able to see the share screen option?
No, I can't see the share screen option. That's the problem I'm struggling. Share screen option.
Good afternoon, sir. Dr. Hiralal. I'm Dr. Ruma. I was wondering if we could move to the next talk, and until then, someone could assist you with the video. Dr. Mala.
Sorry, sir. Can we move on to the next session?
Oh, yeah. If there is any question, you can ask me, otherwise you can move on. Right.
Any question from the participants? They can type in the chat box. Sir, I guess there are no questions.
Right, you are. Okay then. Thank you. Thank you
Thank
very
you
much.
so much, sir. Thank you. Thank you so much, sir. Now we are moving on to the next topic, that is HSG. That will be moderated by Dr. Ruma Satwik, ma'am. Ma'am is a senior consultant and professor in the Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi, and ma'am has many publications in international and international journals. Over to you, ma'am.
Thank you, Khadija. Can you hear me clearly?
Yes, ma'am. Yes, ma'am. You're audible. Clearly audible.
Excellent. So I've started sharing my screen. The talk is on hysterosalpingography, and it seems like it's a small topic, but I'm sorry, I'm going to take a full half an hour to explain hysterosalpingography to you, also demonstrate pictures and of relevant cases. So hysterosalpingography in the current day and age is done under fluoroscopic examination. It is a fluoroscopic examination of the uterus and fallopian tubes. In the past, it used to be done through still films or still imaging, but fluoroscopy, which denotes continuous X-ray image on a monitor, is what is currently used. This is a sort of a setup for hysterosalpingography, where the woman is lying on the table, and you have a focal spot here at the bottom, which emits the X-rays, which are caught onto the receptor plate after passing through the woman's pelvis, and it will catch the images here. And it will relay it to a screen. You'll see it as a continuous moving film. The indications for HSG now are mostly limited to infertility, to assess the uterine morphology, tubal patency, or pathology. But some of us may also be using it to assess the residual tubal length prior to tubal recanalization, to know if our tubal recanalization procedure would be successful. And if it is cut too close to the uterus, then we have our doubts about whether or not our tubal recanalization would be successful. If the residual tubal length between the uterus and the cut area is 4 centimeters or more, we are reasonably confident that we'll get a good length to recanalize. Also, it will be used post-surgically to assess if your tubal recanalization has been successful. And that's a dubious indication to do it for recurrent spontaneous abortions, because we now have better modalities like a 3D ultrasound, but some of us may still be using it to assess congenital uterine defects or synechia, and that is the complete list of indications for why HSG is done. There is a list of contraindications too: pregnancy, active vaginal bleeding, acute pelvic infection, allergy to radio-opaque dye. Extremely rare. A patient would not be able to tell you that there is some such. but it's good practice to check with her if there has been X-ray of, some other organ and if there was any allergy at all. If there has been an allergy, she'll remember it and she'll perhaps come and tell you. So it's really something you can't miss. Recent uterine surgery, why would you want to do on a person who's undergone a recent uterine surgery? Well, let's say it was a case of tubal recanalization and you wanted to check her tubal patency. You don't want to do it immediately. You want to give it at least 6 weeks to 3 months before you undertake the procedure to check her patency. And clearly, adnexal masses or hydrosalpinx are contraindications for doing an HSG, lest you spread the infection and cause sepsis. Prerequisites, of course, you need to have a proliferative phase. The purpose for doing this to ensure that she's on day 5 to 9 is that the endometrium is thin enough to improve visualization. But the primary reason is that you want to rule out the possibility of a pregnancy. Doing it in the luteal phase means that you may be doing it at a time when this has already implanted or is in the process of implantation. You are then, of course, doing something which you were very the purpose why you were doing the HSG was to give her a pregnancy, and which is what you would have disturbed. So make sure she's in the proliferative phase. And the other thing, the prerequisites remain that she is indication and contraindication compliant. Antibiotic cover has been given. This varies from center to center, and an antispasmodic given prior before she has come onto the table. Again, I've put a star there. This can differ from one center to the other. When the lady has come to you, you will also check after you've ensured that she's in her proliferative phase, that she has the right indication for this. There are no contraindications. You ensure that your HSG trolley and your drugs are ready. On the HSG trolley would be all the instruments required like SIM speculum, tenaculum, HSG cannula, which could be a non-balloon or a balloon catheter, which we will be speaking about in the next slide. You have the syringe to push the dye in. You have sponge holding forceps, cotton swabs, and iodine solution to clean the vagina with. And of course, you have sterile gloves and drapes. In the drug section, the primary thing is the contrast material. The contrast material, also known as the dye, which can be of two kinds, water soluble or oil soluble. We'll be coming to that in a bit. And of course, you have your emergency drugs, an emergency tray ready in case of a reaction to the procedure or to the contrast material. What I've also put there are injection Buscopan or lignocaine 2%. These are sometimes needed as per the protocol of the institute to help relieve pain or to help relieve an inadvertent spasm around the cordia of the tubes, which causes what is known as a false block. Now, these are the metallic cannula types. These are the two types that you come across often. The Rubens cannula, which is the primary design, which has an acorn-tipped cannula, it's called. And this acorn here is meant to cover the external loss, to prevent the dye from leaking back, to create the right kind of pressure for it to enter into the tubes. And then you have the Leach-Wilkinson's cannula, which has screws all around it. The screwing ensures that it fixes in the cervical canal and prevents the dye from leaking out. So Leach-Wilkinson is currently the more commonly used cannula in most centers. But apart from that, those are metallic cannulas. The same designs are available in plastic cannula. The common material used is polypropylene, which is non-allergenic, it's neutral, and it can be easily used. So you have, again, the acorn-tipped shape again in this cannula called the Margolin's cannula, and again the same design in something known as the Spakman's cannula. You needn't remember the names, but just be able to identify them as plastic acorn-tipped cannula, like a Rubens or a Leach-Wilkinson's cannula, plastic/metallic. Then you have the balloon-tipped catheters, where basically you have this thin tube passing through the cervix transcervically through the canal, and the balloon is lodged at the level of internal loss, which is where it creates a watertight seal, and then you're able to push in the dye from the other tube, something like your Foley's catheter. In the absence of a single balloon HSG cannula, 6 to 8 French Foley's cannula catheters have also been used, which serve equally well in performing HSGs. So which one is better for the patient, metal or balloon? Clearly, I mean, there have been studies looking at subjective pain scores, and women have reported lesser pain with balloon cannulas and more pain with metal cannulas. What are the contrast material? Remember that the radio-opaque substance in your contrast material is iodine, and iodine needs to be dissolved in something to make it that liquid that for you to push. It can be dissolved with oil, which is known, then becomes an oil-based media. The oil commonly used in oil-based media is lipiodol, or it could be a water-based kind of dye, which has been dissolved in what is known as a benzoic acid derivative, which is that 6-carbon molecule. And so this allows it to dissolve in water clearly. Oil, when it is attached to lipiodol to make it a liquid, it does not dissolve well in water, which is why it's called an oil-based media. Now, it has been used in the past. This was one of the first contrast media to be used in HSGs. And it was said that there is better visualization, better post-procedural fertility. However, there were higher incidence of allergic reactions with oil-based media. There was higher incidence of embolism and higher incidence of oil granulomas. I've put a query along all of those because we need to find the evidence for what one believes, whether that's true indeed through, what is the evidence through randomized controlled trials. Now, water-based benzoic acid derivatives are, where are the iodines placed at position 2, 4, and 6. And there are also some side chain substitutions apart from being directly attached to the carbon molecule at 246. There are some side chain substitutions which allows it to have greater variety, and this will allow it to be low osmolar or high osmolar. So because these are water-based dyes, the molecules disintegrate into anions and cations, positively charged and negatively charged anions. And the more they do, they increase the osmolarity of the fluid. Osmolarity is the number of molecules present per liter of fluid. So if this is very high, higher than the physiological osmolarity of human fluid or human blood or human tissues, it is likely to cause a lot of inflammation, more pain, and all of that. So you have this divided into hyperosmolar, which has osmolarity levels of about 1500 milliosmoles per liter. This, you have to know, is about 5 times higher than the human osmolarity, which is between 280 to 90. And the examples here are diatriazoate, urographin, which is still used very commonly in some hospitals, iodamide, iodothalamate conray, which is another example of a hyperosmolar water-based dye. Then you have the low osmolars. Low osmolars are lower than hyperosmolars, but they're still not isoosmolar with physiological fluids. So you have osmolarity ranging between 320 to 800, but because of the partially lower osmolarity, they cause less inflammatory reaction, less pain, right? And one of the examples here is iopramide, and so it's also called ultra whist, which is what we use in the hospital that I work in. So these are some of the bottles that may be kept or ampules of the dye that may be kept on the examining table. The first one you can see is lipiodol. You have to instantly be able to identify this as an oil-based media. The second one is urographin. You should be able to say that this is a water-based contrast media, but it is hyperosmolar. And the third is iopramide 370. You already see that 370 written there. That is the osmolarity of the fluid. So it is a low osmolar ionic water-based dye. So that is what you should be able to identify and maybe give 1 point of difference as to why one is better over the other. Now, which one to prefer? I already mentioned 4 or 5 of those points there as to this was thought about oil-based media, that it leads to better optics, better post-procedural pregnancy rates, and but a higher incidence of granuloma and higher incidence of allergic reaction, which is what led to its disuse. and more people shifted to water-based media. So HSG was around in the 50s and 60s with oil-based media. People moved to water-based media in the 80s and the 90s and through the 2000s till this study in New England Journal of Medicine was published. It's a randomized controlled trial that looked at all these 4 issues that I talk about. One of them was how were the optics of the films, whether it was picking up tubal or uterine disease with equal efficacy or not. And it was said that there was equal efficacy in picking up tubal or uterine disease if you use one or the other. Also, that what was thought about allergic reactions for oil-based media, this study said that there were no contrast-based allergic reactions in either group. So clearly there was no differences and they had a huge number. And finally, what were the post-procedural pregnancy rates? This study actually finds higher post-procedural pregnancy rates after the use of oil-based media. Now, this here are the different parameters that they are looking at: ongoing pregnancy, clinical pregnancy, miscarriage, ectopic rates, live births, more than 24 weeks, stillbirth, twin live births, median duration of pregnancy since the performance of HSG, median pain score on visual analog scale. So in the first column is the oil group. The numbers are quite significant, 554. In the second is water group, 554. And you can see that there is a 10 percentage point difference, 39 and 29, in the ongoing pregnancy rate, giving a rate ratio of 1.37 and making the probability value highly significant, and so on and so forth for most of the outcomes. Median pain score was 4.8, which is something that should concern the patient. So which is why I'll bring it up here, 4.8 and 5, mildly higher, but still not statistically significant. So in terms of, you can see that oil-based media was actually leading to a higher post-procedural pregnancy. And this was through a randomized controlled trial in 2017. By 2018, apparently, there were 6 trials that were on the scene and 2,500 patients totally. And all of them kind of stated the same thing, that it's going to lead to an odds of pregnancy, which is 1.4 times higher than the one where you are using a water-based dye. So it wouldn't be, completely, it's actually quite good to switch to oil-based media now. Preparation, how do we prepare these women? We ask her to void. We explain the procedure to her. You take a consent after you've explained the procedure. All of this is in the order of how it is written. You check your trolley again for all the things that I mentioned in my previous slide. Now the lady lies in the lithotomy position. As soon as she does this, we drape her first. I put a star there. The reason is that draping allows her anxiety to come down. And then we paint her. The painting is sort of, so anxiety, so she's covered. And now we are just prepping up the required area, which is her vulva and the bit of her perineum and the vagina with povidone iodine to clean it. Now, I haven't put my instrument in yet, my speculum in yet, but before I do this, I would want to choose my cannula. I would want to fill it with the dye and remove the air bubbles. And the reason is that I don't want to keep my speculum longer than is needed. All of these are measures to reduce her anxiety and reduce the pain. And both of these can be linked. And both of these can lead to a falsely positive blocks that appear on HSG very often, known as because of tubal spasms. So once all of this is done, cervix is exposed using speculum. Local anesthesia is given with xylocaine. It could be topical, it could be infiltrative, or it could be paracervical. We'll just look at it in a bit. I'll come to it in the next slide. Cervix is held with Valsalum now after injecting with local. And now you screw in the dye-filled cannula. The one we use is, of course, the Leach-Wilkinson's, which is why I use the word screw. You keep screwing it till an effective seal is reached, and a backward tuck should not dislodge it, should not pull it back any further. So the screws kind of fit into the crypts of the cervical canal. And so at this point, we'll just quickly talk about pain relief during HSG, what is effective. So what they have looked at is whether topical anesthesia over placebo is going to be any better. And mean difference in pain scores isn't very huge. It's just 0.42. So, I mean, maybe it might help, but it's not, don't expect a radically reduced pain score if you're using topical anesthesia. The second is locally injected anesthesia, which is sort of, you could just give it at the place where you hold her with the valsalem. So this is different from paracervical block. I'll come there too. And the difference in mean scores is slightly higher, 1.31. And then the paracervical block, which is actually giving it as high as possible at 4 positions, 2, 5, 8, and 11, and then you wait for it to act, and then you see. And this is even better than topical anesthesia. The mean difference in pain scores can be to a point of 3. But it has its own limitations. Sometimes sort of the dye goes inside the vessels, and that has a problem. We're not talking about the dye, we're talking about the anesthetic. It goes inside the vessel, and that can be problematic. Sometimes you could injure the vessel, and that could lead to bleeding. So unless you are sort of sure you are in the right place, don't use paracervical block, or unless you have enough experience. So topical anesthesia or locally injected anesthesia, which is closer to the external loss, is what one would want. Procedure, now you have straightened, and so you have screwed in the cannula, right? After giving some sort of pain relief measure. Now you straighten and reposition the patient under the machine. You push 1 to 2 ml to delineate the cavity. Take spot film. You push another 1 to 2 ml to see passage through the tubes. Take a spot film. Push slowly till bilateral spill is clean. A total of 5 to 10 ml of the contrast material may be needed. And finally, you remove the instruments. You may choose to take a delayed film after 2 to 5 minutes if the spill was not clearly demonstrated after it sort of came out of the tube, but it did not spread around. So if it did not spread around, you might want to take a delayed film 2 to 5 minutes later after you've removed all the instruments, and change the position to the right or to the left to see if it is freely moving in the pelvis. Now, this is a quick recap of what I have just talked about. And this is, if I had to explain it, I would call it, this is an HSG film of, that has used perhaps a balloon catheter, because it doesn't appear to be metallic to me. And it has outlined the uterine cavity in the first film. The second film shows a clear delineation of the uterine cavity with a clear delineation of the fundus, showing an absolutely normal fundus. The cavity, the walls are very clearly and sharply demarcated. There is no evidence of any synechia or space-occupying lesions within the cavity. The dye has now moved into the tubes all the way to its middle part, to its isthmus. And from there, you can see in the third film, it has moved clearly, delineating the longitudinal folds of the mucosa in the infundibulum and the ampulla. And the fourth film shows spill on both sides. So you might want to say that it hasn't fully spilled. Here is perhaps a case for taking a delayed film after I take out my instruments 2 or 3 minutes later. Now, post-procedure instructions, it's done. I'll check on the patient, check her pulse. Okay, she hasn't sort of reacted to it through a vasovagal attack, although rare, but you want to do that. Koi chakkar to nahi aa raha hai. I'll talk to her, inform her of the result. Now she can get up. Now, I may or may not choose to give her antibiotic course, but whatever the protocol is in our center, we want to give her a 3-day cover of oral antibiotic. The one we use is ofloxacin, and that should suffice. We also like to give a single dose of antibiotic before, oral again, before we start the procedure, at least half an hour to 1 hour before. So there might be some need for pain relief at this point. This pain relief could be through an oral tablet like a Buscopan. And of course, you'll hand over some emergency numbers to her that she may go home. But although it's less likely that she'll have a reaction later, but if she does, she knows where to come. Complications, procedural pain, and that's the biggest one. And procedural pain can be circumvented short of giving her a GA. And this is a big thing to state, which is what we do by taking these small measures, which is talking to her every step of the way, allaying her anxiety about the procedure, covering her, like what I said, prep her later, drape her first, talk to her about what to expect, use balloon catheters wherever you can instead of metal catheters, use of some form of immediate pain relief like intracervical xylocaine infiltration. So all of these will help sort of allay her anxiety, and the pain really, really lessens. You have to have some kind of feedback form to check on whether this was good or not, and whether they would recommend it in the same form to her sister or her friend. And most of them, if they say, yes, we were good, the pain that we experienced was less than what I thought it would be, I think it's a success. Vasovagal reaction can happen sometimes, secondary to pain. It's a rare reaction, rare complication. Of course, you have to have your emergency tray ready. Similarly for diallergy, which is even more lesser of a complication than the vasovagal reaction. You could have vasovaginal bleeding, largely because you've been rough in handling the cervix. And secondary infection, again, a rare complication because you haven't chosen your cases well, and you probably did it in a case of silent PID, which is not always possible to kind of determine. And sometimes it will still happen in 0.1 to 0.5% of cases. And inadvertent radiation to unknown pregnancy, again, perhaps you haven't chosen your case well, or you haven't done it at the right time. So now, this is a good question, and it's a practical point to take back home, right? And this practical point is, even though you're not asked of this in the examination, I want you to remember this. What is the effectiveness of HSG in diagnosing tubal block, right? Now, when HSG suggests a tubal obstruction, it will be confirmed by laparoscopy in 38% of cases. Now, this is given in the NICE guidelines, which is that it is not based on one study, but multiple studies. It is the pooled result of multiple studies, what does that mean? That 1 out of 3 women diagnosed as tubal block, only 1 will actually have it, 2 will not have it. Okay, now that is something you keep telling yourself, that my test is not always the truth. The test result is not always the truth. So I can give benefit of doubt to people who have not had a prior pelvic surgery, who have a short duration of infertility, and perhaps who are women who are anovulatory and are getting an HSG done even without trying any cycles of ovulation induction. So here, if it shows as bilateral corneal block or as some kind of block, I'm very willing to give her the benefit of doubt that my HSG technique was incorrect, or just sort of by the nature of the test, this is not a true result, that your tubes are open. And so I can sometimes say ki bahar se kara kar aayi hai, I can still give you a chance. If you are anovulatory, I'll still give her maybe 2 or 3 cycles of ovulation induction before taking her up for a repeat tubal test. Most of the women, such women conceive, believe you me. When HSG suggests tubal patency, confirmed at laparoscopy 94%. So it's a great test for tubal patency. It's not a very reliable indicator of tubal occlusion, right? When do you do laparoscopy as a first line? And this is a question you're often asked. As in bed, you bypass HSG entirely, where there is a history of PID, known adnexal masses on ultrasound, long duration infertility with normal semen analysis, and regular ovulation. And of course, you do it as a second line where HSG has said there's a problem, or there have been failure of 3 to 4 IUIs. There was nothing wrong in the HSG, but the lady is not willing for the next most effective treatment, which is IVF. And you find that, okay, maybe because she has good ovarian reserve, the semen is okay, I might find something on her laparoscopy, which I can correct, and then she can undertake maybe more cycles of IUI or whatever. So let's not go there. Yes, this is what I next want to compare it with. Hysterosalpingo contrast sonography is another modality of investigating the tubes. Now, a lot of radiologists will have us believe that it is like great. It is equivalent to HSG, which it is in diagnosing blocks and in sort of diagnosing patency. And there are different ways, air saline, gel foam, and you can click pictures or whatever. You probably get a video of this talk, so you can get all the information there. And so once you've used these contrast media, which you can see are different from the ones we use in HSG, now you need very special methods to recreate the images that HSG is able to create with that simple machine. 2D sonography will not give you the same imaging or results, the kind of pictures that you see on HSG. 3D sonography will also not. You need a 3D sonography with noise reduction, image filtration to get images like these. Now, these are Hi4C images, which have used 3D sonography with contrast noise reduction to get the images that you finally get on HSG. So I still say that, okay, it might be equivalent to HSG in its detection technique, but it requires a lot of expertise, a lot of sort of a high-level ultrasound machine to get there, to finally get and reproduce the same kind of images that an HSG does, right? We'll not go into this. We have done this, or we haven't, maybe. Okay, so oral opioids are another way of relieving pain. Intravenous opioids, we don't, so oral opioids, it says not effective. Intravenous opioids may improve pain relief during the procedure. Non-oral opioid, oral analgesics have no effect. So intravenous opioids, but it will make her a little dizzy. It may make her want to rest longer than is required. And sometimes we sort of still prefer what I have shown you in the past, which is use of infiltrative or topical Zylocaine, right? Now we come to radiographs quickly. There are 6 or 7, and you should be able to identify these when they are put in front of you. These are 4 radiographic images from the same woman showing, so these are hysterosalpingograms using Leach-Wilkinson's cannula. The first image shows delineation of the cavity. The second one shows delineation of the cavity with the tubes. And so far, things look okay. In the third one, you can see spill, but I would call it a restricted spill that even in the 4th film, it doesn't seem to have spilled great more than what should have happened. Like on the left, perhaps, you can see it in the pouch of Douglas here, but on the right, it seems to have concentrated around the ovary. So I would suspect adhesions on the right side in this case. Here is a film showing a space-occupying lesion right in the middle of the cavity. And you'd see that sometimes you need to distinguish this from air bubbles, which you inadvertently push through cannulas into the uterus. Air bubbles will keep moving on a fluoroscopic film. You'll see it in the middle, then you'll see it in the top, and then you'll probably see it moving through the tubes outside. But if you find it stable over 3 or 4 films, you know that it's there, it's right there, it's not a bubble. And here, in this case, it represents a synechia, as was later discovered through a hysteroscopy. Now, here you see that this fundus is overly depressed, right? Now, overly depressed funduses could also be normal. They could be arcuate, or they could be partial subseptate. And then there is a whole way of knowing this. And you could go into your classifications of ASRM or ESGE classification and look at the sort of the transcorneal line and the line that goes from the top to the highest layer of fundus, and then measure it 1.5. So I'm not going to go into that. So here it was found that this was a short septum, or it could be arcuate, and I'd want to maybe investigate this further only if she has a history of recurrent abortions. Otherwise, I'll just let her be. If she's a case of pure infertility, I'll not bother with this. Now, here is again 4 radiographic films from the same woman showing good division in the middle. It's going all the way down to the lower cavity. And here it could be a septum, it could be a biconjugate. You'd be asked to distinguish. And what is your sense based on this? And one of the things that you can use is this angulation between the 2 uterine cavities. If it is acute, you say it's septum. Most likely it is septum, but if it is kind of wide, none of this is showing a very wide one, you say that it is biconjugate. But now you'd want to use a 3D screening or an MRI film. MRI only if 3D ultrasound imaging has not been able to demonstrate anything useful to you. So 3D ultrasound imaging to distinguish a septate from a biconjugate, right? That would be the modality of choice if I got a film like this. Here, now, this is a classic biconjugate. In fact, it's a biconjugate showing there are 3 different images from 3 different women. It's not the same woman. Here you see that it is biconjugate unicollis. This is biconjugate, and the cannula is still in the cervix, but the cervix seems to be divided up to the top. And here it is still in the same cervix, the cannula. And this is a guide to me to tell me that, okay, it is still one cervix. It starts off as one cervix, but it divides as it goes up into two cervices. I would call it unique biconjugate bicollis. Partial bicollis. This is what I would call it. And here is biconjugate bicollis completely. And you can see that there are two HSG cannulas, one going in each. So there'll be two external osses in this case. What is happening here? Now, this is a very commonly reached picture where you see sort of connual block on both sides, bilateral. And like I said, we already have discussed this, that most of these are likely to be because of patient anxiety, too much pain, poorly done ultrasound, poorly done or poor technique, or not enough pressure being reached within the cavity for it to be pushed into the tubes. So how will I know this? You can see that a lot of it here, just around the cannula, has actually spilled into the vagina, right? So if there is a lot of spill into the vagina, this pressure in the uterus is not going to be enough to push the dye into the tubes. So I might want to change my cannula or maybe insert it. It's already gone in too much, but there's still enough space for it to leak out into the vagina. So I might want to maybe use a balloon catheter in this case to get a more effective seal. And here, this is another case. This is also a case of bilateral connual block, but you can see that the dye has gone into the vessels. And this is a case, why would it go in the vessel? Maybe because the pressure has to be enough, more than 120 millimeters of mercury, more than the systolic pressure, which blood pressure that the patient has, for it to go into the vessels. And why would that happen? Because you've pushed it too hard, that's all right. But normally you'd have intact mucosas, intact endometrium, which will prevent it from going into the vessels. But if the vascularity was high, or if there was broken mucosa, it's very likely that your little pressure is going to push it into the vessels. So this is likely after endometrial trauma or more likely after endometritis. So we are nearly done here. This is a uniconjugate uterus because the dye has only gone on one side. It's a classic example of uniconjugate. And this is also an example of the same lady who went through the example I've given here. It's a uniconjugate uterus with ipsilateral spill, but it is essential to ascertain the presence of a single cervix in this case to differentiate it from a biconjugate bicollis uterus with cannulation of only one-sided cervix, right? And this is a classic case of hydrosalpinx with no spill at all, terminal hydrosalpinx and terminal block. You'll be asked questions on that. This is a picture that is only possible. It's a mid-segment, bilateral mid-segment block, only possible with two conditions as per me. One is tubal ligation, and the other is something like tuberculosis. So I would want to, of course, check on her history and why this was done. This was basically an X-ray film that we were trying to look at what is her residual tubal length. So it's a clear-cut case. It's going all the way into the isthmus, and thereafter it stops. I think we'll stop there just with this last bit of information. Hysterosalpingography and radiation exposure. I told you we are doing it under fluoroscopic control these days to get a better sense of what's happening. In the past, we worked in institutes. I have worked in institutes where there used to be still films. They would take one film, go and check it, like pull out the thing and then check it under that. And they tell me, okay, this is what has happened. And while I'm waiting for about 5 minutes till this is happening, they say, okay, you need to push more. So another one would be done, a third one would be done. And the procedure would go on for maybe long periods, 15 minutes or 20 minutes. Now here, you are able to accomplish everything because you can see it live on the screen in 2 to 3 minutes, right? But it is continuous exposure and you're taking some stills as well. So if this was the average scenario with procedure lasting approximately 2 minutes and 6 radiographic stills, it would be 3 to 5 millisieverts of exposure, which, to get it in context, is the background radiation exposure which we experience. I mean, because we are in this world, there is some radiation exposure that we are all experiencing, which we experience over 1.6 years. So that is something you need to keep in mind, and which is also why you need to rule out a pregnancy before doing hysterosalpingography. Well, I'll end it here, and if there are any questions, I'm very happy to take them.
Thank you, ma'am.
Yeah.
Is there any question? Ma'am, there is one question from Bhavna Loda. He asked about the time interval between two STDs.
So, Bhavna, if you are on, can you specify what are the two HSGs you're talking about? So you're saying that if one was said bilateral corneal block, I'm just assuming this is what you're saying, and this was done elsewhere, and she came to you to what to do, and you decided, okay, this is a false block, and I can ascertain this. So you can undertake it based on patient willingness, maybe in the next cycle, whenever it's appropriate. So that shouldn't be a problem. Of course, you've ruled out all your indications, all your contraindications and stuff like that. So, however, if it is saying a bilateral corneal block in a woman who's had a past laparotomy or, intestinal obstruction, I wouldn't want to undertake a second HSG here, because now the likelihood that it is a true block is much higher. Okay. Right. Are there any other questions?
No, ma'am.
Okay.
Thank you so much, ma'am.
Thank
Now
you.
we are moving to next presenter. Dr. Kanika Jain and the endoscopic instruments. She is the senior consultant gynae endoscopy and robotic surgeon in minimal accessible gynecology unit. Over to you, Kanika, ma'am.
Yeah, thank you so much, Dr. Anusha. So am I audible?
Yes, ma'am.
Okay, so let me just start with screen share. How do I share the screen? So is my screen visible? Is my screen visible?
Not yet, ma'am. Yes, ma'am. Now it's visible.
इसमें आ रहा है but I'm sharing my screen. Okay. So hello everyone. I think it's 2 now, 2:05. So I hope you've all had your lunch and all. I'll just take half an hour, and we'll be through with the laparoscopic instruments. So basically, I'll be showing you I'll be showing you small video clippets to show the instruments as well as how they are used and how we set up the laparoscopy OT, right? So this is a video showing the patient positioning. So if you can see here, we have inflated a normal glove. Can you see my screen moving? Yeah. So this is just as a substitute to the gel pad that we have for the hands. And the hands are tucked by side of the patient so that the surgeon gets ample space to move around, to freely operate. So this is the position. The hands are tucked in, extension tubes are used so that the IV line and all are connected properly. And these are the Allen stirrups, which once we put in the leggings, then also we can manipulate. The surgeon can manipulate on their own. We don't need the assistance to put in a glove and do the procedure in a sterile way. Then we have the warmer attached, and that's the warmer. And so these are the stirrups. These are the Allen stirrups. what I was talking about, what we were trying to demonstrate. This is the handle through which we can elevate or depress the legs. I mean, manipulate the position of the legs of the patient. And these are the modified Allen stirrups, which we had made on our own, because these stirrups are very costly. So to economize, these are the ones we had created. And then definitely the gel paddings here support the calf muscles, and otherwise we use them externally. And the legs are tied onto these. This is the monitor, which is kept at the anesthesia end. We should always be very, very careful about the vitals of the patient once we are insufflating, and throughout surgery also we should keep a watch in between. Besides the anesthetist, we should also be alert. Now this is the video showing the insufflators and the monitors. I don't know why it's not playing. So, am I audible? I think this is not playing. I'll just skip this. So is this better? Maybe I can show through this. Is this better?
Yes, ma'am.
So I think rather than screen share, I'll show with this. So this is the Viris needle I'm trying to show. This is the disposable one, and these are the stainless steel needles. Basically, they have two parts, a needle and a stillet. So the stillet, the needle goes in and the stillet comes out the moment we have pierced the peritoneum. That is any tough structure that we are trying to hit. So there is a bevel on the needle, which is the cutting end, and the stillet comes out the moment the resistance has gone. So the moment we are inside the peritoneum, and the stillet comes out automatically with a recoil of the spring inside. And this is a preventive measure so that there is no trauma to the vital structures inside. And if you can see, there is a hole here, a small hole through which the gas and the fluid that we put in comes out. So this is another video. We are trying to show how we insufflate with the Viris needle. So we hold the anterior abdominal wall, and then with a small nick, we insert the needle. There are usually 3 clicks heard because of the 3 resistances that we meet. If it's the umbilicus, we just meet 2 resistances because the layers are fused together. So I put in a drop of saline, it went in because of the vacuum, it was sucked in, and then we connect the pressures, and we see that there should be less than 10 millimeters of mercury, which assures us that it is inside the peritoneal cavity. Then gently, first we leave the needle, then we leave the anterior abdominal wall. It should not be vice versa, otherwise the needle comes out. So these are the trocars. These are the non-optical trocars, which have a sharp pyramidal conical end to pierce the layers of the abdomen. And they are non-disposable. They can be reused, sterilized, and then reused. And these days, we usually use the disposable ones. Again, in the disposable ones, we have the optical and the non-optical. Optical, by optical trocar, I mean that the tip here, the conical end here is transparent. If it's transparent, then we can put in a camera while screwing in the trocar, and we can see the layers of the abdomen being pierced. And if it's like this has again a stillet to curve the blades, and the moment the pressure is applied, the sharp blades come out. It is a tri-flange sharp blade trocar, which come out once there is resistance in the abdominal wall. The moment the resistance goes, the moment we are in, this just comes out. The stillet comes out, and that's a protective mechanism. So this is 5 millimeter, and these are 10 millimeter. And this is the connector that we can use if we want to, through a 10 millimeter trocar, use a 5 millimeter instrument. Then these are the Hessen's trocars. Basically, you must be aware of the Hessen's technique of doing an open laparoscopy. So instead of doing a blind insertion inside, we cut the abdomen the layers under vision. So the incision is slightly around 2 centimeters or 2.5 centimeters. And then they have holes here on the side flange, which connect the rectus sheet to this, so that the trocar doesn't move and the gas doesn't leak. And these are the safe port entry points which we use in cases of scarred abdomens, like in cases of previous surgeries, something like previous appendicectomy or a previous cesarean or a previous laparotomy. So there are scars over the abdomen, in which case we anticipate that there'll be adhesions, omental and bowel adhesions to the previous scar areas. So they say that the Palmer's point is the safest and it doesn't encounter any adhesions most of the times. So we can safely go, which is 2 fingers below the left costal margin in the mid clavicular line. But then this port usually for pelvic surgeries becomes inoperable, useless, because it's very high up. So, and then there's a Li Huang points also. There also sometimes we encounter the falciform ligament. So this also is more useful for the surgeons who are operating onto the gallbladder and liver area. For us, this Jain point and the Palmer's point maybe are more useful, because here this is a point which is 3 centimeters below the subcostal border in the mid, it is the left paraumbilical region. At the level of the umbilicus, we draw a straight line, and then we draw a straight line upwards from 2.5 centimeters medial to the anterior superior iliac point. And the junction of these 2 points is the Jain point. This can be used for the pelvic surgery. Then we have this laparoscopic cord and telescope showing like this is the 0-degree telescope, and this is the 30-degree, if you can see, a little incline. So this is helpful to, if we are going straight, so this is helpful to see the angles. Like if the telescope is absolutely straight, like just imagine this is the telescope. If it's absolutely straight, then we'll have the vision equally from all sides. But if it's slightly angulated, we can see more focused area on one side. So that is why the 30-degree telescope is used. There is a 45-degree also available, but usually we prefer 30-degree. And if in the beginning with an inexperienced surgeon, 0-degree would be a preferable bet. And this is the 3-chip camera that we have for the 3 basic colors, that is red, green, and blue. And this has a resolution of 1080 pixels. And it has a prism assembly, a gold lens, and 3 sensors for the primary colors. Then this, we are trying to show an optical trocar entry. Am I audible? Am I audible? Am I audible?
Yes, you are audible.
Okay, Dr. Mala, बीच में कुछ बोलते रहो, नहीं तो मुझे लगता है मैं सिर्फ खाली कमरे को
नहीं. You are audible, very much audible.
Okay. So this is basically, I'm trying to show an optical trocar entry. So the scope was fixed with the trocar, and then as you screw in, you keep piercing the layers and they are all visible. And the moment we pierce the peritoneum, we can see the abdominal structures. And that is when we disconnect it and remove the trocar, and the cannula stays in. And then here, if you see, the gas I'm connecting, but I'm not opening. I'm not opening the stellate till I'm sure, and then you open. Now, this is another video showing the lateral port entry. So here we go under vision of the primary trocar, the camera. So this is the left lower port being made, a 5 millimeter port. Now it should go absolutely perpendicular to the abdominal wall. See, the entry should be absolutely perpendicular to the abdominal wall. There should be no tunneling. if there is tunneling, then there is bruising of the tissues of the patient, and there is extra force applied for the surgeon on the shoulder and the wrist. So there can be, these can be professional hazards for the surgeon as well as extra bruising for the patient. Now here, one of the commonest surgeries that we perform as a gynecologist is hysterectomy and myomectomy. So for this, we need these elevators. There are many available in the market, but the one that we use is this one, so which is shown in the figure. So one, we should check for all instruments. Now the difference between an open surgery and a laparoscopic surgery is mainly that we have to first check the trolley and see that all the instruments are insulated. They should have this insulation intact. Right now in the picture, if you can see, there is lack of insulation in this portion. So for the elevator, it still is not that harmful, but ideally all of them that I may have checked on a discarded one. This is the intact one. The insulation should be intact throughout. And this is the screw that we use to tighten the elevator at the cervical length. So we will first measure the uterocervical length, and then we apply this elevator. I'll just show you in a video how we use it. So this I have applied, I am taking a colpotomizer cup. So the colpotomizer cup is used here. It has holes. Just a second. And we attach it after measuring the uterocervical length. We attach it here, the colpotomizer cup, and then screw this elevator according to the uterocervical length. It is then fixed. And then after holding the anterior lip of cervix with the Alice or the valsellum and depressing the posterior vaginal wall with the Sims, we insert this tip into the cervix as far as it goes. Then slowly we remove the Sims, keeping this in place. Then we'll remove the Alice and push this in. So the cup, the colpotomizer cup I haven't got here, that encircles the cervix like this. And over the cup, we can do the colpotomy. It becomes very convenient. And then elevation and depression, anteversion, retroversion, and sideways movement of the uterus becomes very easy and guarded. We do not perforate if we apply pressure with this, because there is a guard. This is the guard that we have applied. The colpotomizer cup varies. The size varies according to the size of the cervix. They can be small, medium, or large. Now, these are the commonly used hand instruments for laparoscopy. So I can show you. Just a second, yeah. This is a disassembled instrument, and if you can see, what are the parts? We have a handle which has an attachment for it has a lead for the monopolar cautery if we require, like this. So this has a monopolar lead attached to it. Then we have an insulated outer sheath, and it has a cap here, this one, for allowing the gas and the fluid to come out if required. Then we have the insert, which is the main instrument here. And this is available in various sizes. Like for bariatric cases, we use the 45 centimeters. For normal laparoscopy cases, we use the 37 centimeters. For pediatric ones, we have the 20 centimeters or the 28 centimeters also available. And the handle, this is detachable. This handle can have a lock. Then it becomes a self-retaining instrument. I'll just show you. So this is the lock, which can be self-applied. The moment you tighten it up, it is self-applied, and you can just hold the instrument and lock it and keep it like that. So you can give it to the assistant to just retract. Or otherwise, if you're holding tough structures like the bolt, we can also use the lock in case required. Otherwise, it just goes with the a little, the ring finger, we can push it back and this is released. So this is usually applied for in cases of sharp instruments, the holding tough structures. And the blunt instruments usually do not have a lock. So I'll just now show you the tips of the instruments, what all are commonly used in laparoscopy. So this we are showing is the Maryland, which is the dissector. It is a counterpart of the fine artery forceps that we have in open surgeries, if we can see. And these are all rotatable. So we can rotate this knob and change the direction of the instrument for holding and for dissecting. So for dissecting fine structures like the UV fold or for skeletonizing the U-primes, or sometimes if you don't have two needle holders, we use one Maryland on the left hand and needle holder on the right for a right-handed person. And this works very fine. Then the next instrument shown here is the tooth grasper, which I just showed. This one. This has a ratchet lock with it, and it is a tooth. This has 2 serrations this side and 4 on this. So it holds tough structures, and it has plus on top of it, it has transverse serrations also, if you can see. The next shown is the flat grasper, which I don't have here. But what it has is, it doesn't have these serrations, but it has the transverse serrations. So it's a flat grasper, can be used to hold structures gently also, and a little bit of grasp also is there. This again is a non-traumatic grasper. That also I don't have here. This is the bowel grasper. And since it's shown in a transverse way, you cannot see the serrations, but on opening, you can see there are 2 serrations, fenestration, sorry, here. This is so that once we hold the bowel with it, in case by mistake somebody presses upon it, then the bowel can come out of this and it is not completely traumatized. It is not completely compressed and to make it devascularized. Because these fenestrations help in just getting out that extra tissue. So it is a very gentle grasper, it's slightly curved. Again, it has a rotating knob. So this is used to retract the bowel. It is used to hold the epiploicae. It can be used to hold the IP ligament, any gentle structure, even the tubes. So these are the commonly used instruments. Plus, these are the other tips that have been shown, which we commonly use. This is the Maryland, as I said. These are the scissors. Scissors are again of varying types. They can be non-disposable. They can be disposable. There can be parrot beak scissors, something like this, which is the hook scissors. These are very tough and sturdy. Like after we ligate the uterines in the TLH, then cutting the pedicles with this can be easy because otherwise it becomes tough. And cutting the vault also is easy with this. These are delicate scissors used for dissection and cutting. These are the tooth grasper that I showed. And these are the fenestrated ones. They have variations. This is another bowel grasper with fenestrations. Then this is another kind of serrated grasper. And this is a Babcock, like we have in open cases to hold the tubes and the delicate tubular structures for the ureters and the tubes. Then this is the crochet, as I just showed, this one. This is the tenaculum. It can be in 5 mm or 10 mm. I have here the 10 mm tenaculum. Again, to hold tough structures, and it also has a ratchet lock. So basically, we use the 10 mm tenaculum to hold the myomas in cases of myomectomy. So one person has to provide the counter traction. So this is for traction, counter traction. You hold the myoma with this and pull on it. So the surgeon can dissect and remove it from the capsule. So this, the use is this. Plus, in case of morcellation of the myoma also, these tenaculums are useful. Plus for tissue retrieval. Like we have to put the tissue into the endo bag and then pull out the endo bag. So we need a tough holding grasper. Tenaculum is used for that. This is a kind of a Babcock, you can say. This is a ureteric grasper, we call it. And it has it has a figure like this. So it holds the tubular structures and yet not traumatizes. Then these are the scissors, which are the disposable ones. You can see everything has a insulated sheets with it, and all these instruments, they have this monopolar lead, which here in this one we can see is covered by a red rubber cap. Otherwise, they are open, and the monopolar lead can be attached to any instrument, and it becomes a monopolar cutting instrument. Then these are the graspers. These are the traumatic ones, the one I showed, 10 mm. This is the non-traumatic, a similar grasper which has just transverse serrations on the tip, like this you can see, just 2-3 serrations here. And otherwise there are fenestrations. So this is a safer one, a non-traumatic grasper we call it. And this is the myoma screw. So this is the laparoscopic myoma screw, 5 mm. We have a 10 mm screw also. It's the same as the open myoma screw. You screw it in and then pull. This is the suction irrigation cannula. I'll show you. I have the lower one. This is this one. So with this change of direction, we can, this is in the center. That means there is no suction and no irrigation as of now. We pull it this side, so this one becomes functional. So you can attach either irrigation or suction here, depending on the choice of the surgeon. And or else you can attach it this way. You turn it this way and this becomes functional. So the connection is either like this or like this. So the other one is called the trumpet suction irrigation cannula. These knobs have to be pressed to move it to either the suction or the irrigation channel. These are the needle holders. See, all these instruments, I forgot to mention, these instruments should never be held like this, because otherwise, gradually over the years, you have then tenovitis here. So these instruments should also be held, always be held very gently like this. So the ring finger gently is put in to manipulate the instrument this way. Otherwise, there is no need to put any finger inside. This is the way to hold the instrument. Whenever you need to do something active, then you can put in your ring finger and manipulate. So, but for a needle holder, we need a tough grasp. We need to hold it strongly. And if we hold this strongly, either this will break or our hand will break. So the best thing is they are made this way. This is a ratchet lock again, and there is a knob here to release the lock. The moment we press the knob, this is released automatically with a spring action. So now this is a right-sided needle. This is a left-sided needle holder. If you see the direction, it is curved towards the right. So this is for a left-handed person. Somebody who is left-handed would be using this needle holder. I am a right-handed person, so I would prefer the curve to be on the left side. So because the needle is then held that way. And there are neutral needle holders also, which are straight, absolutely straight. Then there are needle holders which are self-riding. The self-riding needle holders have a sharp sort of tooth over here. And then in the middle, there is a curve. There is a kind of a groove. So that way they become the self-riding ones. The moment the needle is held and it is automatically taken into the groove and held in place. So self-riding needle holders, this is one non-self-riding. It has crisscross serrations inside to hold the needle and a lock. Then this is a short clippet showing how we use the needle holder. There is a strong hold here, and then we curve it to rotate the needle. So these are the skeletonized uterines that we are trying to ligate. So you see the needle holder is trying to pull onto the needle and the thread is being held with the merriments. Right, so this is the figure of 8 suture that I'm taking onto the uterines. Just forward it somehow. Right.
Sorry, ma'am, to interrupt, but ma'am, we are running late.
Okay, so fine. So we move to the next instrument. So these are the now proxy shore for laparoscopic endosuturing. And we have another one, which is the overstitch. So somebody who's not very confident about the endosuturing, these instruments can be used. I have 5 minutes till for the half an hour. So I'll just briefly tell you about the energy sources, basically the instruments, the hand instruments. I'm not going into the detail of the energy sources. We have electrosurgical, which has monopolar, bipolar, ultrasonic energy, and laser. So the principle of monopolar is that the earthing is basically used. We need a cautery pad to do the earthing. So the instrument is one end of the instrument is one pole of the monopolar, and the other thing goes through the earthing, that is through the body of the patient, and that is how the circuit is completed. So this is the monopolar hook which we use, and this is the bipolar. Bipolar, the principle is that the electricity goes from one end, goes into the circuit and comes out through the other. The moment we close the ends, the circuit is completed, and that is the principle of the bipolar. So these were videos showing the monopolar and bipolar. So bipolar technology is there is less potential damage, electrical damage and capacitative coupling, etc. to the body tissues. Then we have advanced bipolar devices, something like this, which is a ligashore. Now the principle is compression. The moment we hold the tissue in between, so if this is the tissue paper like we are holding, so this is compressed and then this is pressed and the circuit is completed. There is rise of temperature and plus the time to which it is required. The moment the seal is achieved, automatically the circuit is cut off. So these are the advanced devices, and this has a curved Maryland kind of a tip. Now the tip has a monopolar attachment and the rest of the thing is bipolar, and they have insulated sheets. So there is less chance of lateral spread and less chances of burn to the adjacent tissues in case the activated instrument touches them. So this is the force triad that we use for achieving this coagulation. I think this I can show just to demonstrate how the cut is achieved. So it has a scissors inside. These instruments, they have a built-in scissors. So they have a built-in scissors. The moment the coagulation is achieved, complete coagulation is achieved, we can just press this and the blade comes out through the in between the shaft. If you can see, there is a groove for the blade to come out. So the blade comes out and the sealed tissue is cut. So here in this video, you can see the way it is cut and the way, just see these serrations. The tissue also has serrations at the end, showing the effect of the coagulation. And so it's there is no blood oozing out and it becomes a bloodless surgery. Ultrasonic technology is the other one, in which we use the piezoelectric crystals and the blades, they vibrate at a frequency of 55,000 to 60,000 per second. So the electrical energy is converted to mechanical and mechanical is converted to heat energy. And that is how there is coaptation of blood vessels, which results in sealing. But ultrasonic devices are not too good vessel sealers as compared to the bipolar devices. So this is the commonly used instrument, harmonic. It has one insulated blade and the other one is the active blade. This is the one which vibrates. This is the one which needs to be put under vision all the time. And this is the one which gets heated up. And this is the one, the insulated one, which protects the other body tissues from the heat effect. And it has a vacuolation effect because the vaporization effect, the vapors created because of the sudden burst of the cells releases that air kind of a thing. And for UV fold dissection, it's very useful because that vaporization effect separates the layers. So the tissue planes are very easily separable. Then you must know about these. These are the smoke filters. Because of all these advanced energy devices and the other non-advanced ones, there is smoke created inside. which hampers the vision. So the smoke filters can be used. They were most useful in the COVID times in cases of emergency surgeries. These are the morcellators. So basically these are the parts of the morcellator, and these are the sharp blades which keep rotating at a speed, so that once we are pulling the tissue with the tenaculum put inside this cannula, the blade keeps churning that tissue and long pieces of myomas or whatever comes out. And these are the morcellator bags. So with these, we do the in-bag morcellation so that no spillage of the myoma occurs inside the abdominal or the pelvic cavity. And these are the endo bags. These have been used. So just for the photograph I had taken, these are the endo bags in which we retrieve the tissues. Then these are the port closure needles. So like all the 10 mm ports which are midline, or the more than 7 or 7 mm ports which are lateral, have to be closed. The rectus sheath has to be closed to prevent hernia. So these are the port closure devices, and these are the staplers. So this is a small clipper showing staple application. So for a 5 mm port, 1 staple is good enough. For the 10 mm ports, 2 staples may be required. So this, if you can see, there is perfect approximation. The incision should be given in the direction of the Langer's lines, and then the approximation is no problem. My time is over, just 2 minutes. These angles are very important. We have the manipulation angle, azimuth angle, and elevation angle. So these 3 angles must always be kept in mind to maintain a good working atmosphere and proper ergonomics. Otherwise, we will keep struggling inside the body, and the surgery will take more time. There will be more struggle. There will be more fatigue for the surgeon, and there will be less accuracy and less finish for the patient. So the manipulation angle should be minimum 30 degree. Ideally, it should be 60. The more than 90 of manipulation angle is very bad. The azimuth angle should also be approximately 30 degree minimum, and the elevation angle should be around 60 degree. So these are the angles. This is the elevation angle. Then this is the azimuth angle between the camera port and the operating port. This is the azimuth angle, and these two, between the 2 operating ports, the angle formed by these 2 instruments is the manipulation angle. So thank you. That's all. I couldn't cover the hysteroscopy part. I'm sorry.
Thank you so much, ma'am. It was a wonderful session.
So I'm stopping the sharing.
Okay, ma'am. Now let's move on to the next session, that is specimen, and that will be moderated by Dr. Indu, ma'am. Ma'am is a consultant and unit in charge of the Department of Obs and Gynae at ABVIMS and Dr. RML Hospital. Ma'am has special interest in gynae endoscopy surgery. We welcome you, ma'am. Ma'am, are you there?
Yeah.
Okay.
So can I share my screen? Is it visible?
Yes, ma'am, it is visible.
Is it full screen?
No, ma'am, it's not a full screen. Ma'am, the green one you have to.
Wait. Is it
Yes,
full
ma'am.
screen?
Yes, ma'am. Now it's full screen.
Thank you, Mala, and whole team for giving me the opportunities. Am I audible?
Yes, ma'am, you are audible.
Okay, it's clear, the voice.
Yeah, ma'am, it's clear voice.
So for the postgraduates, I just want to say that it's difficult to teach specimen, to postgraduates. For undergraduates, it's like you identify and you're asked few questions and then it's over. For postgraduates, identification is not a big thing. They are supposed to know because they have been doing this work for 3 years. So when we show specimens, it's just to start the viva in some direction. It could be some basic questions, or it can, if the student is doing very well, then it can move on to the recent advances also. So the specimens are just to start the viva, and don't think So I'll be coordinating with Dr. Saloni and Snigdha just for the smooth functioning, and maybe the others can also answer if they are not able to answer. So we'll move on to the specimen. Can you identify?
Ma'am, this is the specimen showing cluster of translucent vesicles and grape-like structure of varying size with areas of hemorrhage, suggestive of hydatiform mole.
So that's how you are supposed to describe when you are asked. Generally, this one won't have a differential diagnosis. And no, being gynae, MD Ops gynae students, I mean, you don't expect that the uterus would be shown. If a specimen like this is shown, obviously it's a case of hydatiform mole. So my slides are not moving. How do I? Slides are not moving.
मैम आप मेरे को शेयर कर दो, मैं यहाँ से चला के देख लेती हूँ।
नहीं, एक minute. I think I should be able to do it. Can I stop share and then do it again?
हाँ, I think retry.
Share. Okay. I don't know why it's not moving. Can somebody guide me, like why it's not moving?
Mr. Akshay, Vinod, मैम को please help करो.
Yeah, now it's moving. Yeah. Now it's moving. No, something was. Yeah, it's moving now. So identification has already been done. Now,
But the slides are not visible.
It's not visible, but on my end it's visible. What do I do?
Anyone there? Vinod, Mr. Vinod? Can you just guide the ma'am?
Make it full screen, ma'am.
And ma'am, just slideshow, yes. Yes, ma'am, now it's visible.
Okay, great. So, Dr. Saloni, how does the patient present to the clinician?
The most common presentation is amenorrhea with vaginal bleeding associated with passage of clots or vesicles, though other presentations could be abdominal pain, hyperemesis gravidarum, anemia, thyrotoxicosis, preeclampsia, and rarely respiratory distress.
So the commonest presentation is amenorrhea, bleeding, and maybe passage of vesicles. But these days, we are getting patients more in the first trimester who have been diagnosed by ultrasound. So, and the late presentation is usually not there, very rarely. So once you suspect, like Dr. Saloni, the height of uterus is more than amenorrhea, how do you confirm the diagnosis?
Ma'am, we'll confirm the diagnosis via ultrasound and beta HCG.
Yeah, so what do you see on ultrasound?
Ma'am, on ultrasound, we can see the multiple small cystic spaces called snowstorm appearance without any fetal part in complete mole and with few fetal parts in partial mole.
Any role of beta HCG in diagnosis?
Ma'am, beta HCG more than 1 lakh is suggestive of hydatiform mole.
So, it's not very diagnostic, but more than period of amenorrhea and more than 1 lakh, one should suspect that she could be a case of H-mole. But we diagnose ultrasound by ultrasound. Do you need any other imaging modality?
Ma'am, we can go for chest X-ray.
No. For diagnosis. So ultrasound is very diagnostic. Usually we don't need, So Dr. Snigdha, what are the differences between partial and complete mole?
Ma'am, in complete mole, the uterus size is more than the period of gestation without any fetal tissue. The karyotype is diploidy. HCG values are markedly elevated, and there are frequent medical complications.
What about partial mole?
In partial mode, the uterus size corresponds to the period of gestation with presence of fetal tissue. The karyotype is mainly triploidy and very unusual triploidy. The HCG values are moderately elevated and medical complications are rare.
So any difference in the prognosis, like a patient with a complete mole and a partial mole, which one you will be worried about?
Ma'am, in complete mole, there is a high chance of 15 to 20% in conversion to gestational trophoblastic neoplasia, where in a partial mole, there is a minimal chance, only 1 to 4%.
So your viva can go like this, This is slightly tutored one, but examiner can ask anything, So once you have made the diagnosis of H mole, complete H mole on ultrasound, what basic investigation would you order, Dr. Saloni?
Ma'am, we will order complete blood count, blood grouping of the patient, coagulation profile, LFTs, thyroid function test, ultrasound, beta HCG, and if the patient is dyspneic or symptomatic, we can also go for chest X-ray, ma'am.
Yeah, no harm getting X-ray chest done and other basic investigations, but nothing beyond that. So what would be your next step?
Ma'am, suction and evacuation is the treatment of choice for molar pregnancies. We will also arrange blood and blood products. And we will explain the high risk to the patient, and we will prefer ultrasound guidance suction evacuation for this patient, ma'am.
So Dr. Snigdha, the patients when they present, usually they are very anemic, even if they have not lost blood. Why are they so anemic? I mean, you will see hemoglobin 6-7 gram, and she may give history of slight bleeding PB. Why are they anemic?
Ma'am, due to hemorrhages in the trophoblastic tissue.
There is a lot of collection in between vesicles, blood loss. So they are anemic out of proportion. So as you said, suction evacuation is the treatment of choice, except when there is partial mole and it's more than 12 weeks, and then you can't do by suction evacuation. Otherwise, suction evacuation is the treatment of choice. Can we use prostaglandin or oxytocin? Like suppose I have a patient for tomorrow, can I put misoprostol in the morning before doing suction evacuation?
Ma'am, prostaglandin could be used for cervical priming in the patient before the procedure.
And what about oxytocin? Should I start?
Ma'am, oxytocin is not recommended prior to the start of procedure, but we can administer after the procedure when the patient is excessively bleeding.
Yeah. So only in patients who are bleeding excessively on the table, you can consider oxytocin. Otherwise, it's preferable to start oxytocin after you have completed the evacuation. Would you use ultrasound while doing evacuation?
Yes, ma'am. Ultrasound is preferred.
So
to avoid for the confirmation of the expulsion of the tissue, and also to avoid the perforation of the soft uterus, ma'am.
Okay. So once you have done the evacuation, when is the first sample sent for beta HCG? When do you send the first sample?
After 48 hours.
Yeah, first sample should be sent after 48 hours. And then how do you follow up, and why there is need for follow up in these patients?
Ma'am, there is a need for follow-up with this patient because there is a high chance of conversion to gestational trophoblastic neoplasia. We will be following up the patient with beta HCG values weekly. When the values revert back to normal within 56 days, we will be following the patient for 6 months. If it doesn't revert to normal within 56 days, we will be following up the patient after 6 months till the normalization occurs.
Okay, you can stop 6 months after beta HCG has returned to normal. So when can she plan next pregnancy? 6 months after beta HCG has returned to normal.
Yes, ma'am.
Or in case you had given chemotherapy, then why she has to wait for 1 year. So what would be the ideal contraception? Because you don't want her to get pregnant when she's under follow-up. So what contraception would you advise?
Ma'am, low-dose oral contraceptive pills are contraception of choice.
So you need a contraception which is 100%, almost 100% effective. It does not interfere with your follow-up, and there is no bleeding. Like if I use DMPA or POP pills, she might have breakthrough bleeding. Every time she would be running to the hospital, she has breakthrough bleeding. So it's better to use low-dose OCs, and they don't interfere with the follow-up. So what are indications for chemotherapy, Dr. Snigdha?
Ma'am, there are few indications for chemotherapy like rising beta HCG values, plateauing of the beta HCG values, invasive mole, choriocarcinoma, or there is any evidence of metastasis.
So you follow, and any time there is plateau or increase over a period of 3 weeks, that becomes an indication of chemotherapy. So we won't be discussing chemotherapy. We'll move on to the next specimen. So we have discussed, I think suction evacuation is a treatment of choice. Misoprostol can be given, arrange adequate blood. And another thing, use large size cannulas because they bleed profusely. If you start with number 8 and you'll take 1 hour to evacuate, do it under ultrasound guidance, and rest we have discussed now. So we'll move on to the next one. Dr. Saloni. So can you describe the specimen?
Ma'am, this is a cut section of uterus with cervix with bilateral fallopian tubes and right ovary, with large, well-circumscribed mass arising from posterior wall at the fundus, with a whorled appearance along with the necrotic areas suggestive of submucosal fibroid, along with multiple small intramural fibroids.
So whenever you are shown specimen like this, describe first uterus, cervix, pathology, and adnexa. Whether you can see both adnexa, both tubes, both ovaries. So you are supposed to, and then the questions would follow. It may be like this, like describe the specimen, already done. So what could have been the presenting symptom? No, we have done hysterectomy for this patient. What do you think she would have presented with?
Ma'am, most commonly the patient present with abnormal uterine bleeding, heavy menstrual bleeding, intermenstrual bleeding, pain abdomen.
Like in this patient, she's got a large submucosal fibroid. So,
Ma'am, she could have present with heavy menstrual bleeding, and as we can see, there is already oophorectomy and salpingectomy done. She can also present with postmenopausal bleeding.
No, don't go to menopausal. So, age of patient, what do you think would have been the age of the patient?
Ma'am, as the uterus and adnexa has been removed, the patient must have completed her family and must be of perimenopausal age.
So, would you remove ovaries in all perimenopausal? I don't think that's the right answer. Would you remove ovary in all perimenopausal patients?
No, ma'am, we don't
I
remove.
don't remove ovaries if I'm doing hysterectomy for a 48 years old. Are the ovaries functional after 48 years or not?
Ma'am, they could be functional for 5 years more.
Even
Until
after attainment of
till
menopause,
maximum 65 years.
So how do I decide which patients I would remove the ovaries,
Ma'am, if
Suppose
there
she
is any
48
presence.
years and she has submucosal fibroid. She's symptomatic. I have done the hysterectomy. So how do I decide whether I should remove the ovaries or not?
Ma'am, if there is presence of any high-risk factors for breast cancer, familial cancer, familial ovarian cancer, or any previous use of tamoxifen, we can go for oophorectomy along with this.
If she has high-risk factors for ovarian carcinoma. Okay.
Ovarian cancers, yes, ma'am.
Ovarian cancer, only then you remove. Otherwise, you can preserve ovaries in a 48 years old female. So all of us are doing self-injectomy these days at the time of hysterectomy. So Dr. Snigdha, can you tell me what is the difference between opportunistic prophylactic self-injectomy?
Ma'am, in
What we do is opportunistic or prophylactic,
Ma'am, along with any gynecological surgery, if we are removing the tubes without any risk factors, we are doing opportunistic salpingectomy. But in prophylactic, we specifically, in high risk patient, we specifically remove the tubes to decrease the risk of epithelial ovarian cancer.
In patients with high risk factors, when you remove the tubes, that is called prophylactic self-injectomy. So we'll move on to the next specimen. I think Dr. Snigdha, you can start description of the specimen.
Ma'am, it is a cut section of uterus with cervix with bilateral adnexa, showing a ill-defined growth, irregular papillary growth in the uterus with multiple areas of necrosis and hemorrhage suggestive of endometrial carcinoma.
Yeah, in a preserved specimen, don't try commenting on the myometrial invasion unless it's very clear, because it may not be possible. They are older preserved specimen. And you can see the adnexa, you can see the ovaries also in this, and you can see a growth at the fundus, which most probably is what?
Endometrial carcinoma, or it can be of degenerative fibroid or polyp.
Yes, looks like endometrial carcinoma.
Endometrial carcinoma.
So, Dr. Saloni, what are the high risk factors for development of endometrial carcinoma?
Endometrial carcinoma are 90% sporadic, which are associated with unopposed estrogen, like in obesity, nulliparity, late menopause, early menarche, Copper's cancer syndrome, which is associated with diabetes mellitus, hypertension, tamoxifen therapy, and 10% endometrial cancers are associated are familial, which are associated with HNPCC, Lynch syndrome, BRCA1 mutation, Cowden syndrome.
So actually, they already know the question, but that is what is expected from the students. Like, don't beat around the bush. Whatever is asked, be specific about the answers, you know. So how do these patients present and which age group, Dr. Snigdha?
Ma'am, they mainly present in postmenopausal age group with postmenopausal bleeding or purulent pervaginal discharge. If they are young, they can present with menometrorrhagia.
What is a common presenting? It's PMB, you know, postmenopausal bleeding.
Postmenopausal bleeding.
And in patients with high risk factors, they can present early also. What are we have already discussed? Okay. So, okay, no, I'll skip for this for the time being. We'll go to the new FIGO classification. When has this come? The latest classification of endometrial carcinoma?
It has come in 2023, ma'am.
So how is it different from the old classification?
Ma'am, they have incorporated molecular markers, histological classifications, and tumor spread, and for prognostication prognostication markers like like molecular markers, ma'am.
So postgraduates must understand that this classification might look slightly confusing, but in this, the histology type and molecular classification has added, and few sub class have been added, but you must know what is the relevance, even if you are not able to remember, but what is the relevance of new figure classification? Like you said, molecular classification. So how does addition of molecular classification help in prognosis? Dr. Snigdha?
Ma'am, molecular classification benefits in explaining the prognosis to the patient, because there are four types of molecular classification. There are four types. That is present pole aim, mismatch repair gene defect, P53, and non-specific tumor markers. Pole aim has the best prognosis, while P53 has the worst prognosis, while mismatch repair gene defect is an intermediate risk prognosis. Have intermediate prognosis now.
Okay. So that's good. And I think since it has been incorporated in the classification, so postgraduates are supposed to know at least what is molecular classification and what is the prognosis of various markers and what changes have been made in the new FIGO classification and why. So what are the treatment modalities for early endometrial carcinoma? Suppose it's stage 1, less than myometrium, less than 50% myometrium, growth is less than 2 centimeter. What would be the management?
Ma'am, treatment modality of choice for early endometrial carcinomas are a total abdominal hysterectomy with bilateral salpingo-oophorectomy with lymph node dissection and peritoneal washing.
That we will do staging, but should lymphadenectomy be done in all cases? When would
Ma'am, in stage 1A1, when the tumor size is less than 2 centimeter, we can exclude lymphadenectomy. In early stages, with grade 1 grade 1, that is less than 50% invasion, and if it is pole aim mutation present that is having a favorable prognosis, we can leave lymphadenectomy.
So that is only if you have done the molecular classification on the biopsy specimen. Okay. Only then you can say that she's pole mutation negative or positive, whatever. Okay. So what is sentinel lymph node biopsy? Dr. Saloni, can you tell me what is sentinel lymph node biopsy and what's its role?
Ma'am, sentinel lymph node biopsy is sentinel lymph node is basically the first node to drain. If it is negative, we assume that rest of the lymph nodes will be negative. But if it is positive, then entire nodal base should be removed. In sentinel lymph node biopsy, it can be done with the dyes or with the radioactive tracers. The dyes used are indocyanine green or isosulfan blue or methylene blue. The dyes are injected in the cervix at 3 and 9 o'clock position.
So we'll
And
move on to the next question because it's a long one. But postgraduates are now supposed to know role of sentinel lymph node biopsy, both in CA cervix and in CA endometrium. Okay. Suppose she's a case of early CA endometrium. Would you remove the ovaries, Snigdha? And how do you decide?
No, ma'am. In younger age group that is less than 40, we are supposed, and if she wants to preserve fertility and her fertility, we are not going to remove the
No,
ovaries.
suppose I am doing hysterectomy. So in case of endometrial carcinoma, you have to remove the ovaries, okay?
In early cancers, we are
Early cancers if you are doing conservative surgery.
Conservative.
Otherwise, if you are removing the uterus. So unless you want her to go for oocyte donation or something later on, but because there can be 3% chance concurrent ovarian involvement and C endometrium can spread to ovaries. Like this is different from CA cervix in which you can leave behind ovaries. So in endometrial carcinoma, you have to remove the ovaries. Okay. So it's TAH with BSO and that too extrafacial. Okay.
Yes, ma'am.
So we'll skip adjuvant therapy, but you should know, this just to the question can be asked, what are adjuvant therapy? We'll move on to the next. So the specimen on the left and right are different. I think Dr. Snigdha, you identify the specimen on the left of screen.
Ma'am, it is a cut section showing cervix with an irregular growth, irregular hyperemic growth with multiple hemorrhages from external os, suggestive of cervical carcinoma or any degenerative cervical polyp or any infective cervical pathology.
So you think the cervix would have been removed for a polyp? No, I mean, use your common sense. When you're
Yes,
shown
ma'am.
the specimen, I won't be removing the whole cervix for the polyp. What do you think is the nature of surgery?
Ma'am, it is mainly a radical trachelectomy.
Yeah, it's radical trachelectomy. So radical trachelectomy, when do you do radical trachelectomy?
Ma'am, when the size of the lesion is less than 2 centimeter and it is not involving the uterus and the patient wants to preserve her fertility and age is less than 40. And in the early stages
of
cervical cancer.
1A1,
1A1
and 2A. Radical trachelectomy should be done by a expert oncologist and not by a general gynecologist. Very rarely in a patient where she wants to preserve her fertility, it's a small lesion, stage 1A1 through 1B2, and it should not, the tumor should be away from the os, at least 1 centimeter margin away from the internal os on your imaging, and the lymph node should be negative. You remove the cervix. In radical trachelectomy, you remove cervix, you remove parametrium, and you can remove the vagina, upper 1/3 of vagina.
1 to 2 centimeters of vagina.
Yeah, 1 to 2 centimeter of vagina. Now, coming to the right side, Dr. Saloni, can you describe the specimen?
Ma'am, this is a this is a specimen showing uterus along with the cervix with an irregular growth rising from the external os of the cervix along with the bilateral adnexa, suggestive of a hysterectomized sample of cervical cancer.
Can you see the adnexa?
Ma'am, fallopian tubes and
if it's not clearly seen, don't describe, because in a CA cervix, so we might leave behind the ovaries. Okay. So the next question is, how do they present? Saloni.
Ma'am, in reproductive age group, the patient could present with the postcoital bleeding or the intermenstrual bleeding, and in the postmenopausal female, they could present with postmenopausal bleeding or vaginal discharge.
Usually, what is the age group in a carcinoma cervix?
It is the bimodal presentation, 35 to 39 years or after 60 to 69 or 64 years, ma'am.
So how do you confirm the diagnosis? Suppose you see the growth on the cervix. And initially, how do you confirm your diagnosis?
Ma'am, we can go for cervical biopsy for histopathology, pap smear, and colposcopy guided biopsy.
Snigdha. Suppose
Yes,
you
ma'am.
can see a growth, there is no role of pap smear.
Pap smear, yes, ma'am. We can directly send this tissue for
Pap
histopathology.
smear is a screening investigation.
Screening.
You have to take biopsy. And how do you take the biopsy? From which area the biopsy should be taken?
Ma'am, the area should include the lesion and and also the normal area surrounding it. From the normal and abnormal both.
Okay.
The margin contains.
Suppose the report comes as squamous cell carcinoma. So what investigation would you order? Because you want to stage the disease.
Pardon, ma'am?
Other than basic investigation, Saloni can answer. Saloni, what investigation? Suppose the report comes as CA cervix. She is 45 years old. So what surgery are you planning and what investigation would you order?
Ma'am, we will go for total abdominal hysterectomy along with the bilateral. She's a 45 years old female. Ma'am, we will go for the total abdominal hysterectomy with bilateral.
First tell me the investigation you would. What are you worried about? Snigdha, you can answer.
Ma'am, we can go for high modalities of investigations like MRI.
Would you
To
order
look for-
MRI or CT? I mean, what is the difference? What does MRI pick up and what does CT pick up?
Ma'am, CT, we will order a CT scan because CT is investigation of choice for lymph nodes involvement, ma'am.
What about MRI? What about parametry? And suppose I want to see the veins between bladder and rectum. I'm suspecting the bladder and rectum could be involved. Can CT help me?
No, ma'am. For that, we have to go for MRI, ma'am. For any soft tissue involvement, ma'am, we will have to go for
If
MRI.
one has facilities, PET CT is best. But for soft tissue, MRI is better. And for lymph node, CT is better. So what is the difference? The FIGO, when was the last FIGO staging? When was it revised?
19, ma'am, 2019. 1920.
Oh, 19, okay. So is it a clinical, surgical or pathological, the staging?
Mainly it is a clinical staging for cancer cervix.
So it was initially till the last 2018, it was clinical staging. But now the changes have been made that after surgery, after imaging modality and after pathology report, if you have all the facilities in developing countries, you can upstage the disease, because it will change the therapy. I mean, whatever you want to, even on the basis of imaging. Initially, FIGO recommended that you do only clinical staging, but now we can upstage the disease after imaging and surgical and pathological treatments. Okay. So we have already discussed. And Dr. Saloni, what are different types of hysterectomy? You gave a wrong answer, no? When I asked you, what will be the treatment if she's 45 years, CA cervix, let's say stage 1, C, B. So what are different types of hysterectomy?
Ma'am, different types of hysterectomy according to Piver-Routledge-Smith classification. There could be class 1, class 2, class 3, class 4, and class 5. Class 5 is no longer used, ma'am. In class 1, there is simple extrafacial hysterectomy. In class 2, there's modified radical hysterectomy. In class 3, there is radical hysterectomy. And class 4 also, there is radical hysterectomy. Ma'am, in class 1 extrafacial hysterectomy, the fascia of the cervix and lower uterine segment, which is rich in lymphatics, is removed with the uterus. And in class 2, there is uterine arteries ligated, and the uterosacral and cardinal ligaments are divided at the attachment of the sacrum and the pelvic side walls. And
So
upper 1/3 of the vagina is also resected, ma'am.
So this is the answer, but postgraduates are supposed, any other classification of types of hysterectomy?
Yes, ma'am. Yes, ma'am. Ma'am, there are 3 classifications. The other classification is, ma'am, Cordo and Moro classification, in which there is type A, type B, type C, and type D
This is just
hysterectomy.
to complete the list. Postgraduates are supposed to know what are the different classification systems. So, Dr. Snigdha, can you identify the specimen? How much
Sorry,
time
ma'am, to
do you spend?
interrupt. Ma'am, we have
So
to
I'll
end the
just do
session.
give me 2 minutes. I'll just do a spot diagnosis and move on.
Okay, okay, ma'am. Okay.
So,
Ma'am, it is a specimen with a thick walled structure showing showing teeth, hair, and fat fluids, suggestive of mature teratoma or dormant.
we can leave all this. So, what are the characteristic feature on ultrasound of a dermoid?
Ma'am, solid areas like Rokitansky protuberance are characteristics with dot and dash appearance, and fat fluid levels, hair fluid levels are shown are characteristic
Almost
features
a
of
spot diagnosis. Those who are experts, they can make a diagnosis. So, identify and differentiate between these two specimens. The one A1, what is that, Saloni?
Ma'am, the A specimen shows a specimen with the multiple loculi with thick septa with the with fluid filled in that with a smooth capsule, suggestive of mucinous cyst adenoma, ma'am.
So, can't it be carcinoma? Mucinous cyst adenocarcinoma.
It can be, ma'am. Ma'am, it can be, but it has to be ruled out with the.
What about right one?
Ma'am, at the right there is it is a multiple glistening small cysts seen in a capsulated structure with a variegated appearance, suggestive of serous cyst adenoma or adenocarcinoma, which has to be
So
ruled out.
we'll skip the question. Now we'll go to the what is this?
Ma'am, it shows a branching of cord and blood vessels through the fetal membranes before reaching of the placenta, suggestive of filamentous insertion of cord, ma'am.
What is the clinical relevance of filamentous insertion? Can you identify it by ultrasound, Priya?
Yes, yes, ma'am. We can, if the vessels would be lying just below the presenting part, then it could lead to fetal hemorrhage, which is a condition known as vasa previa, and it could be diagnosed with the ultrasound. And it can lead to oligohydramnios and IUGF.
Move on to the next. What is this?
Ma'am, this is a formalin preserved specimen of two fetuses shown in with a close proximity to each other and attached to each other at the level of thorax, suggestive of conjoined twin or thoracophagous.
Are they monochorionic or?
They are monochorionic.
And why do they form? Why does conjoined occur?
Ma'am, when the separation of or the division of zygote occurs beyond 12 days of fertilization, they results in conjoined twins.
So I'm just giving the type of questions which are asked on specimens. What is this?
Ma'am, this is a formalin preserved specimen showing a fetus without a cranial vault and exposed brain matter and protruding eyes, suggestive of anencephaly.
How soon can you diagnose by ultrasound?
Ma'am, by 11 weeks. 11 to 13. It could be diagnosed at 8 weeks of ultrasound, ma'am.
So with that, I think we end, and it's difficult to cover everything, but I have tried to give the type of questions which are asked, and it can move in any direction, the Viva. And thank you very much, Mala. And I think
Thank you so much,
graduates have
ma'am.
done very well. So
Thank you
try,
so much.
Thank you,
try
ma'am,
to
for the
give crisp answers, don't beat around the bush. Thank you.
Any questions?
Yeah, I can take it.
There is no any question in the chat box.
Okay.
Thank you so much, ma'am. Now let's move on to our next session, that is of the CTG. That will be taken by the Dr. Sumitra Bacchani, ma'am. Ma'am is a professor and senior specialist at BMMC and Safdarjung Hospital, and ma'am is a faculty fetal medicine and genetic clinic SGH. We welcome you, ma'am.
Thank you. Am I audible?
Yes, ma'am.
Is it visible?
Yes, ma'am, it's visible.
Put it on. Is that all right?
Yes, ma'am, it's visible.
Okay. So I'll start. So my talk is on CTG. CTG is a cardiotocograph. So what exactly are we measuring or looking at the graph? So we are looking at the movements of the fetal heart. So mind you, it is not a fetal ECG. It is basically the ultrasonic waves. When you put the probe on the mother's abdomen, there are certain ultrasonic waves which move into the fetus, and they are reflected by the movements of the fetal heart walls, and that is electronically it comes out as a graph, and we are interpreting that graph to understand the variabilities in the fetal heart rate, rhythm, and all that, so that we are able to ascertain if this fetus is under some kind of stress or there is some degree of hypoxia. So earlier, of course, we are all routinely doing it is what is called as intermittent auscultation, when we are using our own stethoscopes and hearing the fetal heart, right? But now then we have this electronic fetal monitoring, and this part of this is a very good modality which can be used, especially because it can be used continuously in certain cases. It can be used intermittent also, but most benefit is that we can put a mother who requires continuous monitoring on this kind of a machine. But the drawbacks are that the electronic fetal monitoring has been shown to reduce the incidence of neonatal seizures, but has failed to show any benefit in decreasing the perinatal mortality or the cerebral palsy. So there are currently interpretation errors can be there. Because there are observer variations, so there can be some degree of difference in the interpretation. There can be errors in the interpretation. So there is a need for significant reform in electronic fetal monitoring, with each aspect needs to be still examined and debated. So CTG cannot be a substitute, but it can definitely be a very good add-on to good clinical observation and judgment. So we are all the students must be all very familiar with this, and we are doing a CTG at the time of admission. We can do it intermittently in certain low-risk women if we need to, and in certain women we need to put them on continuous electronic fetal monitoring. So what are the indications when we should be doing a CTG? There are certain maternal and certain fetal indications. So maternal indications are if it is a preterm baby, mother's in labor, or it is a post-dated pregnancy. The labor has been induced for many reasons. Inductions of labor is being done. If the patient is on oxytocins, if there are associated maternal morbidities like diabetes, renal, cardiac disease, severe preeclampsia, it is a previously scarred uterus, and if there are hypertonic contractions, if the woman has been given epidural block, and sometimes on maternal request, and fetal indication could be that this is already a compromised fetus. Maybe it is a growth restricted baby, it is small for gestational age, and already there is some degree of Doppler abnormality. There can be a malpresentation in the sense it is a breech presentation, which can also go in for a vaginal delivery. With the fetus by per se also has some problem, like maybe there has been reduced fetal movements. It is a 2-vessel cord, so it is only a single umbilical artery, and there may be certain fetal structural abnormalities, such as some fetal cardiac defects like a TOF, where the baby needs to be immediately attended to post delivery. So we need to keep a very important a monitor on the fetal heart. So these are the various conditions on which we should be doing the CTG. So the most important thing is that this CTG is actually a medico-legal record. Don't take it lightly. Very, very important to keep a very accurate record, because if there is a hypoxic baby which comes out and there is a case, then it is the cardiotocograph which will be looked at. So make sure that the date and time clocks on the cardiotocograph monitor are set correctly. Label the traces with the patient's name, date of birth, and hospital number, and the date and the time, woman's pulse at the time of monitoring. Sometimes I have had seen 1 or 2 cases where there is an IUD and you are just taking the record of the uterine souffle, the maternal pulse. So one has to keep a very proper check on the mother's pulse. Keep cardiotocograph traces for 25 years if possible. Store them electronically, and sometimes if there's a concern that the baby may experience developmental delay, may have to store them indefinitely. So and we are all aware there have been few cases in the past. So the prerequisites when you want to do a CTG is that you must explain and take a verbal, permission from the lady. She should have an empty bladder. She can be in a lateral recumbent or a half sitting position also. And the acquisition of the trays by portable transducers, as I told you, that they can also be, and they can be a central station where all these signals can also be seen, and by the person who's sitting near the central monitor. Determine the lie-in position, always check the maternal pulse. And wherever you have found the fetal heart rate, you can place the probe there. If it is, as you know, CTG is also a cardiotocograph where you are also seeing the uterine contractions. You are actually assessing the fetal heart in relation to the uterine contraction. So there are two probes, and the other probe is going to record the uterine contractions. So to interpret a CTG, you need a structured method of assessing its various characteristics, and as per the RCOG, one can use this very popular acronym, which is known as DRC Bravado. DR stands for define the risk. Like if it is FGR, mother has severe preeclampsia, small for gestational age, whatever. Like you can define the risk, it's post-dated. Then contractions. You see if she is actually in active labor, what are the type of contractions? Are they hypertonic or normal? And then the baseline rate, variability, accelerations, decelerations. So we'll come to the definition of these, and then finally you give an overall impression, like whether it is normal, it is pathological, likewise. Now the fetus mostly, so however much we think that the fetus is, awake, most of the time the fetus is actually, there is quiescence, there is deep sleep, and at that time you will find a stable baseline. Rarely you will find accelerations and a borderline variability. Then active sleep or the REM sleep is the most frequent state, where you will find moderate accelerations and a good variability. However, wakefulness is actually rare, and when actually the fetus is awake, there can be large number of accelerations and a normal variability. So coming to the definitions, the fetal heart rate. The fetal heart rate, you have to look at the baseline and look at the baseline over a period of say 2 minutes, not very short intervals, at least over a period of 2 minutes. And then you can measure because you have to know the rate at which the paper or the graph is moving. Is it 1 centimeter per minute? Is it 3 centimeters per minute? So likewise, when you know the rate at which the paper is moving, you can see that this small one is actually 1 centimeter. So you will see if it is moving in 1 minute or it is moving in 3 minutes. And likewise, you will be able to you will be able to find out what is the fetal heart rate, because this is also, the markings are there on the y-axis. So here you can see the time along this line, and on the x-axis you find the time, on the y-axis you will find the rate, where you can see, where the baseline is touching. So here somewhere it is around 140. So you have to keep a check firstly on what is the baseline, and then if it is going above the baseline and anything above 160 is fetal tachycardia. Then the second thing you have to look at is variability. Anything above 160 is tachy, and anything about less than 110 is brady. So these are the two numbers which you must remember. Now the variability. What is variability? So variability is basically the fetus's response, to the type of blood flow which is there in the umbilical vein and in the umbilical artery, and accordingly the fetal heart rate keeps on changing. How are we going to study the variability? We are going to look at the variability in the number of beats per minute. So what we are going to see, so we are going to exclude the accelerations and the decelerations. We are only going to see the change in the fetal heart rate, excluding the acceleration and deceleration. So you will find what is maximum, what is minimum. Just divide the minimum from the maximum and you will know the variability. But here, mostly what we are doing is we are doing an eyeballing. We are not sitting and measuring. You can measure, but most of us and all of you also, I think when you keep looking at the graph, on eyeballing itself, you can tell whether it is a reduced variability or it is a normal variability, but it is a good thing to be able to measure and mention it on the graph too. So normal variability is between 5 to 25 beats per minute. Increased variability If it is associated with repetitive decelerations, then you may find that the hypoxia is evolving rapidly. Otherwise, when the fetus is awake, then there can be, and wakefulness can be associated with increased variability. Reduced variability is ominous, especially if it lasts for more than 50 minutes. This is a sinusoidal pattern where you find an undulating, very smooth kind of a graph, and this especially occurs in fetal anemia, which can be in RH isoimmunized pregnancies, fetal-maternal hemorrhages, or acute hypoxias. Pseudo-sinusoidal, a sawtooth, short-lasting normal trace has, maybe a normal feature, or it may be when there is a vasa previa or there is prolonged bleeding from the fetal vessels leading to fetal hypotension. Now, when we look at the variability, we can measure, and otherwise on eyeballing also, as I said, 5 to 25 is normal. Fewer than 5 beats per minute or more than 25 for a certain period of time should make us alert. And where we have to take action when there are fewer than 5 beats a minute for more than 50 minutes, or more than 25 beats a minute for more than 10 minutes, or there is a sinusoidal pattern. So these things you have to remember, that what is normal, where you have to become alert, that is amber, and where you have to immediately take action, that is red. Now, decelerations may be early, variable, or late. So early is gradual and it matches the peak of contraction. Variable is there is no relationship to the contraction. It falls very fast and comes up very fast too. Late is a gradual decrease in the fetal heart rate, and this fall occurs after the peak of contraction has passed. So very important that we have to see the decelerations as per the uterine contraction. And what is a prolonged decel? Anything lasting for more than 2 minutes is a prolonged deceleration, but less than 10 minutes. Why? Because when it is more than 10 minutes, that means the baseline has changed. So now, if it has actually come down to less than 110 and it is persisting for 10 minutes or more, we will say that is bradycardia. Right? So early decel, as I already said, early decel, we are not so worried because it is due to head compression where it leads to vagal stimulation, and this corresponds to the peak of the uterine contraction. Most of the times it is physiological. What we have to look at very carefully are the variable decelerations, because they are mostly V-shaped mostly, and they may be U-shaped or W-shaped also, and they come down very fast. So there is a rapid onset of this nadir. Nadir is what? That is the base of the deceleration. There is a rapid recovery. Most of the times variable decelerations are associated with cord compression. Cord compression, initially the vein which is thin walled gets compressed first, which leads to tachycardia, and that leads to this kind of a shouldering here. So the baroreceptors are activated. This kind of a shouldering which happens just before the contraction gives you a feeling of reassurance that the fetus's autonomic nervous system is functioning fine. So this shouldering occurs, and then finally when the uterine, the umbilical artery also gets compressed with the cord compression, there is a decel. And as the recovery occurs, again there will be a acceleration, and then it goes back to the baseline. So always look for shouldering when you are looking at the variable decel. That is most important. Then you should also see that what is the type of the deceleration is other than shouldering. What is the pattern? Is it a U pattern or is it a W pattern? So as I said, that without shoulders, it is most worrying, suggests that the fetus is now becoming hypoxic. So concerning characteristics of variable decels are that they are lasting for more than 60 seconds. So they are going down and lasting for longer, so not coming up immediately. There is reduced baseline variability. See this here, it is almost like a straight line. There is no variability. Then there is failure to return to the baseline. See, it is trying to come up and then going down again. So failure to return to the baseline, and biphasic, a W phase shape. So, and no shouldering. So these are the concerning characteristics. So whenever you are looking at a decel, just don't say that there is a dip. You see how much is the dip, you see the type of variability, you see the pattern, you see the presence or absence of shouldering. What are late decelerations? Mostly late decelerations are ominous. They are gradual in onset and they begin after the uterine contraction. And then they take a slow time to come back to again to the baseline. So this late deceleration definitely suggests that there is some degree of fetal hypoxia. And a prolonged decel is whatever, as I said, lasts for more than 2 minutes, but less than 10 minutes. So what are the non-reassuring decelerations? I've already, shared that. Look at the type of the decel and see the pattern in that. So if the variable decelerations do not have a concerning characteristic, but they are lasting for more than 1.5 hours, 90 minutes, then that is a cause of concern. If there are concerning characteristics in up to only 50% of contractions, but lasting for more than half an hour, again, concern. And if the variable decelerations are present in more than 50% of contractions, but lasting for less than 30 minutes, still that becomes a cause of concern. What do I mean by over 50%? Again, as I said, you look at the time, you see there are 10 contractions, uterine contractions, and you see how many decels are occurring. So if more than 50% of the contractions are covered by variable decelerations, immediately you should become alert. And late decelerations present in over 50% of contractions for less than 30 minutes with no maternal or fetal clinical factors are also significant. So these are the various things you have to look at: the time, how much decels are being, associated with contractions, and what is the degree of the nadir, how much below it is going and how much time it is taking for recovery, what is the pattern of the recovery. Sinusoidal pattern you will be immediately able to catch. This is an undulating smooth wave. And as I said, this is present at time in fetal anemias and severe fetal hypoxias. Go through the NICE guidelines and whatever these features which I have shared, I know you may have to just remember the time. It is easy to remember, not very difficult. So reassuring, there are variable decels, no concerning characteristics, everything fine, but less than 90 minutes. Non-reassuring, that there are variable decels, but more than 90 minutes. Variable decels with some concerning character you will see, which is lasting in more than 50% contractions. And variable decel if it is lasting for less than 50%, but lasting for a longer time. So I'm not going into the details again and again, but this way you will be able to see whether it is a reassuring, a non-reassuring pattern, or abnormal. So late decels are abnormal. So if they're lasting for 30 minutes or with no maternal risk factors, but less than 30 minutes with maternal risk factors, or there is acute bradycardia, means there is a prolonged decel for more than 3 minutes. So just go through this table and keep it in your mind. You will be able to see that. Quickly look at the CTG and you will be able to define, oh, this is a non-reassuring feature, this is actually an abnormal feature. And if you don't find any such thing, you can happily interpret it as a normal CTG. So what is normal? All features are reassuring. What is suspicious? There is one non-reassuring feature and two reassuring features. But note that if accelerations are present, fetal acidosis is unlikely. So accelerations are reassuring. Okay. And what is pathological? Pathological is one abnormal feature or two non-reassuring features. So keep this in mind to identify the type of feature, reassuring or non-reassuring, see the number, and you will be able to categorize the CTG. There are various reasons for other associated factors for fetal tachycardia, bradycardia, variability is decreased, or there is decel. So I'm sure that in your theory, you will be able to, go through this and identify. So what happens, that's why I said, define the risk. So if you know that the mother is having fever, or she has hyperthyroidism, or the baby is anemic as an RH isoimmunized pregnancy, or there is maternal abruption, then you can immediately correlate. So when you define the risk and then you interpret the CTG, then you are on a firmer ground. Then your interpretation will be correct. But you must remember, like things like if she is on some beta blockers, there can be brady. So you will not think that it is hypoxia. You know that mother has been on long term on beta blockers, and this can lead to fetal bradycardia. So that way you can interpret and take a decision. So always see the complete picture and also see whether the mother is in active labor, if there is associated maternal any morbidity. So this is the summary, that no hypoxia, everything fine, consider whether even if you want to continue with the CTG or you want to do intermittent auscultation. Chronic hypoxia, higher baseline than expected for gestational age. There is absence of acceleration. There are shallow decelerations. Then associated with it, if there is reduced fetal movement, maybe there was antepartum hemorrhage or there is post-maturity, then you have to think of expediting the delivery. Gradually evolving hypoxia means that there is a rise in the baseline with normal variability, but it is compensated. Okay. And decompensated is that there is reduced or increased variability. So variability becomes very important here. So variability will, if it is getting affected, that means that the baby is getting decompensated. So if it is compensated and you find that there was some tachycardia, but normal variability is present, now there's a rise in the baseline, but it is stable, you can still continue to monitor. But if you find that the variability is now showing abnormal pattern, you need to intervene. Subacute hypoxia may be associated with saltatory pattern. So again, subacute hypoxia, maybe she's on oxytocin. You need to stop that. If she's getting hypertonic contractions, you may have to give tocolysis. So again, see the maternal morbidity and then interpret. And in the second stage, subacute hypoxia, you need to expedite the delivery. Now, one important thing is acute hypoxia. You suddenly find there is a prolonged decel which is lasting for more than 3 minutes. Now, before this decel, what was happening? Was everything normal? Well, if it was, everything was normal, there was cycling and normal variability before this decel, then, and suddenly there is a decel which has come, then you have to exclude 3 accidents. And very, very important, you have to immediately rule out cord prolapse, placental abruption, and uterine rupture. So these 3 things you must keep in mind. You are looking at a normal CTG, suddenly you find that there is a prolonged deceleration. So if something was correctable in this case, we could have done, but if these are acute emergencies, we have to immediately intervene. And if it is some correctable cause, then we correct. And so there is a 3-minute rule that we give, we put her in lateral, we give her fluids, and then we wait. And if it recovers, it's fine. But if there is no improvement by 9 minutes, there has to be an immediate delivery. Within 12 minutes, you should have taken out that baby. If you are unable to ascertain, then you must refer to your senior. So this was a low risk. So you may look at this and say that, well, this looks abnormal. This was just a low risk primary spontaneous labor, and she had been given epidural. So a little bit of maternal hypotension leading to this kind of a this thing. The baseline, as you can see, is around, say, 90. Few accelerations are also there. So once the mother was resuscitated, she was given fluids and put in lateral position, it became all right. This is also a normal fetal heart rate, which is associated with normal fetal movements. Now look at this. This is important. Low risk primary 6 centimeters. And you find here this kind of a decel. So here you will see there is loss of variability, and see how the return to the baseline has become slower. This is almost become U-shaped. So this is one, and this is another one, both of them having abnormal variability. So here also you can see this kind of a W pattern. Now you have to see how many such decels are occurring in relation to the number of contractions. As I already told you, if it is present in more than 50%, likewise here, can you see? So more decels are there, more than 50%, then it becomes lasting for 30 minutes, then it becomes omnious. So likewise here also you can see that these are the variable ones, and see how many contractions are there. As I said that you must see the time, what is the, how it is, the rate of the graph. So stop oxytocin, here you find adopt left lateral, oxygen may be required, IV fluid bolus. If mother is having hypotension, as I said, after maybe giving an epidural, may have to give vasopressors, right? So, and if it is hypertonic, you may have to give tocolysis. So likewise, your CTG can tell you what action you need to take. Now, this was a primary gravida at 40 weeks, 2 days gestation. She had been induced. And then she was on syntocinon 32 MIU per minute. She was getting good contractions. Now in the second stage of labor, this was the CTG. So she is getting good contractions. See the decelerations which are happening more than 50%, almost covering each contraction. So, but because she was getting very good contractions, she quickly progressed to full dilatation at 0 station. And once the head came down a bit more, there was a vent house delivery and we could deliver. So we could immediately take action. This is primigravida meconium stained liquor at 4 centimeters, and you see the variability. There is hardly any variability. She is getting good contractions, but there is hardly any variability here. So here we need to intervene and deliver this baby. Now here again, see IUI conception on syntocinon 8 centimeters dilated. See how much the nadir is and how much time it is taking to revert back. So again, immediate intervention required. 32 weeks. Now this is a preterm. So what happens in preterm? Admitted with decreased fetal movements. So in preterm, we need to interpret the CTG in a different manner. Here, you may find that there is a higher heart rate, and with advancing gestation, gradual decrease in baseline fetal heart rate can be noted. Then accelerations can be noted after 25 weeks, but the accelerations amplitude is reduced to 10 beats per minute, lasting for 10 seconds. Similarly, variability is also reduced, and decelerations may occur in the absence of uterine contractions also. So this pattern you need to keep in mind in case it is a preterm baby. Now, another 31-year-old third gravida at term gestation was being induced. On per abdomen examination, the uterine tone was increased. There was mild tenderness and fetal heart dropped to 90. Now, what happened here? So you see here, as I was telling you, that things were going fine and suddenly there is a drop and you find a prolonged decel. So what should you think? Again, as I said, cord prolapse, abruption or rupture. And accordingly, you have to take action. So this is the 3-minute rule that if there is a prolonged decel, review the clinical circumstances, do appropriate interventions. 90% recovery will occur if there is no pathology. Alert the theater staff. Within 9 minutes, 95% should show signs of recovery, but move her to the theater. And 12 minutes commence anesthetic procedure if there is no recovery, and you observe the CTG there. By 15 minutes, if it is still abnormal, you have to deliver. Okay, either by cesarean or if the baby is down and is fully dilated, by assisted instrumental vaginal delivery. So 3-minute rule you must know. 39 weeks, 5 days, term size fetus, getting moderate contractions, head at 0 station, and decision was for ARM was taken to augment the labor. After ARM, there was bleeding through the os. And what do you see here? See, so this is a sinusoidal pattern. So there was abruption, there was fetal anemia, and one of the cases there was sudden IUD also. So that is one thing you can keep in mind, that sinusoidal pattern becomes another ominous sign. So keep this in mind, whether it is green, it is amber, or it is red, and accordingly take action. So nowadays, there is something very new which has come up, and that is CCTG. But CCTG is not used in labor. It is only used in the antenatal period. And CCTG is a computerized CTG. So the computer interprets the fetal heart rate variations. So that I was not included in this because that is only part of the antenatal monitoring, and it is available in 1 or 2 centers in India. So maybe once, if there is some other opportunity, I will be able to share more about that. But since this was more about CTG, a woman in labor, so I just thought I'll mention it here. Thank you.
Thank you so much, ma'am, for such an elaborative session. Any question? Ma'am, there is the one, please show the preterm slide once more.
Sorry, actually, I'm also looking for it.
Okay, no problem.
Actually, I think I'd mentioned it. Yeah, these are the features, you know. This you can take a screenshot of. So in a preterm baby, you know, the heart rate, the accelerations, the variability, this you can, you know, take a screenshot and keep it. Is that okay?
Okay, ma'am. I don't see any other question in the chat box.
Okay. Thank you so much.
Thank you so much, ma'am. Now let us move on to the last session of the Gurukul, the case presentation on primary amenorrhea. For that, the case will be presented by Dr. Spurti. Dr. Spurti, are you there?
Yes, ma'am.
Okay. Dr. Spurti, first year DNB resident, and Dr. Payal, our second year DNB resident. And to moderate the case, I would like to invite Dr. Shweta Gupta, ma'am. Ma'am is an senior consultant at the Center of IVF and Human Reproduction at Sir Gangaram Hospital. She is a treasurer at Indian Fertility Society and convener at Reproductive Endocrinology Special Interest Group, IFS. We welcome you, ma'am. The next moderator is Dr. Meenu Agrawal, ma'am. Ma'am is a president at Pune Obstetrics and Gynecological Society 2023-2024, elected as a Secretary General at the International Society of the Gynecological Endoscopy. Ma'am is a chairperson of Imaging Science Committee, FOXY 2018-2021. We welcome you, ma'am.
Yeah.
And the moderator, third moderator for this case is the Dr. Rupali Basti, ma'am. Ma'am is a senior consultant at the Department of OBGY, Indraprastha Apollo Hospital, New Delhi. We welcome you, ma'am.
Thank you. Thank you.
Okay. Dr. Payal, just share the screen and start your case.
Yes, ma'am. Good evening, everyone. Are we audible, ma'am?
Yes, you're audible.
Good evening, everyone. Today, our case presentation is on the topic primary amenorrhea, presented by me, Dr. Payal Hooda, and Dr. Spurti, residents of Sir Gangaram Hospital. A patient, Miss X, 16 years old, from New Delhi, Hindu by religion, belonging to socio-economic class 4, according to modified Kupuswamy scale, studied up to 12th standard. She presented to us with complaints of failure to menstruate till date. History of present illness. Patient came with the complaint of absence of attainment of menstruation. History of onset of pubic hair and breast development around 12 to 13 years of age. There was no history of cyclical abdominal pain, urinary retention, and no history of loss of smell or hearing loss. No complaint of headache, visual disturbance, and vomiting. No complaint of secretions from the breast. There was no complaint of significant weight loss, vigorous exercise, stress, and eating disorders. No complaint of increased facial hair, acne, hoarseness of voice, hyperpigmentation of the neck and skin. There was no complaint of swelling in the inguinal region, no complaint of weight gain, constipation, and heat tolerance. No complaint of evening rise of temperature and chronic cough. No complaint of any drug intake or any history of chemotherapy or radiotherapy. There was no history of head injury or skull injury in past, no history of malnutrition or starvation, and there was no history of any other chronic illness. Family history. Her mother attained menarche at the age of 14 years. There was no developmental delay or menstrual irregularities in female siblings and cousins in the family. There was no history of tuberculosis, diabetes, hypertensive disorders, asthma, thyroid disorders, and PCOS in the family. Past history, past medical history. She's not a known case of diabetes mellitus, hypertension, tuberculosis, thyroid disorder, and any history of meningitis in childhood. No history of any long-term medication. Past surgical history, no history of any abdominopelvic surgeries in the past. Personal history. Her appetite is normal, bowel and bladder habits are regular, sleep is normal, and no history of any smoking, drug abuse, and alcohol intake.
On physical examination, her height is 154 centimeter, weight is 42 kgs. So BMI is 17.7 kg per meter square. She is moderately built and well nourished. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. There were no signs of hyperandrogenism like hirsutism, acne, male pattern balding. Temperature was 98 °F. Her blood pressure was 110/70. Her pulse rate was 78 beats per minute, which was regular in rhythm and normal volume. Respiratory rate was 16 cycles per minute. Breast examination showed Tanner staging 4 and there were no secretions from the nipple. Axillary hair was of Tanner staging 4. Hair distribution over the body was normal. Thyroid examination normal. Spine and gait was also normal. On systemic examination, CVS, S1, S2 were heard and there were no added murmurs. On RS, bilateral vesicular breath sound heard. CNS, there were no abnormality detected. On poor abdomen, soft, non-tender, and no mass were palpable. In the inguinal region, there were no mass palpable. Coming to the genital examination, on the local examination, external genitalia, pubic hair was of Tanner stage 4. Labia majora and minora were normal. External urethral meatus was normal. There was no clitoromegaly seen. Vaginal orifice appeared as a dimple, and per speculum and per vaginal examination was not done. Per rectal examination, there was no mass felt anteriorly. Summary of a case: 16-year-old Miss X, belonging to socioeconomic class 4, came with the chief complaint of failure to attain menarche with normal secondary sexual characteristics, with examination findings suggestive of Mullerian oogenesis.
Yeah, very nice presentation, both of you, because you have actually covered everything in your nice history. So how will you manage, how will you further investigate this case?
Ma'am, we'll start from the history taking, and further, as we have seen, we have done PR examination also. There was no uterus palpable anteriorly. So next thing is we'll do karyotyping. So we'll do ultrasound first, and if there's no uterus present, then we'll do karyotyping. In karyotyping, if it is 46XX, then it will be Mullerian. It can be considered as MRKH syndrome, and if it is 46XY, then it can be AIS also, androgen insensitive syndrome.
Okay. Now, who are the, yeah, Dr. Rupali, you want to say something?
Yeah. Any more investigations you'd like to do apart from this?
Ma'am, we'll do ultrasound KUB.
Sorry? Yes?
Ultrasound KUB, ma'am, and X-ray spine we can also do if you're suspecting Mullerian oogenesis.
Any other reason can also be taken along with this?
Sorry, ma'am?
Could you think of any other pathology along with Mullerian oogenesis also? Your patient is highly underweight, 17.7 is the BMI, you said, right?
Yes, ma'am.
Yes, ma'am.
Yes. So, any other investigations you'd like to do? Would you not like to do some routine
Ma'am,
investigations? Yes.
ma'am, we can test for hormonal. We can do hormonal testing, ma'am.
Yes.
No, suppose they have done her, suppose you could see the uterus in this case. Okay, I'm giving another hypothetical situation.
Yes,
And
ma'am.
you have done her FSH and LH values, and FSH and LH is low.
Yes, ma'am.
What next will you do? How will you manage? How will you treat? And what is the prognosis?
Ma'am, we'll start with the history. We'll ask the patient whether she's having any visual field defects, any complaints of olfactory disorders, any history of trauma of the brain in the past, any surgical history of brain in the past, any infections in childhood such as meningitis, any
history of
and
anosmia. We can rule out Kalman syndrome also, ma'am.
And we can do her fundus examination also, and visual field perimetry.
So you have done all of that. Now
Yes,
you have done her FSH and LH, and FSH is low, LH is low, her uterus is okay, her ovaries are fine, her AMH is okay.
Yes,
Now,
ma'am.
what next? How will you manage this patient?
Ma'am, according to the condition, we'll manage the patient. If it is hypothalamic, if any hypothalamic disorder is there, then we'll manage accordingly. We'll treat. There can be any hypothalamic tumors also. Then we have to take the patient for surgery. There can be involvement of pituitary also. There can be tumors of pituitary, and the patient can also have the eating disorders, anorexia nervosa. And it can also occur because of excessive stress and exercise. So we have to figure out what is the cause, and accordingly, ma'am, will treat.
Yeah, so she is a hypo. Now,
Yes.
hypo could be because of anorexia nervosa, could be because sometimes primary hypo can also be there. How will you treat her? What will you do? What will you give her?
Ma'am, pulsatile
pulsatile
GnRH.
GnRH.
I'm sorry?
Pulsatile GnRH, ma'am.
कितने का आता है? Is it available? कितना
Ma'am.
यूज किया है आपने pulsatile GnRH? Have you ever used pulsatile GnRH? So where is the effect? The effect is on the end organ, right?
Yes,
Yes,
ma'am.
ma'am.
On the ovary.
GnR is acting on the hypothalamus, the pituitary. The pituitary is not able to secrete FSH and LH. Okay.
Yes, ma'am.
It is not able to act on the ovaries. So ovaries are not producing estrogen and progesterone, which
Yes,
is not
ma'am.
acting on the uterus. So what
Yes.
is lacking in the end point? Kya hai? What is lacking?
Rather than giving an easier option, rather than giving
So
GnRH,
We can give recombinant FSH, ma'am.
no. Why will you give recombinant FSH?
Easier than that.
Estrogen. Okay.
Yes, because we want an effect on the uterus.
Yes,
Right?
ma'am. Hmm.
Cyclical.
Okay, so you give them estrogen plus progesterone cyclically till when? For
Ma'am,
how
till,
long you give it?
ma'am, till she develops the secondary sexual characteristics.
That are all. That is
She
already
has the secondary sexual characteristics. No. Now you give her estrogen and progesterone. Suppose her hypo is because of her anorexia nervosa or because of severe weight loss or because of any hypothalamic disorder. Till you treat that disorder, you continue her on estrogen and progesterone. Okay, so she gets her regular cycles, and by the time she's put on 5 kilos of weight, her own system will start working.
Yes,
Yes, ma'am.
However, if it is a primary hypo, then till when will you give her estrogen and progesterone?
Ma'am, till she attains puberty.
Till she wants to have a child. She is 15 years old now. She does not want to have a baby till the age of 25. Till then, you will counsel the parents, counsel her. You continue giving her estrogen and progesterone. And when she wants to have a baby, what will you give her at that point of time?
Progesterone.
Sorry?
Progesterone, ma'am.
Progesterone.
No, you would want to give her some hormones so that the eggs become
Is
active.
hypo. So the pituitary is not secreting FSH-LH. So you will give her HMG or FSH.
Yes, ma'am, HMG.
Okay, so you can give her HMG and then the ovaries will produce, but you don't want to give it earlier because you don't want to spend so much of money where you can work with just estrogen and progesterone.
Yes, ma'am.
When she wants to ovulate, then you will add HMG to her. Now, suppose this young girl, now she is 31 years of age, she wants to have a child, but husband has oligoasthenoteratospermia, so she's going for ICSI.
Okay, ma'am.
Okay.
So now this particular patient, how will your stimulation protocol change for her as compared to another patient?
So what do you give in a normal patient who's undergoing IVF? You would have seen ovarian stimulation cycles. What do you
Yes,
give in
ma'am.
the initial half? Do you give some hormone?
Letrozole.
Give some
Yes,
hormone
ma'am.
in IVF.
Ma'am.
What is the hormone you give?
Ma'am, we give ovulation. There are other ovulation induction agents.
No, for an IVF, not for an IUI. What do you give for an IVF in a normal
Clomiphene
patient?
citrate.
But say you don't give any
HMG.
FSH.
Yes, ma'am.
But in
Polysurge.
case of a hypogonadotropic hypogonadism, you would not want to give them FSH alone. You would want to give them HMG because
HMG,
they
ma'am.
need some amount of LH. HMG is a
LH.
combination of
75 international unit FSH and
FSH.
75 international
yeah,
LH.
that's what Dr. Meenu said.
So in a normal patient of IVF, you need to down-regulate the LH surge by giving them either agonist or antagonist at some point of time, which will not be required in a hypo patient because she's already down-regulated. She does not have a spontaneous LH surge, which we may be scared of in a patient where we are stimulating the patient. Now, suppose this patient, now that patient we are talking, suppose her karyotyping is showing XY.
Yes,
What
ma'am.
would be your next step?
Ma'am, it could be androgen insensitivity syndrome. Then
So what is
first,
the difference in the characteristics which you have shown in your
ma'am,
patient?
in androgen insensitive, ma'am,
I
in
mean-
case of androgen insensitive syndrome, pubic hair and axillary hair will be sparse.
Yes, and the breasts would be
Breast will
Developed,
be
ma'am.
developed, ma'am.
What about the height? The height would be
Height will be
Height will
normal,
be
ma'am.
tall,
normal
ma'am.
height, or tall girls. Yes, yes. And
They're actually
externally,
very
what do you see
beautiful
there?
girls. They're actually very
Externally?
beautiful girls.
Yeah. Externally, what do you see in the external genitalia?
And female
Genitalia,
genitalia
ma'am,
will
in
be
case
present,
of
ma'am.
complete androgen
Aligned
insensitive
vagina,
syndrome, it
yes.
is complete.
And
Yes,
in
ma'am.
partial, it is ambiguous genitalia, ma'am.
Yes. Okay. So yes, we go further. What will you do if you find that it's XY? Will you do something active?
Yes, ma'am. Ma'am, we have to do the gonadectomy because these patients are more likely to develop the gonadoblastoma and dysgerminoma and other germ cell tumors, ma'am.
Excellent. Very good. Very good.
So where are the testes situated in these patients?
Ma'am,
I
in
mean, the
inguinal
abdo-
canal, these are not descended
Yes, ma'am, they are
because
not
there is
descended.
So how do you
Yes,
you put in your laparoscope, then you will find the inguinal. You will also find a round ligament and that spermatic cord of the round ligament. You pull on that, and suppose you're not able to take it into the intraperitoneal. So what you do is ask your assistant to give a pressure on the inguinal canal. नीचे से thumb से inguinal canal को press. The moment they press it, the testes very nicely come intra-abdominally, and then you gonadectomy.
Next, ma'am.
What was the findings? What about the hormonal profile in your patient?
ma'am, hormonal profile was normal, ma'am.
It was normal. That means the patient had normal ovaries. What was
Yes,
the
yes, ma'am.
HLH in your 16-year-old amenorrhea patient? I want to know the values. You must have had the values, right?
Yes, ma'am, but ma'am, we have not
You don't
mentioned
have
it.
the test.
Yes, ma'am.
All right.
Okay, now she's 15-year-old. Okay, so you will also do a 3D ultrasound or an MRI to see what is the vaginal length for her, right?
Yes, ma'am.
Yes, ma'am.
Okay. So now she wants to get married. Husband knows about that she does not, and she has good ovaries, right, in your patient, right? So she can go for a surrogacy at a later
Surrogacy,
time.
yes, ma'am.
How will you manage the sexual function for her? What are the various options that you will?
Ma'am, there
We can give a
are non-surgical methods, and surgical methods
methods.
will start with the non-surgical methods before the marriage, which is done by the dilators or the molds, which we have to tell the patient she has to start using with the smaller size, which will gradually increase to the larger size, and she has to use it for about 20 to 30 minutes at least 3 times a day.
20 to 30 minutes is usually not possible, but yeah, okay. Gradually increase it.
Gradually
Yes,
increase,
ma'am.
yes,
Ma'am,
ma'am.
then and ma'am, we'll offer her the surgical.
Ultimately, we have to offer a surgical method, ma'am. Vaginoplasty we need to do. In that, we have various methods, like we have Vicchetti method, Davidoff's method, and McIndoe's method. Ma'am, McIndoe's is the most conventional method which can be done.
Most commonly, what do you do in McIndoe's method?
Ma'am, in McIndoe's, we have to create the space between the bladder and the rectum. We have to create the space. Bladder is anteriorly and rectum is posteriorly, and in that space, we have to insert the dilator, which is covered with the partial thin graft, which should be at least 20 centimeter long and 8 centimeter in width, and it should be 0.018 inches in thickness, which can be taken from thigh or the buttocks of the patient, and we have to cover the mold with that graft, and we have to insert that graft into that space in the space which we created.
Any other thing you can use rather than using the skin thigh, the skin of the thigh?
Ma'am,
we can use bubble mucosa also, ma'am.
More commonly, the skin
What have you seen? What have
Amniotic,
you
ma'am.
seen?
Amnion can also be used, ma'am.
Which is very
What
common.
have you seen in your hospital? What is most commonly done for these patients? What have you seen?
Ma'am, skin graft only.
Ma'am, skin graft only we have seen, ma'am.
Seen the peritoneal grafting that we take laparoscopically and we pull it down and cover the vagina with that. That is the most commonly and the easiest way to do, right?
Yes, ma'am. Davidoff's, yes, ma'am.
And then after you have done the surgical part, what do you do then?
And we have to counsel the patient. If she's having regular sexual activities, then she does not need to use any dilators
Okay,
again.
initially, to maintain the patency, would you want to do something?
Yes, ma'am. Yes,
Immediately,
ma'am.
you can't tell them, no? What?
Yes, ma'am. Ma'am, she has to maintain the patency of the vagina by using the dilators.
Or you will change the mold. Initially, you can even change the mold, call her and explain it to her, explain her relatives. You know, in this case, maybe her mother, how she should change the mold, how she should use sterile conditions and change the mold. The
Okay,
mold more commonly is made using a syringe. We use a
Yes,
20
ma'am.
cc syringe and then put a padding over it. Then over that we put a condom and then
Condom. Yes, ma'am.
Yes, ma'am.
tell the patient to keep it so that the canal is kept patent. All right.
Yes, ma'am.
Here also one very important aspect which you must say in exams is counseling.
Yes,
Counseling
ma'am.
is very, very important because it's a big, huge psychological impact on the child as well as the family.
Yes, parents, ma'am.
Yes,
Be
ma'am.
very sensitive when you're dealing with such patients. Okay.
Yes,
And this, anything else you want to say? This has to be a thorough, a skeletal survey is very, very important in these patients.
Yes, ma'am.
Yes, ma'am.
You are talking of MRKH, right?
Yes, ma'am.
Yes, ma'am.
What is the classification of Mullerian anomalies? Can you tell us the latest classification?
Ma'am, according to the ASRM classification, it can be divided as Mullerian oogenesis, cervical oogenesis. Then we have bicornuate uterus, unicornuate uterus, diadelphous uterus, transverse vaginal septum, longitudinal vaginal septum, ma'am, and others non-specific ones. And according to the Connuta classification, which was in 2021, ma'am, it divides into uterus, cervix, and vagina. It is divided into U0 to U6 in the uterus, and C0 to C5 in cervix, and V0 to V5 in vagina, ma'am.
Why was this new classification coined? Anything? Because this was related to the management. All right. So
Okay.
the management could be more directed. That is why this new system of classification came into being. All right.
Suppose you have a complete transverse vaginal septum,
Yes,
how
ma'am.
this patient, what will be the clinical findings more than the amenorrhea? Other
There'll
than
be of collection, ma'am.
There'll be collection of,
of
ma'am,
the
there'll be
blood.
hematometra or
Hematocolpos.
she can have on per abdominal examination. We
can feel the bulky uterus.
Bulky on per rectal examination also.
How,
And
what
on
the patient complain of first? Then you will
Cyclical abdominal pain, ma'am.
and
What is
primary
the term
amenorrhea.
used for it?
cyclical abdominal pain.
Cryptomenorrhea.
Yes.
Cyclical abdominal pain.
Yeah.
Cyclical, yes, ma'am.
Important. Every month she has the pain.
Yes,
and then
Yes, ma'am. She can menstruate.
Yeah,
Yes.
go ahead.
What are the other common causes of primary amenorrhea?
Ma'am,
The commonest cause of
Ma'am,
primary
imperforate hymen, ma'am.
Yes.
imperforate hymen. Okay. What else?
Ma'am, Turner syndrome, ma'am, gonadal dysgenesis syndrome. It is divided according to the compartments, ma'am. So, what? Yes, ma'am.
Yes. Go ahead.
Yes, ma'am. It is divided according to the compartments, and according to the WHO classification, it is also divided as hypergonadotropic hypogonadism, normogonadotropic normogonadism, and hypogonadotropic hypogonadism causes. I'll start with the compartment. Start with the compartment wise. So, first compartment is outflow tract. It contains uterus and outflow tract, vagina and cervix. So it can be cervical agenesis, vaginal agenesis, imperforate hymen, transverse vaginal septum, and absent uterus, which can be in Mullerian agenesis. Then in the second compartment contains the ovaries. In ovaries, it can be Turner syndrome, which is 45X, and then
Can be 46X6 pure dysgenesis, Turner's mosaic, or Savage syndrome, ma'am, which is resistant ovarian syndrome.
gonadotropin resistant ovary syndrome, and then in compartment 3 it is pituitary or hypothalamus. So it can be hypothalamic causes, which includes any hypothalamic tumors, or it can be
Infarction or any infiltration of the
it can be constitutional delay also in case of hypothalamic, and then in genetic is Kalman syndrome, and then the tumors and infections, or infections such as sarcoidosis and other disease, chronic illness, and eating disorder, stress and exercise induced.
Suppose it is Turner's.
Yes,
What is
ma'am.
the next step?
Ma'am, on the general physical examination, we can characterize the features of the Turners, and for confirmation, we can do a karyotyping where if the most common presentation will be
Turner features.
Sorry, ma'am.
Ma'am, it will be, ma'am, it will be short web neck, low set hairline, low set ears, cubitus valgus, widely
And
spaced
nipples.
shield shaped, widely spaced nipples, shield shaped chest,
And our stature will be short, ma'am.
short fourth metacarpal, short stature. And ma'am, these are more
High arch
likely to
palate.
have cardiac abnormalities such as coarctation of aorta and bicuspid aortic valve. So we have to do echo also for these patients.
And
Every
also-
3 to 4 yearly, we have to do echo. And in these patients, in sometimes there can be autoimmune thyroiditis, Hashimoto's also associated.
horseshoe
So we
kidney.
have to do thyroid profile also every year. And they can also have horseshoe kidney.
Okay. And how will the ovaries be in such patients?
Ma'am,
And
streak
streak
ovaries.
ovaries will be there.
So what will you like to counsel these patients? Yeah.
Sorry, ma'am.
You like to counsel these patients? What further prognosticate them? How? What happens with their ovaries?
Ma'am, she can.
Functional throughout their life? Will the ovaries be?
No,
No,
ma'am. No, ma'am.
So what is it? What you have to explain it to them? What?
Ma'am, we have to counsel the patients that her ovaries are not as functional as in a normal female. So she might need hormonal replacement. We have to
Plus-
give her estrogen plus progesterone. And
I mean, then she cannot have her own eggs to produce. So she should take for a donor egg.
So they no.
So that is a very good point that you have
Can undergo
mentioned.
fertility preservation at a younger age.
So
You
they
should be aware of it. Okay,
So
so as
they-
a doctor, it's your duty to tell them that yes, their eggs will get exhausted. They are not completely quiescent. But
Yes,
they
Yes,
can
ma'am.
be stimulated in the initial phases. All right.
So
Yes, ma'am.
normally, if her AMH is say, for example, 2.5, it will take a little longer for her to deplete all her eggs.
Yes,
However,
ma'am.
if it's a Turner's with an AMH of 2.5, very quickly the eggs will get depleted. So that has to be explained like
Okay,
Dr. Pali said. And then you have to also touch upon that topic of oocyte preservation or freezing for them.
Yes, ma'am.
So how will you manage this patient further? Let's get to this patient.
Ma'am, we will give her hormones, estrogen, progesterone for the development of secondary sexual characteristics, and we will
You
also
investigated and you found what was the uterine size. The uterus was there was a small uterus. What was it?
Our
Hypo-
uterus was absent, ma'am.
Ma'am, in this case, uterus was absent in our case.
Okay, so what is the role of giving them hormones, estrogen and progesterone? Already
Ma'am,
the sexual characteristics are very well developed.
Ma'am, I thought you were asking about Turners.
Sorry?
No, you thought you were asking about Turner's. No, this patient, your
No,
patient.
this patient, your
Yes,
patient.
ma'am.
I mean, our patient, since she is a 16-year-old child, old girl, and she's already developed her secondary sexual characteristics, we'll counsel her that before, if whether she's ready for a sexual maturity or whenever she gets married, she can have the vaginoplasty done.
Or you would
And
want to give
counsel
her-
that. Sorry, ma'am.
You'll want her to develop a vaginal canal before she gets married, right?
Yes,
Not
ma'am.
just
Yes,
at the
ma'am.
time she gets married.
Yes, ma'am.
Yes,
Before
ma'am.
marriage.
At least a dilator. I mean, you start with less invasive first and
Yes,
then go
ma'am.
towards the surgery.
Yes, ma'am.
Right?
Yes,
And
ma'am.
some of these women do have good length vagina. Mind it, it's not that everybody has a dimple like your patient.
Yes, ma'am.
Anything else you would want to tell them? Would you want to give them anything else like an add-back therapy? You don't want to give them estrogens because
No,
secondary
ma'am, they
sexual
already.
characteristics are good.
So,
But you
Yes.
want to put them on vitamin D, on calcium.
Yes, ma'am.
Yes, ma'am.
Because they are more likely to develop any likely to have any skeletal anomalies.
All right, and you have to counsel them that for them having their own children would be a issue. But they have ovaries, so she can undergo
Surrogacy, ma'am.
Yeah.
Surrogacy.
the thing what in these patients, you can either do a pelvic MRI or you can do a transrectal scan or a transperineal scan to see the exact length of the vagina. So
Yes,
that's
ma'am.
again important to know.
That's it. Anything else, madam? Anything else you'd like to ask, ma'am?
No, you ask.
I think that's about
I
it.
think we have covered. They
Yeah.
have really done very well. Yes.
Yeah, they've covered almost all. So,
Mhm.
and please remember, do not miss on counseling because if
Yes,
you
ma'am.
talk about it in your exams. You have to complete that. It's incomplete without that aspect. Because you tell a 16-year-old girl suddenly that no uterus, no babies, no person, no normal life, it becomes a huge issue with them, right? So be
Yes, ma'am.
compassionate. I think that's about it. If the skeletal survey, etc., and if the ultrasound of KUB is normal, those things
Yes, ma'am.
also need to be kept in mind, which you've already said. Maybe a single good ultrasound, or usually what we do is an MRI of the pelvis in these cases to finally determine everything, especially considering the vaginal length will not be determined on other investigations.
Yes,
right?
ma'am.
So I think that's about it. We can conclude.
Mala ma'am, good evening. Namaskar.
Good evening, ma'am. Are you there?
Mala ma'am, you are muted.
Yes.
Good evening. Thank you for all of you to come
Thank you.
and guide our students so well. And Rupali has been with us for quite a few times and for quite a few years with us. So it's so
Thank you,
happy.
ma'am.
We
It's
are
an
so
honor.
happy to
It's
have
an
you
honor
all
to
with
be
us
part.
this
So
evening.
when Mala ma'am asked me, I said, see, I am not a medical college, but I can just talk about the practical point. Just no
That
problem.
is the most important thing.
Go ahead.
That is the most important thing, because you see in the exams also they all only ask the practical points. How will you investigate baseline? How will you diagnose? What investigation, basic investigations, and how would you manage?
Very
And
true.
that message we wanted to give to all our students, that it's easy to pass the exam. Whatever you're doing on your day-to-day basis, same thing you have to do in the exam. And the examiners are there to pass you. They just want to know whether you have worked for 3 years or not, sincerely in your wards. That's all. It is not difficult to pass a postgraduate exam. If you are sincere in your day-to-day work, you have been working hard in the wards, in the labor room, in the OT, in the OPD, you can easily sail through your postgraduate exam. So it's my pleasure. And I think all my students have really gained a lot in this 3 days Gurukul exam, Gurukul program. And it's my duty and a pleasure and privilege to propose the vote of thanks to all of you. For last 3 days, we have had structured program for all our students. And I thank our chief guest of the day, Dr. Alka Kriplani, Madam, Dr. Guest of Honor, Dr. Komal Chavan, Madam, and all our teachers who have joined today. That means starting from Dr. Shobha Gudi, Dr. Hiralal Konar, Dr. Arun Arora, Dr. Kanika, Dr. Ruma, Dr. Sumitra Bacchani, Dr. Indu Chawla, Dr. Vinu Agarwal, Dr. Rupali, I thank each and every one of you for participating and enriching our students with their knowledge and helping them to gain confidence so that they can easily pass our exams, and they have really guided us so well. And I thank all our students, and especially Spruti as well as Payal, who had presented the case. And I thank all our postgraduate students who have worked so hard for last 3 days, and they have really enriched themselves with all the knowledge they could get and all the guidance that they could get. And I thank my Master of Ceremonies of the day, Dr. Ashwita Java, Dr. Anusha, and Dr. Khadija. And I thank our back team, Mr. Vinod, Mr. Prakash, as well as ClearNet, Roopsa today. Otherwise, Ritu Shiva has been working every day. And I thank each and every one, all the delegates who had participated, all the students who have participated, all my teachers, all HODs, Dr. Geeta, Dr. Mamta, Dr. Sharmistha, they had nicely programmed the OSCE program as well. So I think it has been a good comprehensive practice for all our exam going PGs. And I'm sure with great confidence, they will give their final exams and they will come out with flying colors. Thanks everyone. Good night and goodbye.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, Mala ma'am. Thank you, Dr. Rupali ma'am. Thank you, Dr. Prakash Tayal sir here, and all the best to the students who have participated for their exams.
And our students have really worked hard to prepare, and I'm sure they will do well in the exams with all the guidance from all the teachers all over India.
Absolutely. And this, ma'am, this thing is an amazing idea. I think letting them present cases like this and discussing it out, because, you know, other people only go as examiners and other colleges from other institutions. So I think it's an amazing feat. Very, very.
And this is done between the theory and the practical, because once they've given the theory exam, they know the subject thoroughly. They have read the subject thoroughly. So now we have to just brush them up, give them confidence, how to answer, how to prepare, and how to appear for the exams.
Absolutely. All right. Thank you, ma'am.
Thank you so much, ma'am, for today's session. With all your permission, can we end this session here, ma'am?
Yes, yes. Thank you so much.
Thank you so much, ma'am. And thank you everyone for joining this session. It was really a great session. Thank you. Thank you.
Thank you, ma'am.
And then Dr. Sumitra ma'am, she's there. I listened to
Dr.
your lecture on CTG, was very, very good. Excellent
Yes,
talk.
yes.
Uh-huh.
I have been requesting her to take CTG off subsequently in all our Gurukul classes. You see, last year also she took the class. We try to keep the same teachers. You know, HSG has been taken by Dr. Ruma, and endoscopic instruments. We try to keep the same teachers.
Yeah,
So
right.
because they are all experienced and they are all versatile teachers,
Right.
and they know how to guide the PG students, and
Correct.
the PGs really benefit.
Correct, correct.
Okay, bye-bye.
Thank you. Thank you, Mala ma'am. Thank you for having me here.
Yeah, and I must say all the best to you as well.
Thank you. Yes, I'm going for the Foxy Vice President election. So thank you for that. Thank you for the best wishes. Yes.